Good morning, friends. I think we will catch up quite soon. We cannot wait still more. We have one session left over yesterday, also has to be carried out today. And now I invite Professor Yathiraj to talk on the subject which we are really facing every time, the hassles and how to manage it. And Dr. Yathiraj is going to give us a lecture on how do I manage renal failure in dog. So we need your expertise, sir. Thank you, sir.
Thank you. Yeah. Yeah, by the time it gets connected, good morning to everybody. I think I should say welcome to all of you for the lecture. I think many are still in the breakfast area. I'm sure nobody will come out when you can give such a breakfast, wonderful dinner. Who wants this? I thought the breakfast is going to be a teaser, but it's not the teaser. I think it's a sumptuous way, and I think probably these are all necessary, good. No, nothing about that. Compliments to the organizers for such kind of wonderful things being organized and arranged. All go on well, and we have had a good day yesterday. I'm sure the second day is going to be the same way and that. I think it's taking a minute, I think, to connect it onto that. Anyway, let him start on that so that I'll not waste too much of a time, because constraint of the time, and 9:40 now, 10:40, 1 hour I'll conclude this lecture, okay? If there are any things left out, probably if unable to cover, we will cover it up during our discussions times, so that I'll give room for the others to move on. By the time it gets started, let me start. All of you know very well that the topic that we're going to talk today is on how do I manage kidney failure. Per se, as practice, when we talk of the highest number of cases that we encounter in day-to-day practice, number one is dermatology, followed by gastroenterology, third is nephrology areas, fourth, rest of the things go on. And in these few points that we need to remember here is, I'll go back from my lecture of yesterday and come to you. Okay, welcome you all on this. You need to make things work for me, I think, okay. This is the topic that I'm going to talk to you today. How do I manage renal failure in dogs? Now, when we talk of this, always we need to talk about the functions of the kidney. What is a kidney disease? What are the functions? All that we have learned, there is nothing new in that, just to brush up. Number one, remove toxins from the blood and excrete them from the body in urine, regulate blood pressure and blood acidity levels, prevent water loss from the body, maintain overall healthy metabolic balance. Please concentrate on these 4 points. Not many people said, my talk has to be like something practice oriented. Forget me as professor, take away my name as professor. Talk to me, or I'll talk to you as a practitioner. These are the important things for us. Our management revolves around this. The 4 functions, what I said, when the kidney gets affected, this is going to be affected. So that's what we are going to intervene, and they are the steps that we need to do. Any condition which stops this kidney working normally is referred to as kidney or renal disease, and can vary greatly in severity. This indicates the damage is in progress, but there is still functional tissue left. This is most important. Unless and until you know that there is a functional tissue left, you cannot manage kidney failure at all. In renal failure, the kidneys have stopped functioning altogether and is more serious. So, renal disease versus renal failure, when we talk of, lot many times as practitioners we would have addressed the renal disease, not yet a renal failure. So, renal failure, if you are talking about it, will be totally different unto that. Simple about the anatomy, lots being talked about. For us, the only reason I put this photograph is that Look at where the kidneys are. We have seen the x-rays being shown by Dr. Jay Prakash sir yesterday and all other things. When we palpate, when we examine, physical examination of them, we need to know for that. Number one, ultrasonography is the second reason for that, and sometimes for the cytosynthesis or the cystosynthesis that you do for urine collection. That is the idea behind that. And now one point that you need to look at the normal kidney when we say this, look at the blood vessel appears so prominent like a major blood vessel. Yes, it is, but unfortunately, when we talk of the blood supply to the different organs, from the point of the anatomical structure or as planknology, when we read, the least amount of the blood is supplied to the kidney. The least amount is to the kidney. This is most important, because when we talk of any damage to the kidney and further damage is going to occur, and you can think about the perfusion that is going to occur. If the blood supply is not good to the kidney, then the perfusion doesn't occur well at all. This is a cross section of the kidney when we talk about the renal cortex, the capsule, the nephrons individually of them, and cross sections what you can see the blood vessels as well. And these are important from the point of the diagnosis when we do ultrasonography, corticomedullary junctions, what happens, things like that. Certain of the things you have come to know yesterday. Now come back to the definition. Kidney disease is defined as the presence of a functional or a structural abnormality in one or both the kidneys. Why I am putting this point is, many people will ask you a question when you say kidney failure, whether one kidney has failed or both the kidneys have failed. If one kidney has failed, the other kidney does the function. So the question of your creatinine level going up doesn't arise at all. Then why do we talk about this? This can happen in situations of probably accidents, certain times of the immune mediated reactions if they are very specific, or a specific nephrolith in only one kidney and the other kidney is functioning, that can happen. Otherwise, for a practitioner, when you have a blood report with the symptoms, you take it for granted that both the kidneys are not functioning. That's what you should go by. Acute renal failure is defined as an abrupt decrease in the renal function leading to retention of nitrogenous waste. Acute kidney injury, these are used as ARF, AKI, AKD, or many times have been used synonymously. There are subtle differences in that. Acute kidney injury represents a continuum of renal injury from mild, clinically inapparent nephron loss to severe acute renal failure. When we talk of a nephron loss, think about each kidney, say few millions of nephron, and the nephron lost is lost forever. There is no question of regeneration. This is another crucial point as practitioners we should remember. Whatever the loss has occurred, I have lost that. It's something like the military. A soldier lost is lost. There can be a replacement for him, but there cannot be a person divided into two. It cannot happen like that. CKD is defined as a kidney damage that has existed for at least 3 months with or without decreased glomerular filtration rate. Underline this point. Again, when I say how do I manage, you got a case, we got the report today, we diagnosed it today, but when could I have been there? People say, is it last week I went out of the country, my maid did not look after the dog well, they fed something, hence the disease. No, it cannot be like that. That can happen only in the acute renal failure, like leptospirosis, or trauma, or zinc phosphide poisonings, arsenic trioxide poisonings, lead poisonings. That is acute toxicities. But when you talk of a chronic kidney disease, the history has been like not eating for few weeks or days or whatever it is, going down in condition, emesis, maybe sometimes blood in the feces, and you go to the report and you get a creatinine value, whatever that you get. There are occasions when you get values right from higher as 2, above 2, 13, 14, 15, 18. I have had a case, even I have seen 23 as a value, 30 as a value in one medical doctor many times. They are totally different. Let's come to that later. A reduction in the GFR by more than 50% from the normal persisting for at least 3 months. This is the condition. That means you have had a case already, but we are diagnosing it now. That is the point to remember. Let's come to the common causes of the kidney disease in dogs. I thought I'll talk to you only about the treatment, but we need to know the cause, because the treatment depends on the cause of the injury that can be caused. This is what the general terms are. Damage to the kidney filters, glomerular disease like infectious disease or like Lyme disease and cancer. Infectious disease of the kidney, only 2 of them. One is the pyelonephritis, very specifically, and the other is the leptospira. Kidney stones, nephrolithiasis, kidney blockage, ureteral obstruction, and hydronephrosis. Damage to the kidney tubules, which is the interstitial diseases, toxins, many of them rather, neoplasms, amyloidosis, hereditary conditions. Inherited kidney diseases, when you talk of hereditary, many people, we were not concentrating earlier, I keep telling this in every lecture of mine. Probably ultrasonography, the moment it came into existence, people started reviewing the abdomen. Like what we saw Dr. Madhumati putting us yesterday, that the moment you say abdominal ultrasonography being done, obviously kidney gets exposed, or you do a ultrasonography for the kidney as well. So based on that, many cases of congenital disorders, most familial renal diseases are progressive and ultimately fatal. Onset of the renal failure occurs at 3 months to 3 years of age in renal dysplasia and some glomerulopathies. Why I am putting this point is, sometimes people saying that, imagine onset can be at 3 months, onset can be at 3 years as well. So the normal notion in us is any congenital disease has to be shown to us in the beginning. No, it need not be. This is what we need to remember. The initiation can be only after 3 years of the age. Sometimes onset of the renal failure is often at 3 to 7 years of age even, though it's a congenital defect. People might say he lived 6 years happily and now you say it's congenital. Need to remember this point. Polycystic kidney, some glomerulopathies, amyloidosis and glomerulonephritis, all these could be there in the animal but gets manifested later. Inherited kidney disease, what are the common signs that you come across in this? Reduced appetite or anorexia, stunted growth, weight loss, polyuria, polydipsia, vomiting, poor hair coat, halitosis, diarrhea, all common symptoms are there. But the thing is, these animals don't improve. I can tell you on my day-to-day practice for the past 1 decade, when I concentrate more on nephrology, I've seen dogs, Cocker Spaniels, certain of the terriers, Dobermans, Labradors, right at the age of 6 months, diagnosing them as polycystic kidney, calling them as renal hypoplasia, renal dysplasia. Why we came across this is because we started looking into that. All these years we were not looking to them, but now we started looking at them. And these dogs, you might ask me a question. I still have one Cocker Spaniel which went around the whole of Karnataka and then came to me in the end. Then all the time the creatinine value was around 5, between 5 and 6. Everybody said it has gone to the stage of maintenance phase and it can survive. Then when we did all of our scans and things like that, we could identify it as a primarily congenital disorder, and still the dog is alive. It's 12 years. Only what is necessary is not the rigorous management that we talk of. It needs a different kind of management, which I'll come to later. Specific familial nephropathies, renal dysplasias are common in Apso, Shih Tzu, Wheaten Terrier, Chow Chow. Primary glomerulopathies in English Cocker Spaniel, Bull Terrier, Dalmatian, Doberman, Pinschers, Bull Mastiff, Newfoundland, Rottweiler, Welsh Corgi, Beagle. All these I don't think you need to write all of them. I'll pass on the notes to everybody, please. You can take it later. Polycystic kidney, Bull Terriers, West Highland Terriers. Look at them, these conditions. These are congenital defects which you should really worry about. Amyloidosis in sharp eye, English Foxhound and Beagle. Immune-mediated glomerulopathies, which is the soft-coated Wheaten Terrier and the Burmese Mountain Dogs. Miscellaneous, what you call as Fanconi syndrome. People might say, do we encounter Fanconi syndrome? We don't really see even Basenji breeds these days. Basenjis are not very common breeds today. It's called as Basenji Fanconi syndrome for the reason that it's very common in the Basenji breeds. But not necessarily it should be only in that, it can be in any breed. What is this Fanconi syndrome is? It is a congenital disorder. What is the question mark? Identification is by only creatinine values. They have a high creatinine value and they don't show any other manifestations. Ups and downs, it doesn't eat for few days, 2-3 days, the animal becomes dull, and then you again put them onto intravenous fluid therapy and send them home, they are fine. Again, few months later, they come back again. So this is what typically that Fanconi syndrome is. And it doesn't need an aggressive medication at all. Management is important. Now let's come back specifically to ARF and AKD, classically divided into 3 categories: pre-renal, intrinsic and post-renal. This is all about the acute renal failures. Pre-renal causes. Kidney is not involved at all. That is the pre-renal. Intrinsic is the renal, post-renal again down. Renal is specifically for AKD and CKD. Pre-renal and post-renal do not relate to the AKD and CKDs and that. So when we talk of the pre-renal causes, these are all majority of the other infectious. Pre-renal azotemia is caused by number of causes. You can read them. Anything which decreases the renal blood flow. That's why I showed you the blood vessel. Anything which can decrease the renal blood flow. What can decrease? You have the reasons there. Dehydration, hypovolemia, hypotension. Many times people say the animal doesn't eat for few days. Can there be hypovolemia? Yes. Can there be a kidney perfusion being lowered? Yes. All these what finally would lead to is think of surgery, shock. Many times people would say, I did a surgery. Blood reports were not done prior to the surgery, and 2 days later the animal doesn't recover. I go for a blood test and it shows creatinine value being higher. Was it there earlier? If you had not done a blood test, people would say, yes, it was there earlier. You did a surgery without a blood test. But on the contrary, it could be post-surgical because the recovery is slow and the perfusion for the kidney is very low. Creatinine value goes up at that point of time. They all recover, not an issue at all. Hemorrhages, hypotensive things. Septic cases. There are situations, gastrointestinal disorder with severe, probably food poisonings. Invariably, they are the toxins. And such kind of situations can end up in renal failures. Hypoalbuminemia, heat stroke, very common. Not many people would say that heat stroke can it cause. Yes, very well. And this is where we come across the heat stroke is situations where we send the patients after the surgery, tell them go home, relax. They put the dog or a cat in the car. They go out for breakfast after the surgery, locking up inside. And you come back and then come to us saying that after the surgery, this dog collapsed. But they don't tell us that they had put the animal in the car, locked, doors closed, and come back to us. These are very bad for us. And most important is non-steroidal anti-inflammatory drugs of late is increasing because giant breeds are the ones which we come for CKDs. And many people use NSAIDs on their own because they're all freely available. They can keep on encashing the prescriptions. I've seen prescriptions coming to me in the day-to-day practice wherein they have used NSAIDs for months together, maybe with break a few days and that. And even in that, many a times even the compounds which are banned compounds have been used, like Nimoluside has been used, ibuprofen has been used, which we normally don't talk of at all. And these are all highly toxic when you talk in terms of the kidney damage and that. Angiotensin converting enzyme inhibitors, particularly AC inhibitors used in cardiac patients for a longer period without monitoring can lead to renal failure. These are all pre-renal. It is characterized by the increased BUN and creatinine concentrations in conjunction with a concentrated urine specific gravity. The urine specific gravity normally should range anything between 1012 to 1024. Remember 1224 generally. Anything less than 1008 will be low specific gravity, and higher anything beyond 30. So low specific gravity in these situations can be attributed for this, and normally acute renal failures have a high specific gravity, chronic renal failures have a low specific gravity. And in chronic cases, particularly specific gravity gets fixed between 1005 to 1008, what you call them as isostenuria. It gets settled there and doesn't change at all. Intrinsic may result from damage to any section of the kidney, glomeruli, tubules, interstitium and vessels. Most intrinsic renal failure is from the tubular damage, either ischemic or toxic. Underline the statement. I should have put them in the bold letters. It's because of ischemia or because of toxemia. These are the main things on that. Ischemia, there is no blood supply, any of the reason that we talked about it. Toxemia because of any of the way. You might say toxemia, the moment we talk of, is it a toxin produced by the organisms or the toxins of the system? Excess nitrogenous waste material not eliminated becomes a toxic material. Blood urea nitrogen of the higher levels is a toxic material. Nitrogenous substances of all the groups are toxic material. So ischemia and toxemia are two important things for the kidney damage. Infectious causes, bacterial pyelonephritis and leptospirosis. Intrinsic continued, ethylene glycol toxicities, non-steroidal anti-inflammatory drugs, aminoglycosides, and less commonly tetracycline, cisplatin, amphotericin. Of all these tetracycline, I would like to make a mention because many people ask a question that we treat cases of Ehrlichia, babesia with combinations of tetracyclines or doxycyclines. Tetracycline, some people would say any kind of tetracycline, oxycycline, oxytetracycline being given for a few days at the dosage of 20 milligram per kg for Ehrlichia, will it cause a renal failure? This is a divided thought. I have gone through the literature enough. I have interacted with the practitioners. Some practitioners say you give them for 5 days, it ends up in a kidney failure. There are people who would say use it for 20 days, no side effects in that. But to be safer, whenever you have no choice of using oxytocin, if you don't have a choice of using doxy because of the oral way, or doxycycline becomes expensive in the treatment schedule, if you think, then definitely you can use oxytetracycline IV, but monitor the creatinine values. Any reason the creatinine value is going up, stop there, that's enough. You can withdrawal is more than enough. Not that it will cause death in a 2 or 3 injections, or somebody gave injections for 5 days, the dog died of renal failure because of oxytetracycline is a myth, I would say. It's not be acceptable phenomena like that. The best thing is to go for doxycycline, but tetracycline alone, when used orally, also doesn't cause severe toxicity, but it should be used with caution. Postrenal azotemias, urine leakage, bilateral ureteral obstruction or unilateral obstruction, all can cause postrenal. These are the 2 things which normally said don't give the dogs, particularly animals which are suspected of the kidney failures. Grapes and resins are contra for this. These are not berries, remember that, because you use a lot of berries there, but not the resins. So grapes typically no in case of renal failures. Chronic renal failure is the commonly recognized form of the kidney disease, both in case of dogs and cats. The kidney lesions are typically characterized by a permanent reduction in the number of functioning nephron. Regardless of the underlying cause, CKD may be characterized as an irreversible, slowly progressive disease. Irreversible, slowly progressive. You need to remember this. So, whatever that I am doing today, is that drug going to be damaging the kidney further? Is the question you should ask yourself, because you know very well it's progressive. Whereas, no treatment can correct existing irreversible kidney lesions of CKD. Clinical and biochemical consequences of the kidney function can often be managed with supportive therapy. First question anybody would ask is, what is the best treatment for CKD? Please read this para. If you read this para, I don't think anybody will ask me a question saying that what is the best treatment. Whatever you do is the best, keeping in mind what you should not do. If you put a list what you should not do, and whatever the other things that you do is the best treatment, I would say, and you do that persistently, monitoring the value. Most important, do the treatment which you feel good and monitor the kidney functioning. The easiest way is to monitor the creatinine value, and to prevent the secondary anemias, evaluate RBCs and the hemoglobin. These are very important for us because secondary anemias are very common in case of kidney failure. And that is the reason is, you know very well that when the kidney is being damaged, you have a different phenomena, the renin-angiotensin axis system, where it gets reduced, and these are responsible for erythropoiesis. So, erythropoiesis gets affected. Yeah. That is dates, resins. Resins are, apart from the compounds of berries, you have the resin compound which is the date. Yeah. Grapes and dates are dangerous for that. Keep away from the kidney patients. Congenital causes of CKD are similar to AKD, what I talked about. Let me not repeat them again. Amyloidosis, dysplasia, polycystic kidney, glomerulopathy, Fanconi syndrome. Acquired, I am talking about the CKD more now. So, for the acquired causes are infectious, metabolic causes like hypokalemia and hypercalcemia, obstructive nephropathy, neoplasms, proteinuric kidney disease like glomerulopathies, sequelae of ARF, chronic nephrotoxin exposure, immune-mediated diseases, renal ischemia, and at the end, I think God is very kind enough for all the veterinary practitioners. That's why we keep talking about it. Sometime back I had some of the visitors in Bangalore, they formed an association as Overseas Women's Association. They were a big number. They wanted me to talk to that group once and said, every disease that is there. You talk of anything, you have the term like idiopathy. Why that was given to you, they asked me. They said, God gave the term to us, not the science. and you don't find any cause, you can say idiopathy, isn't it? So then people said, do you get idiopathic husbands and wife? I said, no, we don't get that. We don't get that, isn't it? It's all arranged in that way. So people sometimes make fun of us, isn't it? So thinking that, whatever we talk of, idiopathic immune mediated anemia. You don't find a specific cause, you can always cause idiopathic. And sometimes we need to use them because certain times intelligence alone doesn't do well in the practice management, which is a different chapter by itself. There are occasions when you say you don't know, then the simple question they would say is, why did you treat all these years, all these months, my dog without knowing any etiology? The best thing that we say is we don't know, and that is the reason we call idiopathic kidney failure. Idiopathic recurrent pyoderma, best way, never goes. We can say cause is not known to us. So this is one important for us, and probably we need that. Again, I repeat, because I was talking yesterday again about this, in dogs, acute loss of 2/3 or more functional nephrons is associated with loss of adequate urine concentration ability, whereas acute loss of 3/4 or more of functional nephron results in azotemia. The meaning of azotemia here is the nitrogenous compounds being higher in blood. That is the meaning of azotemia. It doesn't say it is kidney damage or liver damage. Okay? Azotemia is a laboratory finding with several fundamentally different causes. Should not be used as a synonym for kidney disease or uremia is what you need to remember. Many times people say the values are elevated, I put them in a simple treatment, and somebody will be seriously talking that I had a bad case of kidney failure, did not respond, and right at point of time my colleague will come and say, I had a similar case and I just gave a drip for 1 day and one wonderful drug what he has in his packet, and he will say, I gave that B complex, it did wonders, and he will shatter me into pieces. And this owner will think I should have gone to him rather than coming here, and I spent a lot of money, wasted my money. These are all, and in front of the clients, are a frustrating statement made by my colleague or a partner. You should be very careful on this, because as such we have so many butterfly clients. So you produce more butterfly clients. Butterfly clients are dangerous, very, very dangerous butterfly clients. They are classified as butterfly clients. Like the way we talk of loyal clients, butterfly clients. Butterfly clients are very, very difficult. So have minimum number of butterfly clients in your practice. You should work towards that. If you're having a loyal client is not important. Work towards minimum butterfly clients. Yes. Chronic in the context of CKD means an irreversible and usually progressive loss of kidney function and structure. I am repeating this because some of them are latecomers or some of them came late to say that. In contrast, acute kidney injury is potentially reversible, remember this, either by resolution of at least part of the kidney injury or development of adaptive compensatory enhancements in kidney function, or a combination of these events. So that is for the acute, whereas for the chronic kidney disease, it's very difficult. Glomerular filtration rate is accepted as the best overall measure of the kidney function in health and disease. I am giving you this point from the point of day-to-day practice what you need to do. What you need to probably have is one TS meter, which can measure total proteins as well as the specific gravity of the urine. One drop of urine, you might say, is it easy to collect? Yes, not a big deal at all. Don't do cytosynthesis in all the cases. Pass a catheter and collect the urine. Again, aseptic precautions. And you check for the specific gravity. Urine analysis was taught to us during my days, and we used to practice. And there came the era of 90s, 2000 and all that. People said, urine analysis is no use. Bun and creatinine are the best. We have forgotten basics about the urine analysis. Specific gravity is such a wonderful indicator. Microalbuminuria in the urine is a good indicator. The moment you get a protein positive, gives you an indication, now think twice. Kidney is not all right. We have lost all that. Any kind of calculi found, cysts found, or the epithelial cells found in the urine by way of sedimentation, you check them, that's a good indicator to say desquamation is occurring. Because we are given up all this, so get back to them. You just need to spend 12,000 or 15,000 rupees and have it and put one drop of urine and you get the specific gravity. Anyway, these days you get the strips as well, which are much cheaper. You can do the specific gravity as well as this by the strip as well. Okay, the normal is the higher limit what you take here is the urine specific gravity. In acute cases it can be more than 1040, whereas in case of chronic it can be less than 1010. And what is considered for here is, let me leave all this, not to worry too much about the pathogenesis for you. What is more important for us is the methods of diagnosis. Quickly I will go through this, not in detail. These are all history. History is very important that we need to collect a good history. Physical examination, a thorough examination would be necessary in terms of all the parameters that you talk of, and then go in for a laboratory evaluation and a renal function test, radiography, renal biopsy, exploratory laparotomy, quantitation of urinary enzymes, endoscopy, scintigraphy, CT scan, MRI, cystogram, urodynamic studies, plenty of them are available. Let me stop there. I will not go into detail of any of that. Let me come back onto the history. This is more important for us. Clinical signs, polyuria, polydipsia are the common earliest signs. Then gastrointestinal tract. Look at the signs: anorexia, nausea, vomiting, oral ulcerations, and stomatitis, necrosis of the margins of the tongue, halitosis, uremic breath, diarrhea, melena, hematochezia. When we talk of the uremic breath, many people in the class people used to say, you put this dog in a small room like 10 by 10 examination room, close all the doors and ask every student to come, they would say it looks like a lavatory. That's the typical uremic breath, and you get these in really renal patients. But unfortunately, we do our examination in a big hall of 30, 20 rooms, and you don't get this smell. So if you really do a closed room examination, you will find them. Weight loss, muscle wasting, hypothermia, lethargy, weakness, muscle tremors, uremic pericarditis, pneumonitis, hypertension, altered behavior, renal osteodystrophy, hemorrhagic diathesis. These are again symptoms of GI. CKD is the most common cause of elevated blood pressure. Organ system most commonly affected by blood pressure are eyes, kidneys, nervous system, cardiovascular system. So what is not involved in the kidney disease? Every system can get involved. That's why in the physical examination, do a thorough examination starting from the eye to all the systems, and then even the skin as well. Now coming back to the physical examination, when you talk of, I'm sure anybody would say, look at the gingivitis and the halitosis and the oral ulcers. This is the typical bleeding occurring in that. This is stomatitis to me from the point of teaching. But what is that stomatitis due to? Look at that kind of lesion. The lesion is peripherally, it's bleeding on its own. Reason? When the blood urea nitrogen level goes high and high, the kidney is not able to eliminate it. Similarly, liver is also a place where the urea cycle would occur. Nothing is handling. Then obviously, what are the other tissues which take? Epithelial tissue of the GI tract will take the function of doing it. So the epithelial tissue in the oral cavity, it ends up in, it cannot eliminate. These nitrogenous compounds accumulate there and they burst. So that ends up in an ulcer. Same thing happens in the intestine, in the Peyer's patches. That's the reason why you get blood in the motion. So the epithelial tissue cannot do the function of the elimination of nitrogenous compounds. Hence you find all this. You can look at these kind of ulcers even on the palate. And look at this blood tinged discharge. This makes a difference. Probably this is different from what I showed earlier. This is where you can call of stomatitis, could be because of a niacinamide or a nicotinamide deficiency, which is very common in case of Spitz. You can see that stingy saliva, copious production of saliva, in between you find a blood drop, and this is typical in a stomatitis as compared to any other way. This also makes a differentiation for us, even for rabies as well. This is the rubber jaw, what you can see them. In chronic cases, you find a distorted shape of the bones, more particularly of the face. And this is the X-ray of such patients of them. And coming back to, if you are talking about how does the kidney failure would occur, starting from a normal kidney, sequentially if you look at, when you finally say, imagine the changes that are occurring, we talked about can be a structural change. The structural change is from the size to this, what is ending is it is getting shrunken. You talk of a shrunken kidney. So the shrunken kidney is that, and the changes what you see in your ultrasonography from this structure to that structure is entirely different, and you can say based on this ending up towards the death and that. And these are all the gross changes what would occur, which can be visualized in the ultrasonography, which I will not deal in detail here. Now coming to the laboratory evaluation, I was talking to you yesterday saying that there are many kinds of biochemistry analyzers available. This is one of the simplest biochemistry analyzer, is an Indian make. Like it can also do 124 parameters, like what the advanced machine that we have. In the college where I was working, we had this machine, one, which was costing just 1.2 lakhs, and we had another machine which had costed us 48 lakhs, a batch analyzer. And that was also doing 124 parameters. We were using it more for research work with other equipment, whereas this was enough for us. So azotemia, hyperphosphatemia, metabolic acidosis, hypocalcemia, hypo or hyperkalemia, anemia. These are the findings in the CKD when we talk of. So this is what needs to get addressed on this. When we say this, you also talk in terms of urine analysis. When you say the minimally concentrated urine specific gravity is less than 1035, proteinuria, glucosuria, CAS you find in the urine sample, you need to take 15 ml of the urine sample, centrifuge under 3000 rpm or 1000 rpm, between that, examine the sediment and you find a variety of all these material, which is a good indicator. You can see all these in your laboratory with a simple microscope. What you need here is a centrifuge, which probably everyone has for a fecal examination, and a simple microscope. You don't have to do it even under high power or oil immersion. And you could also stain them. If you are not very trying to identify the WBC, RBC, all these, you get stains for this. You can stain them and examine them, and it clearly gives you an idea as to look at the bacteria and cells in the urine. You can very well say this is pyuria. It could be a future even in case of prostate enlargement. Pyuria is a future where you find plenty of leukocytes and the organisms, not necessarily with that. It could be a contamination later. These are the different kinds of CAS which would all be there, and you also have all other probably the crystals that you find them. You can find them in your urine sediments, and these are drugs. When you use sulfur drugs, you find all these indication to say that you are putting them on either trimethoprim or combinations of sulfur methoxazole. If they are on a combination treatment with sulfurs, the urine can be concentrated. This indicates that you should put them onto a rigorous fluid therapy, or oral intake is not good. You should think in terms of parenteral therapy. Now, the laboratory evaluation for all these is hyperphosphatemia. The primary consequence of phosphorus retention and hyperphosphatemia is a progression of CKD and a metastatic calcification. Both the things would happen here. So when you talk of this, hyperphosphatemia is an important finding in cases of renal failures. So when you find this, your aim should be something different. The initiating cause cannot be identified at the time of diagnosis of CKD in majority of the patients. This is the statement not because of frustration by me, it's the statement taken out from many groups who work on the area of the nephrology. This is what you need to underline. That doesn't mean that leave those cases, but you should understand this. Don't ever say, like the case of leptospira, when you have identified as leptospirosis and CKD or AKD, whatever it is, you can say 10 days down the line, this animal is going to be back running around. Whereas in a case of CKD, you cannot say that. There are situations beyond your expectation, they might respond very well, but many a times it can boomerang and they will not recover. Biopsies are indicated when results are likely to substantially influence the prognosis or treatment, or of importance in establishing a role for a hereditary disease. So when you talk about renal biopsy, it's a different subject by itself. There are many surgeons here. I wouldn't like to venture into talk about all that. As a routine practice, in a routine clinic, you should not think in terms of doing all this, because it can be very dangerous. So you need to anesthetize the patient, have the different methods of way of cutting the tissues, get the renal biopsy, send it to away. If you are referring it to an expert, very well recommended. Hematological values, don't worry too much about all these values. What I would concentrate to know is hemoglobin, PCV, RBC. These are the indicators for that. And as a practitioner, irrespective of what disease you are treating, the cutoff points for us is, one is the hemoglobin, other is the PCV. Hemoglobin less than 6 would indicate a transfusion. PCV less than 16 would indicate a transfusion, irrespective of the disease what is being produced. That is the cutoff point. PCV less than 16, hemoglobin less than 6. To that level is the tolerable level which you can think of modifying in a different way. And in terms of the biochemistry, I had been talking yesterday, when we come down to specifically renal diseases, you need to talk in terms of values like creatinine, blood urea nitrogen. Other parameters are bicarbonate, calcium, phosphorus, potassium, sodium, urea. These are very important for us. Don't leave them at all. Don't ask for simple parameters, saying that biochemistry, when you ask for each of the parameter, people say 50 rupees, 100 rupees, whatever it is. Adding phosphorus in the list is not going to trouble you much. It might cost you another 100 rupees, ask for it. Because if you identify the cases of hyperphosphatemia in the early stage, the recovery is much, much better. So that's why you need to worry about that. When it is not responding, then people would ask me a question like, is hypothyroidism associated more with the renal failure? Yes, there are reports that hypothyroidism can cause. When the owner can afford, you can add many parameters. But if the owner cannot afford, but as a clinician what you need, you ask for a minimum. CBC, 3 parameters. In the biochemistry, the reds what I put on, you need to 100% ask for this. And if you are doing only blood urea nitrogen, and people going by and say that it is kidney failure, don't just get alarmed by a value like 40, 45, 50. Normally it is considered as blood urea nitrogen. Anything above 90 is considered as kidney origin. It indicates that there is a kidney damage. Less than 90, that is the cutoff point for blood urea nitrogen. It could be other causes. Now, one word to talk about hyperphosphatemia. I am not going to talk to you on cardiology, but you look at what are the ways that you would get it, like PQRST. Majority of now the clinics have changed to probably multi-practice. When we talk of many doctors was one way, earlier was one doctor like a garage practice, later now got converted into a polyclinic, now specialty, super specialty hospital. Now people started from 2 to 3 vets to 8 to 10 vets, more the vets, more the facility, more specialty in terms of that. And now recently I have been hearing after coming to Chennai, it's not just that, owning more number of units, you call it yourself as a specialty. So when you are doing all that, consider ECG as one of the normal equipment necessary in your clinic. If you do that, and people might say it's going to cost me huge money. No, you get ECG machines even for 45 to 50,000 rupees, good ones. Veterinary models you get even at 50,000 rupees. Why you need this is any kind of a critical patient, the moment it comes, connect to an ECG, and you look at this, what I am trying to talk to you. When we talked about hyperkalemia, in such situations, now look at these ECGs. I'll again go back to the previous one, just to look at the P wave, leave that. Look at this here, this is the P wave, this is the QRS and the T wave, P wave, QRS, T, that should be the normal. And let us not talk about the rhythm, rate, etc., etc. Now look at this ECG, continuously look at the lead 2. Lead 2 is the most common that we use. This is the lead 2. Look at them, continuously here you don't find a P wave at all. Absence of P wave is a good indicator of hyperkalemia. Now, when I want to start the treatment, now I can avoid a solution which has potassium in this. Any other thing is fantastic, use it. You don't have anything, you can talk of dextrose saline. Yeah, but in these situations, alterations, that is a long T wave and QT also, wherein we talk in terms of the potassium of that. This is for the hyperkalemia, both can be used. QT can also be used on that, I will come to that. QT can also be used onto that. I will come to the next one. Okay, look at that. Prolonged QT interval, okay, this is also associated with more with hypocalcemia more than hyperkalemia. Prolonged QT interval, can you make out there? QT interval is that, and this is an indication for hypocalcemia, QT interval. And T wave, again hyperphosphatemia. More use the P wave as a criteria rather than the T wave. T wave significance not normally given too much into that. So use this QT interval and P wave, which you don't even record. When you do that, you can see that. When you are connected to a vital monitor, you can see on the map, on the board, okay? You can do that. This is very important to assess that. Then send the sample there. Then imaging, radiographs may demonstrate normal to enlarged kidneys, nephrolith, ureter. You need all these. Abdominal ultrasound may show normal or enlarged kidneys. All these go on. And the renal sampling, just a word about renal biopsy, you get different kinds of needles called needle core biopsies for kidney tissue to be taken, and then you can take the tissues, and only thing that you are, when you are doing it, is the correct methodology to take is the cortex and the medulla, never go it across like that. So you need to study much about anatomy, anesthetize the patient, keep the animal in a recumbency as to what you want, put them onto ventrodorsal recumbency, and then insert your needles. Otherwise, you can end up in the blood vessels and cause death of the animal. And even later, the bandaging techniques are totally different onto that. These are the scans, etc. I'll leave them. This is the pale shrunken kidney firm kidney with pitted surface and with the scarring everything, which can be visualized in the ultrasonography. Newer strategies, I talked about this, that's why I will skip all this, Cystatin C, and generally look at their creatinine, an insensitive marker for mild renal function. So, you cannot think of creatinine always, do not depend on that. Cystatin C correlates well with the glomerular filtration rate, and you can use the biomarkers. The blood biomarkers help in the early detection of the renal disease. We did talk about all this, so I will skip all this so that I will talk more on the other way. This I did talk about novel biomarkers. Okay, in this what is more important for us is the SDMA, which is the symmetric dimethyl arginine. Let me skip all this. Okay. This is what we talked yesterday again. 1 and creatinine levels rise when 75% of the tissue is damaged. Urine enzymes are better than this because the day that we talk of, they can detect much earlier. Urinary enzymes we did talk of, I will skip all this. Proteinuria I did not talk. Let me talk to you a little about this proteinuria because this is a good parameter. This is a good predictor for the CKD progression. Screening for early detection of microalbuminuria in dogs and cats, the normal is 1 to 30 mg per deciliter. So, you can do this. Normal values for 24-hour urine excretion in dogs and cats are less than 20 mg per kg per day. And you can arrive at these values. You can go in for estimation or you can use the kits as well for detecting this. If it is a positive thing for microalbumin, then take it for granted that you should monitor these patients, that they can end up in CKD. This is the total solids meter what I was talking about, available very easily and no reagents required, only one time investment and works very well. Not even no battery for this, there is nothing on this. Okay. Pretty good for specific gravity and total proteins. Total protein is serum protein. It cannot assess the urine protein because this does in grams per deciliter. The serum protein estimation is in grams per deciliter, whereas what you get in microalbuminuria is milligram per deciliter. So, you cannot use this for microalbuminuria. SDMA, we did talk about this a lot yesterday, so I will skip this SDMA. Blood pressure is another, I think all the time now everybody monitors. You have a Doppler. Doppler is also commercially available, very easy to operate as well. Not much of an invasive technique, it is a non-invasive Doppler what you get, you can use them. So, if you get less than 150, it is called normotensive, 150 to 159 is the borderline hypertensive, 160 to 179 is definitely hypersensitive and more than 180 severely hypertensive. Why you need to do this is, how do I manage CKD when I talk of this is important. If the blood pressure is high, then you need to use hypotensive agents. Just do not go by BUN and creatinine alone. Dogs, let me leave all this. This is what you talk of is, if you are doing it by SDMA, it is generally said, people ask you how frequently I should do a test again and again if I depending on. If you are depending on SDMA, it is said once in 3 months is enough because you do not lose time at all. Whereas if you are doing it by BUN and creatinine, you will have to do it on a weekly basis. So, if you are doing SDMA, once in 3 months is enough for monitoring. This is the IRS, International Renal Interest Society, which is very popular. You get everything like this. Grade 1 is 1 up to less than 1.6, but now in the recent one it has been modified to even 1.3 to 1.5. Grade 2 1.7 to 2.5, grade 3 is 2.6 to 5, grade 4 is 5.1 to 10, grade 5 is 10 and above. I am sure all the practitioners sitting here will agree with me that we get cases of many a times, more than 90% of the cases of kidney failure when we diagnose is either in the 4th stage or the 5th stage. Rarely we should be very happy if the owners are very good and if they are ready to go for all the tests, you are in the 2nd or the 3rd stage. Otherwise, many a times it is in grade 4 and grade 5. Generally, again the cutoff thing is anything beyond 5 creatinine, one of the methods suggested is regular hemodialysis. Now, we can imagine how do I treat, how do I manage. Now, do we go by that? And in case of chronic, how often we do it? Is it going to be easier? There's a lot of difference between the human practice versus the animal practice. In human practice, anything above 5, definitely dialysis, and they will decide how frequently based on how much gets accumulated based on the diet. During the dialysis time, they make them eat whatever they want, all the kind of things. That's why if you go to dialysis centers, you will see everybody chewing and eating and only that, nothing else. They don't even say hello to anybody because that 2 hours is very important for them to eat. Later, they say no eating. Values can go up, anything can happen because you're taking away all the blood urea nitrogen products. So for us, many a times in chronic renal failure, hemodialysis also doesn't become an answer, and how many can afford is the next question, because hemodialysis is not going to be easier. We'll talk about it a little later. Now come back to the treatment part of it. Treatment of AKI. Treatment involves limiting further damage, enhancing the cellular recovery. Treatment is most successful during the induction and extension phases, and success diminishes once the latter phases have been reached. These are all theoretical, we don't know. The most effective therapy for AKI is careful management of fluid balance. That's all, nothing else. Do the fluid therapy rigorously and you are one. What is the way you need to do it? A balanced polyionic solution, lactated ringer solution is appropriate in most situations. Physiological saline contains no potassium and is suitable when treating hyperkalemia. If you talk of hyperkalemia, use this. Fluids low in sodium are more appropriate after rehydration. Determination of the volume to be administered involves consideration of a variety of factors. The volume for rehydration is calculated from the formula body weight in kgs into estimated percentage of dehydration is equal to the fluid deficit in liters. Calculate 20 kg, 25 kg, 10 kg, 40 kg. Many times what we have is we have little time, so we say that it's a 30 kg dog and now it's not taking anything. You work out on that, a 30 kg dog, estimated percentage of dehydration. The maximum that you can see is anything between 5 to 12%. Beyond 13%, the animal will be in moribund condition, it's bound to die. So anything between 5 to 10%, let's say 8% is dehydration, 30 into 8. 30 into 8 is the 30 kgs. Estimated percentage of dehydration 8 by 100, okay, 8 by 100, and calculate the volume that you get in liters. If there is vomition associated, for the losses you calculate. It works out to be anything always quite a, this is another 66 ml per kg is the maintenance fluid. You can go by this. This is a simple formula. You can even go up to 75 ml per kg body weight as the maintenance requirement, as a thumb rule. This is for a practitioner. I have a 20 kg dog, 20 into 75. That is the fluid I should do it. That's per day. This is the simplest way of doing it. Don't worry about the formula. You can very well use that fluid per day. Now, the per day when I talk of, the next question asked is, do I set the drip for 24 hours like that? No. In veterinary practice, you can give that fluid based on the rate of infusion as, normally we say 6 ml per minute. You can go up to 10 ml per minute. So, 1 to 1.5 hours is good enough. During that period, animal is good enough on that. But the question here is whether it is associated with a cardiac problem. If it is ending up in congestive heart failure, this fluid therapy principle doesn't work. If there is a pulmonary edema associated because of the constant fluid administration, or if it is a renal failure associated with pneumonitis, then this is not a fluid therapy. This fluid therapy restricts to exclusively CKD, and wherein you don't have any other complications on that. So, ongoing losses of vomiting, diarrhea, body cavity drainage are all generally estimated, and anuric patients should receive fluids to replace insensible losses as well. So, you need to think about these and give the fluids like that. And the next question being asked here is, how much of a fluid if I give between Ringer's lactate versus saline, or I have to give dextrose for these animals, because where do they get the dextrose? Other rule that you can follow here is like this: mannitol should be administered as a slow IV bolus, 0.25 to 1 gram per kg. You get quite a good amount of preparations of starch, plenty of preparations are available, you can use them. It's a good diuretic as well as replaces the fluid. Hypertonic dextrose can be used as an osmotic diuretic. If mannitol is not available, you can go in for a total dose of 22 to 66 ml of per kg, 20% dextrose. So, you can convert this RL and 22% dextrose, or you get 25% dextrose, 20% dextrose as ampules, you get bottles. Then when you give, people will ask a simple question. This is a hypertonic solution, so it will produce hemolysis, correct? Any isotonic solution infused is acceptable. Hypo and hypertonic solutions cause hemolysis. 20% dextrose, anything above 5% dextrose is hypertonic. Saline 0.9%. Each of the preparations are different. If you talk of soda bicarb, 1.3% is isotonic solution. So, you should administer isotonic solution. That is the principle. But how do we convert this? Many a times I keep talking to everybody on fluid therapy. You can convert this. What is the formula we can use? V1C1 is equal to V2C2. The known concentrations formula you can use, and 20% dextrose can be infused into the RL bottle and it becomes a 5% dextrose later. It can be used in that fashion. Or if the animal is not severely dehydrated, requirement of this, you can very well use this. Glucose is a good way of perfusing the kidney. When you do this, first time when you are doing it, within half an hour to 1 hour, if you can check the urine, if the urine shows glucose presence by any test, it is a good indicator that you can treat this patient very well. The kidney still be viable and you can reverse it. This is a simple test. Infuse 25% dextrose, collect a urine sample after 1 to 1.5 hours, urine sample, check for glucose. If it is positive, it is a good indicator. Loop diuretics, furosemide can be used. Furosemide doses vary and you can start from 2 milligram and the maximum that you can go up to is maybe 6 mg per kg. And you can call it as an IV infusion. Start like that. If there is no response to high doses, therapy should be discontinued. Do not use diuretics for a longer period, particularly in these cases, in acute renal failure. If a response does occur, this dose can be administered every 6 to 8 hours. Renal replacement therapy is the treatment of choice for patients that fail to respond to the medical management. The renal replacement therapy is totally different. When we come to the renal replacement therapy, intractable hyperkalemia, life-threatening volume overload, these are the things. Peritoneal dialysis is rarely used for critically ill people, but it is more readily available for animals than hemodialysis or hemofiltration. People talk of why not we do hemodialysis in these cases. Yes, you can do it. Acute renal failure, you can do it. Peritoneal dialysis, lot many people talk of, but there have been people saying that we do a peritoneal dialysis. I for one would say not very good at all. If you do an ambulatory peritoneal dialysis in a patient, in a day, it is considered as every 2 hours you are supposed to do a dialysis. Infuse the peritoneal dialysis fluid, you get it, or you can prepare. Leave it for 2 hours, drain it back. You should get the fluid back. And 6 times if you do in a day, the value of creatinine can come down by 0.5 to 1 milligram per day. If you are talking about the blood urea, it can bring it by maybe 5 to 10 mg per deciliter. So obviously, I would put it as saying that if you do this for 4 days like this, each day 6 times of a peritoneal dialysis is an expensive procedure and not a worthy thing at all. So the best thing is to change over to hemodialysis rather than that. So for this, you have extracorporeal renal replacement therapy, which includes the intermittent hemodialysis and continuous renal replacement therapy. Both can be done on that. And this is now these days, lot many people are buying the hemodialyzing machines. In Bangalore, in the last 6 months, I have seen 4 people buying the hemodialysis machine. I have heard number of machines are available in Chennai. Lot many people in Kerala have been practicing hemodialysis. Recently, Delhi people got it. Kolkata, there is one philanthropic agency which has come forward to establish a hemodialysis for dogs. I am on their consultancy role to establish a center with 10 machines in one place so that they want to do hemodialysis for dogs. Exclusive hemodialysis center. I don't know when it will take off. They have made a beginning. Hopefully things will become all right on that. Sorry? Both are available now. You can use human machine as well as animal machines. Even human machines of hemodialysis are good enough. Where do you find a difficulty in this is, if you have to use this machine for young dogs, less than say 20 kg dogs. The whole of the tubing, I'll show you the equipment, I'll talk to you about that. Okay, renal replacement therapy, you can follow short-term double lumen catheters, etc. I'll not talk about this. Let's go to the specific treatment. I'll come back to the dialysis there. I'll show you. Specific treatment, I'll talk to you about the hemodialysis as separate way. Certain causes of acute uremia have specific treatment. For example, leptospira. So treat for leptospira. Lot many people still will believe that penicillin is a drug of choice. Yes, I do agree. Doxycycline is equally a drug of choice. Okay, doxy is much better than penicillin. You can use doxycycline for leptospira. Pyelonephritis is usually caused by the gram-negative organisms. So any of the antibiotic fluoroquinolones are much better. To the extent possible, These are the compounds, ampicillin, amoxicillin with clavulanic acid, and cephalosporins may be effective in this. But take it from me again here. The infective diseases which cause kidney failure are only to the extent of 5% in a day-to-day practice. So, every case that you are attending is not an infectious disease. So, antibiotic is not a choice in the management of the renal failure. So, if you are very particular it is leptospirosis, then use it. Otherwise, as a choice, do not take any of them. And gentamicin is one thing which you should totally avoid. Gentamicin and combination of anuria, gentamicin and furosemide. If you make this, you have an anuric patient, you use diuretic furosemide and you give gentamicin, instead of the animal becoming all right by evening, and within next day the animal will die. So, instead of you making euthanasia, you are giving gentamicin and furosemide and feeling that you are doing a treatment, on the contrary you are killing the patient. Sorry? Amikacin? Again the question here is gram-negative organism. Gram-negative organism respond to the quinolones. Amikacin is not a choice. All the renal problems of them, lot many people use even imipen compound, saying that they are expensive antibiotic. And once I had a debate with the group, some of the experts on the nephrology. It's something like, you are running an inpatient facility and an intensive care unit. The antibiotic choice is imipen and imipen derivatives. I would say that simply. So that imipen also I get my own, and every 8 hours, imagine every 8 hours, 3-day treatment, 4-day treatment, and the bill will be something around $1 lakh for the imipen alone for 5-day treatment. These are not necessary, I would say, but if the owners insist, I have no answer on that. Aminoglycoside should be avoided because of their potential for nephrotoxicity. Urinary alkalization is recommended. Maintenance of high urine flow rates with mannitol and high volume fluid therapy may also be beneficial. So, when I say this, then probably what we talk of is treating complications, hyperkalemia. How do I treat hyperkalemia? This is the major mechanism for removing potassium from the body. Hyperkalemia is more likely to develop in oliguric and anuric patients. And when you say this, hyperkalemia can be life-threatening, and you can use calcium gluconate, 10% solution, 0.5 to 1 ml per kg IV to the effect, given slowly. This can be used to restore cardiac membrane excitability, but it does not decrease potassium concentration. Okay, it does not decrease the potassium concentration. This is to revive the functional thing about that. Regular insulin can be used, 0.5 units per kg IV has an effect within 20 to 30 minutes. You can make a combination with dextrose and insulin, so that you have a mechanism where the insulin to act, dextrose has to be present. Okay? So, you make this enter into the cell and take out the potassium from the cell out, so that it gets eliminated. So, this is one good mechanism in cases of acute renal failure associated with hyperkalemia. Correction of metabolic acidosis with bicarbonate allows an international shift. The dose of sodium bicarbonate to treat hyperkalemia is based on calculation, but finally 1 to 2 milliequivalents per kg IV over 10 to 20 minutes, 1 to 2 milliequivalents per kg. Again, peritoneal and hemodialysis may be necessary to treat hyperkalemia, because hyperkalemia in strict sense cannot be treated at all. The best way is hemodialysis. That is the reason why hemodialysis becomes a life-saving thing in acute renal failures. Now, coming to the anemia seen with acute anemia because of GI bleeding, repeated blood sampling, dilution associated with the volume overload, packed RBC transfusion is prepared to the whole blood if the PET is volume overload under oliguric. But for us, we do not have the packed cells available separately, but you can separate if you want and do it, otherwise go for the whole blood transfusion. Fluid therapy, fluids low in sodium are more appropriate after rehydration. Determination of the volume, we talked about it. Fluid therapy dose, we talked about it. And now, in patients with signs consistent with chronic or recurrent dehydration, long-term subcutaneous fluid therapy may be considered in case you find veins are not easy to puncture. The method that you can follow for these are subcutaneous fluid therapy. This is the area for both dogs and cats in the event of not able to get the cannulation. Okay, that is the most important point. And this can be done once in 24 hours. Accepted. That is why I am putting it as urine volume. This is another what you need to worry about. The importance of monitoring urine output and composition cannot be overemphasized. in a healthy animal is 1 to 2 ml per kg per hour. This is what the quantity is, 1 to 2 ml per kg per hour. So, you consider as 20 kgs and calculate 20 into maximum 2 ml per kg per hour. So, 20 into 2, 40 ml, that is per hour into 24 hours, calculate like that. And now you should monitor this, and any situation more than 2 ml per kg per hour, that might result in polyuria. This is the simplest one should worry about. 1 to 2 ml should be the minimum on that. The question asked here is, am I there to collect the urine? Yes, the owner has to do that. When we can do all other things of dialysis, when we can do peritoneal dialysis, when we do a fluid therapy, be there with their patients for so many hours, and the owners say that we cannot collect the urine and say how much has come, I think they are not real pet parents, I would say that. Because this question would be asked many a times for us, so we tell them, do it, you need to do that. These are the hemodialysis what we talk about. These are the old, this is the old model machine which we had installed long ago in the veterinary college. 90s we had done this equipment. And the left side there on the screen, the bundle what you see like a tube, that is artificial kidney. The artificial kidney meaning here is it's all just fibers. All of them, it is an exchange procedure that happens. You pass the blood there, surrounding is a dialysis fluid, and this tubing what you talk of, this will be at least around 250 ml, 250 to 300 ml. So, if you are using in a small dog, these tubings, you should buy the infant tubing. If you do that, it hardly takes 50 ml there. The tubing length will be shorter. So, that is the difference it makes. Otherwise, now the specific veterinary model equipments are also coming into the market. Earlier, these are all costing around 15, 20 lakhs like that. Now, it has come down to 5 to 6 lakhs for the hemodialysis machine. It's not very expensive. But the only thing is, the artificial kidney what you use, since you pass the blood like this, the cleaning procedure is very important. Otherwise, what will happen, if the washing is not done very well, it's as good as transfusing the blood into the next dog when you use it. So, normally what is done is, this artificial kidney is kept for a particular animal, and you can reuse it 5 to 6 times after washing. So, first time when you do that, it will work out to be the material will be around 4,000 to 5,000 rupees first time, and repeated transfusions only the fluid what you use. Otherwise, if you want to use every time fresh, it will cost you anything between 10,000 to 15,000 rupees for the dialysis. That is where the cost will be high on that. Treating complications continues. You can use dextrose for correction of metabolic acidosis, sodium bicarbonate, I talked about it. You could also use potassium citrate 40 to 75 milligram per kg orally every 12 hours. Simultaneously addresses metabolic acidosis and hypokalemia. There are situations of hypokalemia, it can also talk about it. Oral sodium bicarbonate can be used 8 to 12 mg per kg orally. I have given all these options, but maybe do not ask me a simple question again saying that this animal vomits everything, doesn't eat, how do I give this? This is for a situation where it can take it. So, do not say that like I gave it and it vomited, what should I do? Resort to the fluid therapy, infuse intravenously. Okay? So, if it can be managed, you can work on that. Hypertension, because we talked about the hypertension. So, common complications of both acute and chronic renal failure. Treatment is indicated if it is beyond 180. So, the drug of choice are amlodipine. You can use them both in case of dogs and cats. If immediate control of hypertension is necessary, you can use hydralazine. The dosage is all which I put onto that. These have been necessary. The point I am trying to drive here is you need to treat the hypertension. That is more important. What drug you use, you decide. Hypertension is treated using ACE inhibitors as well. These are much better. You know very well that you can use them, these compounds. You could also use the ACE inhibitors like benazepril, both can be used. Then amlodipine can be used, and dosage may be increased even up to 0.6 milligram per kg daily. Anorexia is the most important complication, you know very well. Anorexia, nausea and vomiting. So, treat them symptomatically. And gastric protectant like sucralfate is very essential. And many of the antiemetics have been used. The list are here. You can use famotidine, ranitidine. Ranitidine may not be available these days. Omeprazole, pantoprazole, metoclopropamide is still one of the wonderful drug. Sucralfate, misoprostol, and you could also use the meropatent which has come to the market recently. You can use ondansetron both in case of dogs and cats as well. 1 milligram per kg every 2 to 8 milligram every 24 hours. These are good enough and you need them. Do not say that these are not important, these are very, very important. I do not need a break. So, let us go ahead with the chronic renal failure. These all I will skip because I talked about it. I'll come back onto the iris staging. In case of iris staging in the CKD, what you talk of is the 4 stages. I think 5 minutes shall I finish? Okay, I think okay, my time is over. I know the time. 5 minutes I'll finish. The iris staging, the creatinine value, if you stay 1 less than 1.4, 2 is 1.42, and 3 and 4th stage is more than 5. All your cases are in the 4th stage. You should remember this. And pathogenesis, I want to skip. Clinical signs, same as that what you find in case of acute renal failure. Laboratory findings are all the same. Now come back to treatment. Treatment of CKD should generally include specific therapy, prevention and treatment of complications of decreased kidney function, and management of the comorbid conditions. Unfortunately, a renal diagnosis amenable to specific therapy is not obtained for many patients. You should remember this. Treatment is directed at the complications of decreased kidney function is often termed as a conservative medical management. So, what we are trying to do is a conservative method on that. It consists of supportive therapy and symptomatic therapy designed to correct all those kinds of deficits in terms of the fluid, electrolyte, acid base, endocrine and nutritional balance, which is very important on that. Lot of them concurrent drug usage in chronic kidney diseases. Whenever you want to use the drug, be careful on that because the clearance is slow. The dose of any other drug what you use, the dose has to be adjusted. This is what we need to remember when we talk of CKD. Dehydration, I will not talk about it, similar to ARF. Anemia is one which I would like to talk about. We talk about the transfusion, and much important is you can use this way. A therapeutic course with histamine, H2 receptor antagonist to prevent the bleeding, oral supplementation with ferrous sulfate 100 to 300 mg per day for dogs, but many a times this is followed by a black motion the next day. So, it is not because of the bleeding, it is because of the iron. You could also talk in terms of the blood transfusion. Of late, it is very difficult to accept that because in the recent times I did one transfusion where I did 5 tests to confirm a donor. 5 animals were subjected, all showed positive CEA1. So, I do not know the scenario what is going to happen in the days to come. The random transfusion for the first time, what we used to say no reaction, cannot be generally accepted that easily. So, you get the kits for identification antigen is the A1 which produces the naturally occurring antibody. That is why there can be reactions. So, go for that and do it. Then the next question is, sir, I want to do the transfusion and you said unless you do the test you should not do it. Then am I sabotaging your interest? No. The other best method of transfusion is do not collect the whole blood initially, collect small quantity maybe 15 or 20 ml in heparin. Heparin is available as 5000 units per ml, 2000 units per ml or a higher concentration. What we need is 1 to 2 units, maximum 5 units per ml. You collect in a syringe, coat the syringe, collect the blood sample and infuse that blood to the recipient. Ready with all the things. Keep ready adrenaline, cortisone, everything with you. If there is a reaction, infuse it, there will be no complications. You can go ahead with your routine methodology. So, first time transfusions you can do in that fashion. So, 10 unit is enough for 2 ml of the blood. So, infuse back into your syringe, 20 ml syringe, push back that and collect into that. That is good enough, absolutely no problem. This is a practical way of doing it. You might ask me a question, do I do it in a routine way? Yes. This is the first test I do irrespective of whether you can afford or not. People who say that I will go for a test, I will go for that, otherwise I will do this biological test. And majority of the cases, more than 80% have been successful, but there have been reactions in some cases. You will find what are the reactions. First symptom that you will find is tachypnea, tachycardia and animal eye movement, lacrimation and swelling will start slowly. Because you are already an IV connection, quickly give a dexamethasone or all these etc. all complications that you treat, it works out very well, absolutely no issues. Now, coming back to the treatment of anemia, this is very interesting. Trust me, this I have been following for the past 10 years. I would say 10 years, reason is I have been documenting for the past 10 years, right. Erythropoietin is wonderful. There are occasions when people have said, why repeated transfusion? I have gone through the whole lot of literature on erythropoietin and darbepoetin both. Erythropoietin and darbepoetin. Darbepoetin is much superior, erythropoietin is superior, I will say. This is much superior. Erythropoietin dosage 50 to 150 units per kg subcutaneously 3 times weekly, plenty of preparations. Do not call me saying that I am pro some company. It is just to say that they are available. I am not far for any of those companies. And If you can use them at initially once in 3 days for 72 hours, later it can be once a week. How long? There are literature for both erythropoietin and darbepoietin, use of them for 6 months to 1 year at intervals. Intervals meaning do a hemoglobin, do the RBC. If they are beyond 10, don't do it. If they are coming down, keep doing it. No harm in it. Darbepoietin is probably little difficult in the sense these are all in micrograms, 0.5 to 0.8 microgram. They are available as 40 microgram per ml. So you will have to adjust your dosage and that, and can use it subcutaneous again, and this can be used in a much better way. Renal thrombosis, yesterday I was very fascinated when Dr. Sumati was showing me, and the spleen thrombosis. This is pretty common these days. There are more common in CKD where protein is lost into the urine. In nephrotic syndrome, blood has an increased tendency to form clots. The renal vein thrombosis is a serious condition which can cause kidney damage and is life-threatening, but it is rare in AKD. There is at times people would say it was doing very well and it ended up in a problem. The only thing you can talk about is the protein is not monitored, hence it ended up in renal thrombosis and death. And this is also pretty common in human beings. Quickly, 2 minutes on dietary management, primarily 4 goals. Lot has to be talked on the dietary management. In a good fish oil which is available in the market and can use it. Similarly, dietary lipid, dietary sodium. Dietary sodium is quite important. Dogs with spontaneous renal disease frequently have hypertension, elevated phosphorus. This is most important. I've been talking about. Dietary phosphorus restriction is important and prevents development of the renal. Could also use calcium acetate 60 to 90 mg. Calcium carbonate combined with chitosan is a veterinary product for binding phosphorus, which they sell as intestinal dialyzer. This is what they sell as intestinal dialyzers, but they are not dialyzers, but they prevent the absorption of phosphorus. Chitosan being used over a long period also leads on to certain complications. Let me not talk too much about that. And normally when we talk of the diet, look at this phosphorus. People talk of saying, I give so much of milk, so much of things. What should be avoided? Look there. Cooked chicken has got 200 milligrams of phosphorus. Egg has got 205, lamb 200. Look at a lot of people talk in terms of the soybean flour. Say soybean is fantastic. Look at 650, wheat flour 372. Almonds, people say I give almonds to my dogs. Look at the content of phosphorus, 475 milligram. So avoid phosphorus rich diets. And influence of phosphorus when you talk of, look at here, when you say 1.4% versus 0.4%, 1.4% is the green line, 0.4 is the other one. When you talk about this, how long they survived for a period of 24 months at whatever the percentage of dogs giving this percentage, they maintained a good way to say that phosphorus restriction makes phosphate binders help in the control of chronic kidney disease. Calcitriol, I did talk about it. Excess should not be used. Side effect of calcitriol is hypercalcemia, and you get many diets, commercial renal diet versus the homemade diet. Yesterday, Dr. Karunakaran sir was talking about whether you should use a commercial diet versus a home diet. It's up to you. What is good, you can use it. If you think homemade diets can be better, you can formulate it, make it palatable. That's most important. You can mix everything, but you should know a fact that dogs are not omnivorous breeds like pigs and human beings. Whatever you mix, they will eat. No. You mix everything, there's a process. The process of making a food is very important. That's where I'm not again talking for a company or a commercial company, but the science is that the extrusion process is a must. The dog has to have the taste of food, the bite of the food. It has to keep it in the hand, chew it. Unless the chewing effect is there, that is not a food for a dog. So then you might ask me a question, whether a kibble becomes like that. Yes, the process of manufacturing the food makes the extrusion process where when you put that in water or curds or buttermilk, it gets into that kind of a feel and it can work better. Semi-solid food versus liquid diet, all these you can talk of. In case of cats, particularly dry food, and they don't drink water at all, semi-solid may be better. Liquid diet, if you can afford, internal feeding is best, and lot of herbal protectants have come to the market. Nutraceuticals, I would pay for that. I would say yes, they do work. When we had no answer of saying that you can bring about regeneration of the tissue, what best you can work out is something like this. I'm exhausted. I need to clap 10 times. Say somebody gives me a target of 100 times I have to clap to do a function. What you can make me is, we have 10 people and all are ill beyond 60 years. We cannot clap 80 times. What I can do is, the rest of them, I can make them clap 130 times. And average, we can say all we did it. So what it does is, the available nephrons can be made to function better. That's what the renal protectants, supplements, nutraceuticals do, and do a better function, and I would say that it's good. This is, people used to ask me a question, how long they can survive. Look at the prognosis in kidney failure, median survival time. Stage 1, more than 400 days. Stage 2, 200 to 400 days. Stage 3, 110 to 220 days. Stage 4, 14 to 80 days. Now it's up to you to see that whether you can make them longer, much longer than this, and probably then you have an answer and you have become a successful man. Issues: use of dopamine, use of acetylcysteine, use of amino acids. Use of these amino acid combinations has worked better, and people say the animals can be living longer. To conclude, early detection of kidney disease in dogs is very important. Amongst the biomarkers, SDMA is a way. Treatment involves limiting further renal damage. Treat the specific cause where applicable. The most effective treatment of AKI is management of fluid. Treatment is most successful during the induction and extension phases, and success diminishes once the latter phases have been reached. And regardless of the underlying cause, CKD may be characterized as an irreversible, slowly progressive disease. No treatment can correct existing irreversible kidney lesions of the CKD. Nutritional management has to be given due importance. Renal protectants, nutraceuticals, and phosphate binders play a great role in improving the quality of life. This is what the take-home message I would want you to take home, and see that you do a big way. Thank you very much. Very sorry again. I think I extended my time. I feel very sorry and apologetic for that. Thank you.
Lecture on the chronic kidney disease. So the next is tea session. By that time, utilize that short time, check out, and then come for the next session. We have to run it very quickly so that we can at least have our lunch by 2 p.m. So the next session is on minimally processed diets, an evidence-based approach by Dr. Charlotte Gray from Right for Pass. Dhanraj?
She is the founder of Companion Nutrition and the Raw Vet Company, and the Chief Knowledge Officer of Right for Paws. Dr. Gray has been part of the Technical and Veterinary Nutrition Advisory Committee of Pet Food Manufacturing Association, PFMA of UK. Over to Dr. Charlotte Gray.
Yep. Sorry for the interruption. As Dr. Sumati is leaving, now we have to felicitate her. I request Dr. Jennifer to come to the stage to garland Dr. Sumati. Dr. Sumati, please come to the stage. Dr. Uma Maheshwari. Yeah. Give them a big hand. Yeah. Dr. Uma Maheshwari, our Lady Wing Secretary, will garland Dr. Sumati. Thank you, Dr. Sumati. So we will start the program.
Are we good to start? Oh, there we go, it's coming through fine. Hi, my first few slides were dedicated to telling you who on earth I am. But actually it sounds as though I've been introduced already, so I'm going to skip through a few. What's the most important thing, I think, before I even start is that you realize how much I like nutrition. This sounds utterly geeky to most people, but I can't explain to you how powerful it can be. And I've got a few videos just at the start to give you an idea of how I ended up in this position, how I ended up being somebody who spends my entire life in a spreadsheet playing with food types rather than playing with the dogs themselves. Much of my area of work is actually now to do with fresh food formulation, and that's not because I am biased to only using fresh foods, in that I understand that there are differences between different kinds of pet owners, different types of dogs. And there are going to be situations where it is better and where it's important, and other situations where it's not. But the reason that I end up working in those fields is because that is the area where I felt there was the biggest deficit, where I felt that formulations were being done badly, where I felt that owners had nobody to speak to. Owners had no port of call if they needed help with their fresh diets, their raw diets, their home-cooked diets, their dehydrated diets. And that's how I've ended up in that field. Nutrition is more powerful than most of us give it credit for, and I know that one of the speakers yesterday was discussing how huge percentages of disease could be prevented or treated using nutritional management, and then we just had our talk just now talking about the nutritional management of renal disease. And it's incredible when you start employing those strategies to your clients and your patients, how impressive the improvements can be. I think people underestimate how much of a contribution that makes to your treatment. The other thing is that a lot of people find nutrition dry, and I think university often doesn't help that. It tends to just be a discussion of whether or not you should use Hills ID, Royal Canin, KD, urinary SO, which product should you use, and it gets to be quite a dry topic. When you move into then formulating with home-cooked foods, I'm just going to move this down because it's catching my, sorry, I keep hitting it. It becomes far more interesting when you start working on it yourself, and something I do a huge amount of is formulating diets from scratch to have accurate clinical guideline adherence. And that, the power of being able to formulate like that will hopefully get you excited about it. And something else that I feel is that I'm not sure if it's the same here, but certainly in the UK, we find that many vets feel that nutrition is something that's out of their league. We find that the recommendation is quite often go to your board-certified nutritionist. Call one of the only 2 board-certified nutritionists in the UK. Nobody else is good enough. And actually, I think that's insane. The majority of vets are happy to operate on dogs. We're happy to do surgeries. We're happy to interpret biochemistry, remove a spleen, you know. And yet, for some reason, we feel that nutrition is something that's out of our reach. And I think we're missing an enormous section of treatment options by feeling like it's something that we can't do. Why do we need to be excited about it? Why do we need to care? Because nutrition affects everything. I'm not suggesting for one moment that you can fix everything with nutrition. You can't. We know that. Your dog that ate ethylene glycol will never have normal kidneys again. But what we don't seem to do often enough is in the first consult or the second consult, quite early on in our investigation of a disease, why do we not say, what does your dog eat? And it is incredibly common that we just assume those dogs are eating a diet that will not have caused this disease. And actually, since I've moved into clinical nutrition over the last 5 years, I can't tell you how many of my general practice clients come to me and say, I have fed this food, and this is what's happened. And this diagram is actually not mine, it's from one of the American board certs, it's by Justin Schmalberg. It's not here so that you can learn about dermatological disease, it's just here to show you how many things from a nutritional point of view may affect your nutritional decisions. So things like using hydrolyzed diets, we all understand, but we have so many other diseases. So this is a good video. I hope that it will play for you. This is Mamba. Mamba looks like, to all the world, she has a brain tumor or some kind of toxicity. She looks like she has a really serious, unfixable, expensive problem. Luckily for the owners, they had insurance, so this dog had a proper investigation. It had a referral MRI. From what I understand from speaking to some of my colleagues in India, things like nutritional deficiency are more common here because the inclination to feed home cooked is higher. But actually in the UK, people don't ask. So nobody asked this dog in the first opinion practice what it was fed. This dog eats a diet based on raw fish. And what that caused was a thiamine deficiency. This dog got better from one vitamin pill. So within 24 hours, this dog was improved. 6 weeks of B1, this dog is normal. So I think this is one of the coolest cases I've seen so far, one of the most impressive rapid recovery cases. But I could do this for days. I could talk to you about cases I've seen where, where our investigations have gone through biochemistry, hematology, x-rays, ultrasounds, MRIs, and what we come back to is that it's got a vitamin E deficiency, for example. Pansteatitis in cats is something that's incredible, causes abdominal pain. Sometimes you can feel the lumps, the necrotic fat in their abdomen. These cats are quite often euthanized. Some of those cats are eating fish-based diets with inadequate vitamin E. I could talk about these for ages, but I won't because we have things to do. So why am I here today? I'm sure some of you will have noticed that I'm sitting up with the Right for Pause crew, so I can't pretend that I don't have an involvement with a company here. I don't think there's any reason to, because the reason I work with products like this is because I believe and understand the reason that these products need to exist. But my discussion today will also include some other unprocessed foods, so the raw foods, home-cooked foods. I'm not specifically there talking about cooked foods like extruded diets and kibbles, but home-cooked products and dehydrated foods. What we need to decide is why owners are choosing these. Why are they choosing them? And what can we do to help? What should we be doing differently now than we were doing 15, 20 years ago? So pet foods, most of you will realize that it's a rapidly expanding market, and I realize that we're part of that. But every time I go to a pet shop, I find a new product, every time. And owners find it incredibly difficult to decide which one to choose, and vets find it very difficult to keep up. And frequently an owner will come to me and say, I've chosen this product and I've never even heard of it, it's new. So it is a difficult area to be in at the moment for both pet owners and vets. And the other thing that is not helpful, and certainly USA and the UK, pet fooding is becoming a really emotive topic. It's becoming something that people feel very passionately about, sometimes rightly, sometimes wrongly. And I don't think I'm bad-mannered to say that the raw feeding community tend to be the most vocal, and certainly in the UK they can be some of the most difficult people to speak to in clinical practice when you're trying to discuss nutrition. So it can be difficult if you don't understand their angle and where they're coming from and why they're doing it. It can be very difficult to get them to do what you need them to do for the health of their dog. What do I mean by minimally processed foods? Just to do a quick summary, I've got the other types of food. Of course, we all know about commercial kibble foods, the extruded diets. We know that they tend to be processed at relatively high temperatures, although it varies a little bit. And they're produced at pressure. That's how they puff. They come out, they go in at high pressure and they puff on their way out. So that's how we get that well-preserved structure. It is quite cheap. It's quite easy to transport. It's easy to store. So it has benefits from a commercial point of view. Tins and wet food, they tend to be processed at a lower temperature, but they are still, we'll see shortly, subject to some processing. But the water weight does mean that canned foods are more expensive to be transported, stored, etc. You've got the raw foods, so people that transport and use frozen products. And we've got then the minimally processed products. And the reason these products are starting to exist is that practicality and safety of feeding raw foods is posing an issue. And there's these very close to raw food products that are starting to provide sensible alternatives that meet the needs of both the owners and the vets. Why do we even need to discuss it? And I've got this slide up because I think a lot of people don't realize how dramatically this trend and how rapidly this trend is changing. This is based in English-speaking countries, but also by nature of the fact that I have Indian colleagues, we know that this trend is happening across the world. the pet feeding trends are dynamic, they're changing. And at the moment, we've seen in the last 10 years, so between 2008, 2018, we've seen a doubling in the number of people who are using home-cooked, fresh or less processed foods as a decent part of that diet, as a substantial part of the diet. And this particular study that I've referenced, they didn't include pets who just fed a few table scraps after dinner. These are owners who are actively choosing to use unprocessed foods in this percentage. If owners are switching, we need to understand why, because we are going to do a better job of treating their animals if we do. So we need to look at why they switch, which of these reasons are valid, and I think that's important because we tend to, or certainly I've seen many vets in the past just say, no, don't do it. Your diet for this dog is likely to be unbalanced, it's likely to be bad, it's likely to give it salmonella. Don't do it at all. And actually that doesn't work. So we need to understand, okay, which ones are valid? How can we have a sensible conversation with these people that gets them to open up to us and discuss nutrition with us on a level so that we can get somewhere? But something I will point out is that despite the fact that in some cases we are going to have a very sensible, level-headed conversation with people who are sometimes a little bit difficult, we still need to maintain our scientific evidence-based approach. We must never say, we cannot ever say, this product will magic your dog better, the end. And that is never going to be the case. We must always maintain an evidence-based approach and we must always keep up with what's changing. Why are they switching? There was a study that looked at particularly raw feeding on this occasion, but actually a lot of overlap with the less processed packaged products as well. We've got a huge number of reasons here. We don't have the time to discuss them all, but I'm just going to highlight some of the ones that I think are the most important. Social and cultural reasons. It sounds like a silly reason. For me to say we should look into this because owners want to sounds silly. However, it isn't. We have studies now, or surveys, that show that when we recommend a prescription diet, so let's say with this renal case that we were just talking about, we need a diet that has restricted phosphorus, that has lowered protein in certain cases. If we ask this owner to feed it and they don't, we know that their survival will be compromised. And the practical point is that with these owners, we need to encourage them to actually follow the rules. And at the moment, only 5% of owners will adhere to a prescription diet properly in this particular surveyed population. I would say, in my experience, it's a bit higher, but I think that particular study just highlights that the proportion of owners who say yes in the consult room and then walk away and do something else is really very high. What about the fact that owners think there are nutrient losses when we produce kibble? What do we do about that? Are there? Are there? What can we do about it? Do we need to worry about it? It is fair to say that any processing type, sorry, every time I turn my head, this changes, doesn't it? I'm going to move it across. I feel like I'm going to make it feedback by doing it. Oh, now it's doing nothing. There we go. Any kind of processing will affect nutrients. We can't help that. When we cook our own food, nutrients will change. That's not avoidable, nor is it necessarily the end of the world, but we do have to understand what they are so that we can do something about it. The losses for kibble and tin foods are fairly well quantified. We do understand what is lost, and the majority of pet food manufacturers will replace those. So when you buy a bag of kibble, you will have food ingredients and you will have supplements added on. The extent to which they are equivalent is variable, and I'm just going to have a little chat in the next slide. Are supplementation versions of a nutrient identical to the ones that come from food? I would say in many cases not, although it depends very much on the choice of compound. But the other aspect that I have a lot of conversation with when I'm talking about minimally processed foods with those who are very pro-raw, pro-home-cooked, pro-minimally processed, is what about the things we don't consider essential? So our guidelines, things like FEDIAF, NRC, AFCO, they all give us a set of guidelines that are about 26 nutrients or so, depending on which set of recommendations you're looking at. What do we do about things like beta-carotene, which are not considered essential, but which may help? Those might be lost as well. We also have some processing changes that will bind things and make them less digestible. So we're going to talk over those things. This chart from the bottom is just from the Small Animal Clinical Nutrition 5th edition. It's very easy to get hold of, but it just gives you a few examples. So this first one, in moist food, we're getting losses of particularly water-soluble vitamins during storage. So we have things during processing. So we're losing 50% of our thiamine in processing. I accept we are likely to replace those. And of course, then we're having more of the fat-soluble losses in the kibble foods. So in a raw and unprocessed food, as you would expect, if you have no processing at all, you're not going to lose any nutrients. So that's fairly straightforward. Home cooking losses can be very variable. So of course, we will have pet owners who are cooking at home. Something that can cause a real problem for me, certainly, is owners who boil foods and then drain the water. Because you can find you lose large amounts of water-soluble vitamins. And dogs like this little dog, the neurological dog, if you lose too much thiamine, especially if you're home cooking for a cat, you're going to find yourself in trouble. Home cooking can be a good option, but I would say of the different owners that I work with, it tends to be the worst addressed. I will say, from experience of working with vets in India in previous years, there is a better attitude to remembering to supplement things like calcium in India than there are in home cooking in places like UK or the USA. Minimally processed foods, though. The processing method makes a big difference. There's certainly a marketing strategy in calling things minimal processed, and it's things like calling foods cold pressed when they're in fact not processed cold at all that make it very difficult for understanding whether we're going to get losses. But it is possible with dehydration processes, if they're done very carefully, to achieve some really very minimal losses. And this chart is just from one of our sets of data from Right reports from quite a lot of years ago, probably 3 years ago now, from the processing development stage. But we're getting a thiamine loss down to 8% versus the 52% we're having in canned. It's about 9 or 10 in kibble, but we're also not losing substantial amounts of fat-soluble vitamins either. What about the fact that owners have worries about artificial supplementation? Is it a problem? Is artificial supplementation an issue? And I would say a really unhelpful, well, it depends. It depends what you're using. It may not be equivalent in every case. So certainly if we're looking at, for example, zinc. Zinc is a really commonly used nutrient, commonly very low in processed foods that need it then supplementing. Using very bioavailable forms, and we'll talk about what bioavailable means in a second, means that you get a very good access, a very good absorption, very good use of that zinc. Using products like zinc oxide, you may find that a larger amount is required to provide the same amount of usable zinc. And it's those kinds of decisions in pet food manufacturing that can put us in trouble. If pet food manufacturers, or certainly owners at home using supplementation, choosing correctly, they may actually cause themselves a problem. I would say from experience in the UK, I do see the result of poor supplementation in commercial available foods. They don't, the fact that they are available on the market does not necessarily mean that they're brilliant. And as we were saying earlier, the other concern is, what about non-essential nutrients? We don't currently consider anything outside FEDIAF, AFCO, NRC in most pet foods. What do we do about that? What do we do about things like vitamin C? Not an essential nutrient in most dogs, but does have immune supportive actions in pets who are convalescing. What do we do about that? What do we do about beta-carotene that we know is good antioxidant support for dogs with canine cognitive dysfunction? Old dogs need antioxidants. For dogs with renal failure who would appreciate additional antioxidant activity. We don't consider those. And the question is, the fact that we don't need them, does that mean that we should ignore them? The fact they're not supplemented, is that sufficient? And that is a problem with processing, is that we are ignoring that at the moment. We can also lose nutrients in ways that are not quite so obvious. So we can say, okay, we tested thiamine before, we tested it afterwards, it's less. What about nutrients that are still there but can no longer be used? And I think that's a much more subtle problem. A common one discussed is actually the phytic acid and having phytate complexes forming in processing of high carbohydrate foods. So if you have a high level of phytates in foods, it will bind your zinc. So your available zinc in a pet food may be an awful lot lower than what you think it was when you made the food. And I have seen zinc-responsive dermatoses in dogs eating carbohydrate diets who will then improve when you switch them to very high meat diets. And I've got a discussion later about the few reasons why that might be. The other issue we have is this formulation of amino acid complexes with carbohydrate. The extent to which it happens in processed food varies, but extrusion and high temperature increases the incidence of these bind complexes. And if we have Maillard reaction products, we find generally that dogs do not absorb them, and when they do absorb them, they excrete them. But we're going to talk about later about whether those have any additional concerns associated with them. What about the owners who just say, okay, this food's less processed, so it must make the dog more healthy? And I know actually we do now say that in people, so I'm not surprised that owners are now following suit and saying, okay, well, if my dog eats, if I eat unprocessed foods, why is my dog being encouraged to eat processed foods? It doesn't sit quite right with our current health ethos for us. So how do I feel about that? We have got a lot of research to do on this. We have a long way to go, and I can't tell you that whole foods are perfect and kibble is rubbish. That's not acceptable. I think we've got to be very much more balanced about this. But we are having an increase in the amount of research into using fresh foods and whole foods and raw foods and minimally processed dehydrated foods that are starting to support these owners in their understanding that their pets are healthier. And I'm going to talk over some of these recent studies and see if you can sympathize with those owners like I do. So the things we're going to consider, these are the things that I think may explain why owners see better health in their dogs that are on minimally processed foods or raw foods. Digestibility, we'll talk about it, what that means. Bioavailability. Reaction products, which was these protein-carbohydrate interactions we were just discussing. Effects on your gut biome. That's a huge topic, the gut biome, and I'm sad to only give you a few slides on that, but that is a fascinating topic. And ingredient types. What ingredient types are we using that are different? So digestibility means the amount of nutrient that is available for passive and active absorption in the gut. So how well is it broken down in the first place? And that is affected by the type of ingredient and the type of processing. There is a difference between processed foods and unprocessed foods in terms of digestibility. So we do see a higher digestibility in unprocessed and minimally processed foods compared to cans and kibble foods. I'll try to give you all the slides for this because all the references are at the bottom of each slide, and some of these studies you might want to go fish for. Excellent bedtime reading. Increased digestibility, as you would expect, also reduces fecal volume, which you would expect, and it reduces their feed intake. So these dogs will do better on less calories. So we can see that they are absorbing more calories per gram than they would be from an identical food in a processed form. And it's now become quite widely accepted that we should use different calculation guidelines for whole foods and for processed foods. So for kibble foods for many years, and also when I was at university, we used something called the modified Atwater factor. So the Atwater factor was a multiplication number that we used to guess, or estimate rather, the amount of calories in any given food product. We used a number of 3.5 for protein and carbohydrates. That's actually 0.5 less than we would use to calculate the amount from a human food. The reason we did that is because we know, or we knew in the past, that pet foods were likely to have a slightly lower digestibility and bioavailability, and we allowed for that in our calculation estimation. But we now use, certainly in the UK, and has been recommended by our PFMA, our Pet Food Manufacturers Association, if you are formulating with foods that are whole foods or minimally processed, that we use the original Atwater factors. So we now use the 4 for protein and carbohydrates because we understand now that dogs and cats will obtain more calories from an unprocessed product than they may do from a processed product. It's a sliding scale. There are certainly better and worse foods in the pet market in terms of processing. We have some of the prescription diets are approaching whole food in terms of digestibility, but actually there will also be products at the other end with a digestibility of just 80%. So then we have bioavailability. It's often common that people don't realize the difference between digestibility and bioavailability. Bioavailability will tell us how well used those nutrients are once they are absorbed. So once they're up through the gut, can the dog or the cat do anything with it? And iron I like as a good example for this. It varies quite a lot. So different kinds of iron from different sources are used differently. Iron from plant sources is less well used by dogs than iron from meat sources. And supplemental forms are used very differently. So iron oxides, we do not use in pet food except as a food colouring because it does not provide in a form of iron that they can use. But things like iron chelates we can use, iron sulfates we can use if we want to. The other thing that links back to where we were talking about loss of non-essential nutrients, where we were talking about loss of beta-carotene and all these things that we think are just bonus features, there is a possibility that these bonus features, these things we aren't considering, may be affecting the bioavailability of minerals in foods. And iron, again, is a brilliant example. Anybody who's ever been given iron tablets at the doctor, they will tell you to take it with orange juice because it improves your absorption and your bioavailability of your iron. What if the vitamin C in these pet foods that are unprocessed is improving the absorption of iron? These are all things we don't know. I realize it's a very speculative conversation, but there's a lot of potential here that the health benefits that owners and vets are seeing in minimally processed foods are real. The processing method can also affect the binding of protein, which we already discussed, but that's twofold. We've got these potential health problems that we'll talk about later, but we're also losing amino acids, and one of the amino acids most affected by this is actually lysine, and lysine can be bound to the sugars during the processing and lower it to a level that actually makes it inadequate. And there were some concerns a while back. There's a study listed here that some pet foods in this study had levels of lysine that were actually hazardous. They were too low for the dog as a result of that processing. So could the differing bioavailability be the reason that some owners are seeing improvements? I would say yes, it's very likely that there is a contribution. We are yet to quantify that. We've got a lot to look into. But for example, going back to this sheet from the beginning, so going back to Justin Schmalberg's dermatology paper that he wrote here. This paper is suggesting that we supplement dogs who are already on other diets. But could some of these things be being solved? Are we solving some of these problems by switching that dog? Is that why they're seeing the improvement? So the zinc deficiency dogs, the dogs with dermatosis that move to unprocessed, minimally processed diets, is it because the bioavailability of the zinc is better? Are we accidentally fixing zinc deficiency because we're changing them from a processed diet or a kibble diet to an unprocessed diet? What about the forms of vitamin A? We get vitamin A dermatoses. Certainly in the UK, we see it a lot in golden retrievers. Are we accidentally fixing vitamin A responsive dermatitis by giving dogs an alternative source of vitamin A? Because these dogs, quite often we're using liver as a source of retinol, so the active form of vitamin A. Is that why these dogs are getting better? What about cofactors? We were just talking about how iron absorption is affected by things like vitamin C. Are we seeing improved health in some of these dogs because the nutrients that we are talking about in this slide, things like vitamin E, things like zinc, are they more available because of cofactors that we do not yet understand? Are there things in this food improving absorption and improving bioavailability? Are we seeing better amino acid availability because they are no longer bound? Quite often, raw feeding owners and owners on minimally processed foods are reporting better coat colour. That's a really common thing, better coat colour and better shine on a coat. Is that partly to do with the fact that these dogs are better absorbing amino acids like tyrosine because they are in forms that are more available to them? This is the bit that sometimes causes some conflict in my consult rooms when I get raw feeding clients particularly who are saying to me, look, kibble kills dogs. Kibble kills dogs. And I think we have to be realistic in saying, if that were the case, a lot of dogs would be dead. We can't be saying, yes, okay, owner, definitely kibble is killing your dog. But what we do have to say is, okay, there are some aspects of kibble processing that I understand you might have concerns about, and this is where we're going to go. So these processing products, the Maillard reaction products, where we're getting cross-reaction between amino acids and sugars. In humans, endogenous Maillard reaction products, so ones that are formed inside the person, are associated with chronic disease, so things like diabetes, renal disease. We also have some studies in humans that show that if you increase your intake of dietary Maillard reaction products from processed food, that you will increase your endogenous pool of Maillard reaction products. So the food you take in is affecting it. So we've got a few parts of the puzzle. If you eat more of them, you likely will have more circulating Maillard reaction products. We also have some studies suggesting that these Maillard reaction products are involved in affecting the gut biome. And we know, as vets, the gut biome plays an enormous role. I think there was maybe somebody here selling products yesterday, weren't there? Gut biome product to support the gut health. So we know how important it is. These gut bacteria have so many roles. For me, some of the roles I discuss with owners a lot is things like vitamin K and choline, so minimal nutrients that need to be produced by gut bacteria. If your gut bacteria are incorrect, you will find your level of nutrient production is incorrect. Things like converting your dietary components, the food you're eating. The things that are most relevant in this context, though, is things like secondary bile acids and indoles and your fatty acids produced by that bacteria support your gut. So things like providing anti-inflammatory actions, they modulate your intestinal motility, your gut bacteria. In some cases, it will inhibit your enteropathogens, and we all understand that because we will do things like take gut probiotics to prevent getting sick from other pathogenic bacteria. They also act as signaling molecules. So we get multiple organs affected despite, well away from your gut by these signaling molecules, and they are all associated with gut biome. So I think we have to be sensible in saying, look, if these products are affecting the gut biome, there is a possibility that it is also affecting health in a way that is far bigger than we currently understand. We have also had a few studies in dogs that have tried to link these things together. And we had a few very recent ones. There was one in 22, one in 2020. We've had a recent one that suggests that dogs fed human-grade foods. So that was less processed foods, food scraps, raw foods, things like that. People that are putting in up to 20% of fresh foods, let's say, less processed foods. These dogs had a lower incidence of atopic dermatitis and IBD. I've realized my slides actually for this are the next one, but we can have a look shortly. But we also know from these studies that it is affecting the gut biome. So there are several studies now linking the difference between processed foods and raw foods and the change in the gut biome of dogs. There was one a little while ago linking gut biome and aggression, which was an interesting study, and I'm not sure we can start making that link just yet. But these studies continue to be showing us these processed foods are changing gut bacteria. Could it be that the effect of the processing products on the biome are the cause of some of these health benefits that the owners are seeing? Is it the fact that removing those is improving their health? I have to suggest it's feasible. Again, we can't say, yes, it definitely is. We need good controlled feeding trial studies in groups of beagles, identical dogs. We need good studies to prove this kind of thing. But I would say that so far, our correlations and our surveys are starting to suggest that it might be true. And I think we have to consider that both as vets ourselves, but also when discussing this choice of food with owners. I don't think we can poo-poo their ideas when they say to us, well, kibble causes cancer. I think what we can say to them is, look, I understand where your concern is coming from, and that's where we start. And this is how we maintain a good communication with our owners, irrespective of what they're choosing to feed. So these are the slides from the study, sorry. So there's a group in Helsinki called Dog Risk, and they are run by a lady whose name I wish I could pronounce, as Anna, a wonderful vet who is producing some really well-designed studies based around unprocessed and minimally processed foods. And one of these studies is her. She did an enormous survey of dogs, and she selected her participants in and out of the study carefully to try to avoid too much bias. She has found that dogs that are offered at least 20% unprocessed foods are having a lower incidence of atopic and allergic dermatitis. And we had another analysis a bit later of 7,000 dogs showing us that a similar pattern is seen with young puppies, and if they are exposed to fresh foods earlier, they are developing less IBD, so irritable bowel disease, food intolerances relating to gut. So the limitations, this is a paper that I would encourage you to go and look at. the lady who, the group that wrote this paper, they're realistic in their conclusions. They do not conclude that therefore all dogs should eat fresh food. They're not that silly. They do discuss their limitations and how we need further research, and they suggest further places to take this research. But what I think is important is that we are consistently getting the same correlations. We are seeing the same correlations, and at some point we are going to have to move, I think, on this. So what should we do about it? We're a group of vets. We all have hundreds of patients. Should we now write them all a letter saying, by the way, please make sure you feed 20% raw food or 20% minimally processed products? No, we can't do that. We don't have enough evidence for that just yet. Even if the studies were definitive, there are other factors to consider. Okay, so we've got, particularly with raw foods, fresh raw foods, we have issues, especially in hot places like India, with pathogens. So both the processing method and then, taking the animals apart and then refrigerating it is quite difficult. We also have issues with nutrient balance. Certainly for me, the things I see the most often is calcium issues, high vitamin A from excessive amounts of liver being fed, excessive fat, and then the excessive fat causing low nutrient density aside from fat. What about home cooked foods? We've got the same issue with balance here. So that is, again, something we have to do carefully, using recipes that we know are balanced, if we're going to do it at all. If we don't, and certainly, again, I see this a lot with elderly owners in the UK, it tends to be elderly owners with miniature dogs. I see this in dogs with severe hypocalcemia and bone resorption, particularly obese dogs. We see a lot of home-cooked obese dogs at home, and mineral deficiencies all through. Dehydrated and cold pressed foods, we have to consider the processing. That said, the positives here are that when we get into the area of things like dehydrated foods, we can remove some of these worries from raw foods. So we can get some kind of middle ground where we can provide this less processed product, but without having worries about pathogens, without having to freeze things, and without worrying about cross-contamination, things like E. coli, Listeria, Salmonella, Campylobacter. So we have got some middle ground there. Dehydration method is important. It's very important that you speak to your companies about their processing methods, and I've got a slide just now for that. And cost. I think we have to be realistic. If I had my choice, I think that I probably would feed all of my dogs on less processed foods. I would feel that that was the right thing to do, but I openly admit I have quite a lot of very large dogs. And realistically for me, it's not always possible to feed them all the things that I would want. And we have to transfer that consideration to our clients. We should not make owners feel bad if they cannot do the thing that we want, but we should always be able to provide an alternative. And that works both ways. If we have owners who want to feed raw foods, minimally processed foods, dehydrated foods, we need to find the best option for them in that direction. And this is where I think foods like the ones we've worked on here, this is why I have gotten involved in products like this, is I think it does provide a safer, better balanced alternative for those owners who want to feed things like raw and home-cooked foods, because I see the nutrient deficiencies so frequently that it makes me want to find an alternative for some of those owners. So what can we actually do? Given that we cannot tell them all to change, what can we do? There are several things we can look at in each and each type of food. So we have the raw foods. If companies are producing raw foods, they need to be able to show you that they test for pathogens. And in the UK, we have some guidance, but actually there is only a requirement to test for coliforms and Salmonella. We do not have to test for Listeria or Campylobacter. There was a recent case in the USA where we had a company testing for Listeria, but failing to remove the product from the shelf. So do speak to companies, or ask the owners to speak to the companies to ask about pathogen testing. Look for a company that adheres to some internationally recognized nutrient guidelines. There is a habit in the raw feeding market of saying that you don't need to do that. And I think I could talk for a day as well about the fact that perhaps FEDI, AFCO, NRC are not perfect for products that are unprocessed, because they are not made with those in mind, but they are still useful. And for a company to deny all knowledge of existing science when formulating a food just because it's raw, to me just indicates a lack of thought. So any company that says to you, I don't care about nutrient guidelines, I think I have no interest in that look for nutrient disorders. So the one thing we will find is that a lot of our owners will go away and do something different to what we have said or didn't ask us. And something that becomes important then is that we retain our communication with these owners. Make sure that you stay in contact with these owners. Do not shame them or make them feel bad, because you need to diagnose their nutritional deficiency when it happens. So in 7, 8, 9 months, when that dog has a dermatitis or a hyperkeratosis or develops chronic diarrhea from your zinc deficiency, you need to know what that looks like. And I could give you a talk on each of these nutrients and all the things that I've seen from owners who are using poorly formulated products. What about if they're home cooked? I think we've had quite a lot of recipes actually. I've been pleased to see how much there was in terms of nutrition in the last day or so. Truly home prepared diets, certainly in the UK, tend to be shockingly unbalanced if they are not dictated by a vet or by a nutritionist. Owners who make up diets at home frequently do a very bad job. And we were talking just now about the renal diets and the fact that many owners misinterpret our discussion. So we say, you need lower protein in these diets. Owners here, no protein. So we have to be very careful about home-cooked diets because they do not always interpret us well, and that is where there is this very much safer feeling in prescribing a diet or suggesting a diet that already exists. What about if they are not happy to buy a complete product or if it is not affordable? So you need to find a recipe that has been formulated by a vet or a nutritionist. You need to find something that will meet their nutrient guidelines to feed them. In the UK, the options are quite limited. There's actually just the 2 board-certified nutritionists, and as far as I'm aware, me and a few other non-veterinarians who are formulating. In India, hopefully you're bigger, so I hope there are more. But I think this is the thing. I don't know if you have a list of people you can contact, but I really hope there is one. A list of reliable nutritionists is what you need. And what about the minimally processed diets? Things like Right for Paws, but we also have the New Zealand product that is very similar. We have cold pressed products in the UK, a product called Hug. What do we need to know for those products? How do we choose for owners whether or not they are good? They do provide an excellent halfway house for owners where you would have concerns about home cooking or about raw foods, because there are lots of, as we've seen, potential problems, particularly in the region of balance and pathogens. We do have less nutrient loss, so for some owners who are worried about their raw food saving their dog's life, preventing disease, they can be very useful. It tends to give us a halfway house with less pathogen risk. And it does quite often, and I say this just from speaking to huge numbers of raw feeding owners as a veterinarian, it does tend to sit quite well with their cultural beliefs in terms of unprocessed feeding. So where you have owners where you have concerns about the current food, it does quite often create a middle ground where they're happy to work with you, but still feed a complete food if you have concerns about nutritional deficiency. So what can we continue to recommend? The recent studies do seem to suggest that some foods may be better for the health because they are fresh. We don't understand it yet, but we're getting there. Is it reasonable to say that supplying some fresh food is better than none? Our recent study by Anna does suggest that actually supplying some fresh food on top of kibble might be better than using nothing at all. Optimally though, we would try to use balanced foods. So if you are going to use a product that is fresh on top of a kibble food to try to work with this recent finding that perhaps it's improving gut biome and improving health, what we need to be doing is trying to find a product that is unprocessed but balanced is the optimal way to do it. So I guess gold standard would be the term we use there. Or if they are going to use things like table scraps, meat that they have around themselves, things they bought at the raw pet food store, try to encourage that 10% of the diet remains unbalanced at most, if possible. This is if you are worried that this dog is at risk of nutritional deficiency. Are there any cases where we as vets might say, actually on this occasion, we should use a less processed diet? It's going to depend on your own belief a little bit, I think. But for me, because I now work exclusively in nutrition, so I will see continuous cases of the worst deficiencies and the cases that have not responded to anything else, the place where I see the most response when they're moved to a less processed diet is the gastrointestinal disorders. And I think a lot of that comes back to probably the digestibility, but the bioavailability of some nutrients may be playing a part. There are huge numbers of dogs that I work with that have tried Purina HA, they've Hill ZD, they've tried feeding just home-cooked diets, but they've used the processed versions, you know. And when we then move them to unprocessed or less processed diets, their fecal volume decreases, their ability to absorb their water improves so they don't have diarrhea, and we're getting improvement in body condition. I think there are going to be some cases where if you have run out of options or where you have gastrointestinal disease that is worrying you with low albumin, that we start to look at using less processed foods. It's already the norm for allergic skin disease, certainly in the USA, to switch owners to an unprocessed, home-cooked, 2-ingredient diet. So there are cases, I think, where as vets we are going to start to want to recommend unprocessed foods or minimally processed products right from the start. So this is my conclusion slide. The pet feeding landscape is becoming quite complex. It's changing quite a lot over the last 50, 60, 70 years. It's important, though, that we continue to keep up with this. Many of us have been in this profession for a while. I've only been in for 13, 14 years. Some of you will have been there for decades. It's changing. We need to keep up because our owners will change. It's also important to continue to discuss openly with these owners their choices. So we must make sure that if they are choosing to go minimally processed, that we understand why and we go with them. There's also some evidence to support them. We know that there is evidence supporting the potential benefits of feeding this way, but you must make sure that nutrient balance remains at the forefront of your recommendation. Owners who choose to move to fresh foods may be better in many cases to use a pre-prepared product, if at all possible, because we reduce this risk of nutritional deficiency. In terms of where you find other information for these kinds of things, each page has got references, and I'll try to make sure that you can get those so that you can chase down the references for any of it. You're very welcome to email me if you have questions relating to this or other nutrition things that you think I might know about. I would say I'm quite busy, so I apologize for any delay if you do happen to email me about a case. And we were talking about the calories last night, the calorie calculators. I will try to add some calorie calculators for you to either the Right for Paws website or my own website to make nutritional calculations a bit quicker for you in practice, because I appreciate doing that maths in a 15-minute consultation can sometimes be quite challenging, especially when you're dealing with growth cases or lactation cases. So please let me know if there's anything else you'd like to learn another day. Send me an email. I do look forward, hopefully, to the new generation of vets or the new recent graduates moving into nutrition in a new way, trying to approach it in a much more open-minded way than we used to. And then this is one of my dogs and my daughter. So thank you very much. Has anybody got any questions? Thank you. How do I turn that off?
Thanks a lot, Dr. Gray, for enlightening us on the nutrition, canine nutrition. And right now, they are going to launch their product. I request all the delegates to come inside. And one small announcement. After this, the felicitations program is going to be there, the tea session, and the 3 lectures are there. And finish off the tea sessions quickly and then come to us. And a final announcement, in the end, after the program is over, we are having a lucky dip here. For those of you who are present only will be given the lucky dips. And then another gift is also there. You have to all give your feedback forms, and then you can collect a gift hamper from the Right for Paws stall after the program is over. And there is an announcement from the resort people also, and they have decided to give 2 nights free for a family who have given a good review in their website. Thank you. I request Dhanraj to start.
Dr. Karnataka, Dean of Madras Medical College, and Dr. Etraj. Please come on stage and light the lamp to bless us.
ஐயா அவர் ஓரம் வர சார் லைவ் போயிட்டு மறுபடியும் கேபிள்
Am I audible? Am I audible? Yes, so this is the last session before the tea break. So, good afternoon to everybody. Good afternoon. Let's hear it back. Let's bring that energy out. Good afternoon. So, thank you to Sapac Tn for giving us this opportunity to introduce Right for Pause. My name is Samir. I am the co-founder of Right for Pause. Yeah, Pallavi, this is my colleague, Dr. Pallavi. She's going to run the slides for us. And oops. Okay. Yeah. So, the journey of Right for Pause started 15 years back when my friend and founder Dhanu started his research on finding a pet food that is healthy at the same time provides high performance to his dogs. We've taken time. It took us 15 years to get here. We've taken time. We've perfected the products. And in 2022, we launched the products in the market. That was around July 2022 is when we launched the products in the market. So, Right for Pause is a journey where we are on a mission to provide holistic well-being to pets. Holistic well-being comes when the internal and the external health of the pet is good. As they say, a healthy gut gives you a healthy body. So our journey starts there. Now, how are we doing this? We have brought out the next generation of pet food, which is the minimal processed food, using the latest available technologies. The dry kibble, which is the popular format, is the extrusion technology that's used to make dry kibble is at least 60 years old. There have been incremental improvements, but The technology as such is about 60 years old. So this is the next generation of pet food using the latest technology. All our products are 100% natural. The formulations have been done in UK by Dr. Charlotte and team, a team of veterinarians, and we are a clean labeled product. All our products are, what goes into the product is put out very transparent. It's very easy for the end user or the pet parent to understand. Yeah, next slide. We are proudly Indian. We make world-class products in India for the world. 99% of all the raw materials that go into the food is made in India. So that's the way we support the Indian farmer and the industry as such. You might be interested to know that 70% of all the pet food that is sold in India is imported. In spite of the fact that we are one of the largest exporters of meat for the world, we export substantial quantities of poultry, that's eggs and chicken. We are one of the largest exporters of marine products, and we export a lot of fruits and vegetables. All of this, all of the raw material which go into pet food go from India, but we import pet food into India. I mean, I don't know why. We make satellites, we make rockets in India. So, and I'm sure we are very, very capable of making world-class pet food in India and put India on the world map. India's time has come, and we are just doing our bit. Yep. So Right Food Paws, as I said, was formulated in UK by expert veterinarians led by Dr. Charlotte. So we have a technical tie-up with the Raw Vet of UK for formulations, research and development and training. Dr. Charlotte is part of Right for Paws as its Chief Knowledge Officer. Yeah. So this is our product offering. We have products in two categories, pet food and pet wellness. Pet food is our mainstay, and that's what Right for Paws is primarily. So in pet food, we have complete and balanced diets which meets FEDIAF guidelines. We also have complementary meals which can be paired with home cooked meals to provide to basically address the nutrition gaps. We would be coming up with our natural supportive diets, the first in India, somewhere towards the end of 2023. We are coming up with our food toppers and treats in probably another 3 months. In the pet wellness category, we have products for personal hygiene, which are probiotic shampoo, coat cleansers, grooming butter, and so on. For external hygiene, we have floor cleaners and kennel washers. So Dr. Pallavi would obviously run you through these products as we move along. Now, all of the pet food that we make is built on some core philosophies that we follow. As I said, it is 100% natural. I mean, whatever ingredients that goes into the food is 100% natural, and there are no complex chemicals or preservatives that go into the food. Human grade ingredients, I think Dr. Charlotte spoke about that. All what we use, what goes into the food are human grade ingredients. These are the food is species and biologically appropriate, which means it is designed to suit the digestive system of the dog. And it suits the body constitution actually. So that is what species and biologically appropriate diets are. No chemicals, no preservatives, no palatants, no flavoring agents, no coloring agents, none of it. All of these are bad for the dog, and we don't use any of these in our food. And in spite of all this goodness, it's as easy as it can get. Just open, feed, shut and store. It's as easy as it for a pet parent. So we bundle all of this. We bundle nature's goodies with the convenience that the pet parent requires. Now this is an actual shot of what goes into the food actually. I mean, what you see here is an actual shot of what goes into the food. We have multiple ingredients that go into the food, starting with different cuts of meat, eggs, fish, fruits and vegetables, botanical herbs, pre and probiotics, cold pressed oil, and so on. These ingredients are as I said, we'll just go back. All of it is sourced in India, and the obviously minimally processed. The natural nutrition is obviously retained in the process. Yeah, let's move. Now, as I said earlier, we are a clean labeled product. We believe in the concept of clean labeling. Clean labeling means it has to be transparent. The ingredients that goes into the food are everyday ingredients which the pet parent understands. I mean, he doesn't have to sit through a chemistry class. I mean, there are no complex chemical equations that are there. These are very easy for the pet parent to understand as to what goes into the food. And that's what transparency is all about. Just to give you an example, I mean, if you read concentrated lime juice in a label, it actually means citric acid. The concentrated lime juice is the way to mask it, you know. Or let's say you read something like concentrated apple juice, it's nothing but sugar. These are not examples of clean labeling. Clean labeling is when it's transparently put out and the pet parent understands what's going into the food, and he reads it and he gets it. And we are the detailing of nutrition analysis on our pack and the declarations that we give on our pack is the best in the industry, unmatched by any other brand, and we are very proud of this. Yes, Malavi. So now you must be thinking, what is the technology that we are really talking about? So this is the technology that we use to manufacture Right for Paws pet food is called multi-factor controlled dehydration, or the MFCD technology. The objective of this is to preserve the natural nutrition by sucking out the moisture from the food and ensuring that the enzymatic activity in the food is not compromised, or without really hampering the enzymatic activity. What you get in terms of a product after the dehydration is something that is stable and has a long shelf life. We have an in-house proprietary process called, process that we follow, where we modulate 4 factors to achieve the dehydration. The factors that we modulate is airflow, humidity, temperature and time. All of these factors are modulated to get the end results. So the fresh ingredients are taken, they are measured, they are blended, and they are balanced to standards, and then it is dehydrated. So that is the process that we follow for the food. So it typically takes about 18 to 21 hours to complete this process end to end, and that's how we get the food which is dry and can be stored for about anywhere to 12 to 18 to 24 months. Yep. So the results of the MFCD technology, the product that you get is 100% natural. The ingredients are not denatured, which means if you rehydrate, you can bring it back to a fresh meal in about 3 to 5 minutes. Once you rehydrate, you can just look at the food. You'll find the pigmentation and the texture of fruits, vegetables, and the meat. You can actually find them in the food, which is not possible in the other format, the kibble format. It will never come back to its denatured. It will never come back to its original form. Here, the ingredients come back to its original form in terms of textures and colors actually. We have a long shelf life. As I said, it's anywhere between 18 to 24 months, and the process itself will ensure that there is no fungal or microbial growth. And the moisture content of the food is anywhere between 4 to 8%, and the water activity is between 0.4 to 0.6. And the peroxide values are anywhere between 1.5 to 2.5. All of these are amazing results compared to what you find in a dry kibble. So it's safe, it's healthy, and I would say it's best for your dog. So, yep. So that's it from me. So I'll just request Dr. Pallavi to explain about the products. Thank you.
Our diet has a very big impact on our health and overall well-being. And this same thing applies for our pets as well. Wrong diet can lead to a lot of health issues that comes up, starting from dental issues to obesity, diabetes, allergy issues, and the list is never ending. Hence, to get it right is very crucial. I'm Dr. Pallavi and I'm here today to showcase our products from our Right for Paws company. So we have two main categories. One is food and other is wellness products. So to begin with, we start with the Nutrition Naturally series, which is our range of complete and balanced diets. So this series is a complete and balanced diet, and it meets the nutritional requirements, both macro and micro requirements of a dog on a daily basis, and it meets FEDF guidelines as well. It has low obesity risk. Today, obesity is a growing concern among the pet world, so all across the world. And so our products, we ensure that no added sugars, no fillers, no starchy vegetables, no unnecessary starch is added. So this takes care of like the fact that pets should not gain unnecessary weight and lead to obesity. Higher absorption and reduced stools as another factor, which is very important again. So a lot of factors comes in play here. The quality of food that we are giving, the quantity, and the balance among the nutrients, which helps to decide how much of the food is absorbed by the body and how it is utilized for the different functions of the body. So our food is highly absorbent, and which results in reduced stools. So these are nutritional highlights of our product. So it has no GMO, no filler, chemical or preservatives, balanced for best bioavailability, best price to value, and because of the high nutrition density, feeding 25 to 35% lesser compared to dry kibbles is what we suggest. Pathogen control is done over 3 stages and it leads to a shelf-stable product. So here we have the complete and balanced range for puppies. So we start with a starter pack, which is for all breed starters, and we can start with this from 3 to 6 weeks after the puppy is weaned from the mother's milk. And from the 6th week onwards, we can start the puppy food. It has 3 categories: toy and small breed, medium and maxi breed, and large and giant breed. So all this, this whole range is 85% high quality fresh animal source ingredients with vegetable, fruits, herbs, botanicals, and probiotics. The highlights of the puppy food is that it has optimized calcium and phosphorus levels for excellent growth, high levels of DHA for maximum brain development and trainability, increased zinc levels for better immunity, and the energy delivered is 4840 kilocalorie per kg on dry matter basis. Now we come to the complete and balanced adult food. So this again has 85% high quality animal source ingredients with vegetable, fruits, herbs, botanicals, and probiotics. It comes in 3 forms: for toy and small breeds, medium and maxi breed, and large and giant breeds. So this is a maintenance diet for adults. The key feature is optimal zinc, omega-3 and 6 for high immunity and cardio health. Energy delivered is 4833 kilocalorie per kg on dry matter basis. Now we come to the performance diet, which is for the active dogs, active working, lactating and pregnant bitches. Here we have 89% of high quality fresh animal source ingredients with vegetable, fruits, herbs, botanicals and probiotics. So this is formulated for high energy requirement, any pet who has a very high energy requirement. So energy delivered is like 5067 kilocalorie per kg on dry matter basis. Energy here is delivered through fat, which ensures that the retention of muscle mass in case of high intensity activities. This range is coming up, which we call the supportive range. So it offers support for therapy or treatment. And we'll be having different ranges like for renal support, for pancreatic and gut support, diabetic, oncology, and itchy skin or allergy. So this is going to be launched by the end of 2023, and this is going to be a very beneficial product for the whole pet industry. And because this is coming from, all the diet is coming from the natural sources. This is a separate range we call the Natural Blend series. It is a complementary meal. So 95% of Indian population they are used to and feel comfortable with the fact like they prepare their own, they like to prepare their own meals, like the home cooked meals for the pets. So keeping that in mind, we have come up with this range of complementary meal, which is designed to be paired with home cooked meals and to be made into a complete and balanced diet. So energy delivered here is 5300 kilocalorie per kg on dry matter basis. So this is the complementary meal. So this is for adult maintenance basically. And here 87% of the ingredients come from animal sources with fruits and vegetables. Now we come to the wellness product range, which is a specialized probiotic range of wellness products. Here we have internal hygiene, probiotic supplements and external hygiene. In internal hygiene we have products like grooming butter, shampoo bar, liquid shampoo, coat cleanser, etc. And in probiotic supplement we have this for gut support, and external hygiene we have products like kennel wash and floor cleaners. This again is coming very soon. This is a complete and balanced range of senior food, meant for senior food. It has 65% ingredients coming in from animal sources and fruits, vegetables, etc. So this is meant for senior food, and the highlight is that it has low phosphorus levels, which takes care that no extra stress is there on the kidneys, plus optimal zinc levels and omega-3 levels, etc. So another product is a Boost Up, which is a meal topper. So the meal topper is basically intended to increase the nutrition value of any home cooked food or kibbles, and also it enhances the taste. So for finicky eaters also it is going to be a big help. So yeah, this is all, and I request now Mr. Dhanu Roy, our founder, to come and take over the stage.
I'll just quickly run you through, how our product stacks up vis-a-vis other formats of food that's available in the market today. And we look at the parameters against where we're going to benchmark. So if you look at a dry kibble is never going to be species and biologically appropriate, simply because it requires a binder, and it requires simply because it requires a binder, it can never be species and biologically appropriate. While we might have some brands which say they're biologically appropriate, the process of making that kibble itself denatures the underlying characteristics of the ingredients. That makes it a different product at the end of the process. What we talk about when we look at fresh and minimally processed is that when the processing, which is a kind of preservation, when that job is done, the product is as close to its natural state. The ingredients should reflect something which is very similar to its natural state. Which is why for us the acid test is, when I pour back the water that I remove during the preservation, how close to the underlying ingredients do I get? The acid test there is again very simple. If I can find the chlorophyll in the spinaches that I use, if I can find the blue pigments of the blueberries that I am using, or the cranberries that are there, then that shows that the product really hasn't changed a lot. It has still retained itself. Now here's another very interesting thing. Have any one of you tasted a kibble? When you pop it in your mouth, what it smells and what it eats and what you feel inside is totally different. Now here is where the dog's sense of smell comes in. Dogs have an amazing sense of smell, and as veterinarians you know it. They judge distance, direction by a sense of smell. They cannot see very much, which means that they are able to sense what flavor hits them next right now at this point. Which is why when you open our pouch, you will not get a smell like that of a dry kibble, because we don't add palatants, because the dog's sense of smell can sense the various flavors that go into it. Now, Samir and I often eat our food, put it in our mouth to see how it flavors, see how much it changes when you put it in your mouth. while we don't recommend that this is meant for human food, because we use human grade, we eat our food once in a while to see how it tastes. The first thing that you would get as a hint is eggs. Then you would get a hint of fish, and then you would get a hint of the chicken that's coming in. So it's 3 layers, which is why 9 out of 10 dogs that we introduce the food to at initial stage accept the food. 9 out of 10, which I think is actually a very good number, considering dogs might not have eaten something that looks like a dry piece of mat. The moment you add water in 3 minutes at around, let's say, I normally have a test which is, I put it in the microwave for 30 seconds, and that warmth is enough to rehydrate it in 3 minutes to a fresh food. That's the parameter which we talk about when we look at minimal processing. So that's number 1 in terms of processing. Number 2, species and biologically appropriate. Grass is great for a cow. Grass can be broken down into cellulose, but does that mean that the newspaper that I read in the morning can be used to feed a cow? May not be the best way to interpret that, because that is cellulose too. That is exactly a great example of species and biologically appropriate, because now cellulose, which is otherwise found in grass, cannot be used to say that I can feed a cow a lot of newspaper. Doesn't work. Where's my screen? Okay. So the idea of it being species and biologically appropriate means that we use a lot of organ meat besides the muscle fibers and fermented fibers. So we don't say no to carbohydrates, but we say no to starchy vegetables. So we use a lot of fermented fibers, which is approximately about 13% of our food for our maintenance diet. And those come from fruits, thank you. What's the next? Yeah, so the next parameter we're talking about is FEDIAF or AFCO or any international agency compliant. Now here is where the kibble industry does it really well. There's not a single kibble that you would find which is complete and balanced that does not meet, at least chemically, the requirements as laid down by these guidelines. Now many of the home cooked, fresh, raw, kind of retort packed products that are there today don't really comply to anything. They may be great from the dogs from a palatability perspective, but they don't really comply to anything, and nor do they disclose that. That is where we are a bit different, because we are the only guys in India today who actually have this, and we keep getting it audited by Charlie and team every 3 months. The last point that we speak about, yeah, on pathogens. So pathogens actually, in kibble most of the time they say they rely on the temperatures and say that okay, we're going to destroy everything because of the temperatures. But the more fresh or natural food you go to, the problem of pathogens to exist. So we have a 3-stage pathogen control. We use some things called as bacteriophages. Bacteriophages are introduced during the process. They work very well in the kind of processing that we have, because in the processing that we do, we start our processing at -20 degrees. So we don't start with our ingredients at room temperature. Our ingredients go into processing at -20 degrees, and by the time they go into the preservation room, it's around 10 degrees. So the temperatures are working at these ranges, and this is where bacteriophages plays in very well, because bacteriophages plays up to a temperature of 55 degrees. So while in the preservation room, the phages would constantly multiply, keep taking care of the E. coli, Salmonella, Listeria, and all those other strains. So we get that from one of 2 companies, and our sources are from Netherlands for that. For cross-contamination, we take care of with UV treatment. So once the product is out of the preservation room, before it goes into packaging, we have a UV treatment. But before it comes out of the preservation room, there is a 15-minute hold period at a particular temperature to make sure that there is pathogens which are there which are destroyed. So once out of the preservation room, cross-contamination we take care of, which is on the surface by UV treatment. Ease of handling, of course, we'd really love a product that's as convenient as kibble, and which is why our dry meat flakes in the form that they are as convenient, and the format is versatile. You could feed it dry, moist, or as a natural food in the same format. And the availability for us in our current format is actually pan-India. So while we're rolling out in the south now, our ambition is to go into the west in this coming quarter, and then toward the rest of the country. We also like to say a few nice things about what we do, which are unspoken. 100% of our manufacturing staff are women from the tribal areas of Anaikatti area. 100%. They are trained by us, and why we empower them is because they are the ones who actually, and many of you all who have actually been part of this outpost in this area would know that the women actually drive the economies and the culture in each of these homes. So we employ 100% of our women in our factory forces, and our idea is to make it sustainable. For example, we use 30% of the electricity that a dry kibble industry uses, because our machines are energy efficient. So we want to be 100% sustainable in every aspect that we do, and we want to be proudly Indian for the rest of the world. Because in 2013, a very large company asked me to take up the distribution for India, and they told me that, I said, why don't you put up a plant? They said, you can't make good product in India, which I think is a complete misrepresentation of what India can do. And that was one of the tipping points to decide to make a really good product in India, which is truly next gen. What you're doing is 1960s. Let's come back to something that's invented in the 2000s, and let's take that to make a new kind of product which the world could enjoy. Thank you so much.
And now we have come to the felicitations. I request all the EC members to be ready. First, I request Dr. Yathiraj to come to the stage, sir. I request Dr. Venkatesh, our president of Sapac, to honor him with a shawl. No, sir, it's all shawl. Dr. Venkatesh will honor him with a shawl. Dr. Suresh will give him Dr. Suresh will garland him. Dr. JP sir will give him a memento. Give him a big hand. Now I request Dr. Charlotte Gray to come to the stage. Dr. Uma Maheshwari will honor him with her shawl. Dr. Jennifer will garland him. Dr. Senapati will give him a memento. Dr. Senapati. Dr. Gray, come to the stage. Dr. Uma Maheshwari will honor her with a shawl. I request Dr. Nagarajan to come to the stage, sir. Dr. Kanniappan will honor him with a shawl. Dr. Ramurthy will garland him. And Dr. SS, our Vice President, will give him a memento. Dr. Kanniappan. Dr. Chandra. I request Dr. Jayaprakash to come to the stage, sir. Dr. Siranjeevi will honor him with a shawl. Dr. Vairavasamy will garland him, and Dr. Ramachandran will give the memento. I request Dr. Pushkin Raj to come to the stage. Dr. Pushkin Raj. I request Dr. Vinod Kumar. Dr. Vinod Kumar will be honored by Dr. Subramaniam by the shawl, Dr. Jairaj by garland, and memento will be given by Dr. Subramaniam. Dr. Jairaj. And Dr. Suresh will honor him with a memento. Request Dr. Pushkin Raj to come to the stage. He will be honored with the shawl by Dr. Pandian. Dr. Swaminathan. Dr. Siranjeevi will honor him with a garland. Dr. Ramurthy. Dr. Ramurthy will honor him with a memento. And now, felicitations for these sponsors. I request Mr. Dhanurai to come to the stage, and Dr. Samir. Dr. Dhanurai will be honored with a shawl by Dr. Jagadisan. Dr. Jagadisan. Mr. Samir will be honored by Dr. Sri Kumar. Sky Easy. Mr. Sky Easy, Jarin, will be honored with a shawl by Dr. Kanniyappan. RV Drugs. Will be honored with a shawl by Dr. Suresh. Dr. Gautam. Dr. Chand, Dr. Gautam from Mutt. Okay, now we are breaking for a quick tea. We are back again in 10 minutes for Dr. Nagarajan's session. And I request you all to check out. I think you would have done. I request all to come into the.
ஆரம்பிச்சாச்சுன்னா உள்ளே வந்துடுவாங்க. ஏன்னா ஒரு பாதி பேர் வந்து கிளம்புற மோடுக்கு போயிட்டாங்க, கொஞ்சம் பேர் வந்து செக்இன்னு போயிட்டாங்க. இப்போ வந்துடுவாங்க.
I request all to be seated. Professor Nagarajan doesn't need an introduction. He is known pan-India and he is going to give us a lecture on feline dermatology. I think he will finish it off very quickly and we have 2 more sessions also. I request Dr. Nagarajan to start this session.
Thank you. See, today, big day. No. So, good afternoon to everyone. Everyone is ready or still in the hanging mood? Where? So long lectures, full meals, full breakfast, hangover. That's why meow also hangover. So somehow we have to come up. So today we are going to discuss about the feline dermatology. That is actually it is not possible to cover everything in 1 hour lecture. So I thought we can just give some tips for you to follow in your practice. That is very, very important. Because the dog, dog practice was there just a few years back. We started having more cats in the clinic. So now you know very well, whatever the thing, dog or cat, we have the prime, as Dr. Etiraj was telling, that dermatology is the number one cases what we are facing in the field. So it is very, very important. It looks simple, but it is very difficult, because we will be thinking that with chlorpheniramine maleate and dexamethasone or prednisolone itself we will solve the problem. That is the end for the dermatology. Like that we will be thinking. It is not like that. So we have got very many things to learn about it and understand about it. Particularly in cat, it is not a small dog. That you should remember. That is a very, very important thing you have to remember. So the cat is not a small dog. So that is the very important thing you have to remember before going for examining or before going for treating the case. So it is very important to have this. So in India, common dermatological problems in feline means we have got what are all the common things you can expect? Can you tell me? What is the commonest problem? Sir. The first one is parasites, isn't it? The parasites, it is the very dominating thing in any dog or cat. See, some more than 50% of the cases in dermatology are related to parasites. So if you are good in parasitology, or if you are going to be very good in attending what is what and how to cure, you can easily succeed in your practice. So it is very, very important to go for identifying the parasites. That is a very, very, very important thing. That's why I always tell to our students, first you do the skin scraping. So the skin scraping will give a lot of information. So at least you can rule out. See, in case of cat, not only skin scraping, what are all the other things to know the parasite? Tape impression, comb. See the brushing of the hair. So you can collect in the paper and see under microscope. Just put it in the slide and see under microscope with the mineral oil. Particularly fomites are nowadays becoming more and more, isn't it? Then what else you can see with the ear swab. So these things are very, very important in identifying the parasite. So these things you have to follow. It is very, very important for our practice. Next one, fungus. See, all the dermatophytosis happening in cat than in dog. So that you have to remember. Particularly in case of cat houses, or in where you are seeing lot of kittens or anything which is going to be crowded, you can expect to have this kind of fungal infection. That is also one another important thing, and it is both, many times it will be zoonotic. So it is very, very important to take care of ourselves, take care of owner, and also for the animal. The third one is allergy. See, here it is very, very important to understand it is not like a dog. So the dog, if it is going to be a flea allergy, means flea allergy. Whereas, and it can have a combination, whereas here it will be mixture of everything. So it is very important to rule out one by one. So any allergy, say the feline allergic dermatosis, like that they coined the name. So it is very important to identify each problem by exclusion. That is a very, very important thing. Step by step you have to do. First you rule out the parasites, then you rule out all the thing. See, the parasite means a flea allergy. So you can go for treating it and rule out that. Then food trial. Then you go for environmental allergy. So because all these things will be in a combination and they will show the same symptom. So that is the difference between the dog and cat. So skin disease in cat, what is the importance here? So here mostly clue with a reaction pattern. So the reaction pattern, how it is having reaction, say excoriation, or it is going to be a the miliary dermatitis, see the head and neck lesions, or symmetrical alopecia. So like that we have got eosinophilic granuloma complex. So the miliary dermatitis, symmetrical alopecia, or this eosinophilic granuloma complex, or head and neck pruritus, all these things are reaction pattern. So this reaction pattern will give you a clue, but very importantly you have to remember that unfortunately be associated to several causes. So you cannot dictate, so once you are going to see that, immediately you cannot jump into a conclusion it is having this problem like that, because underlying cause is many. Only the reaction pattern will be there, then never pathognomonic. See the presentation, whatever form, it is not at all going to be a pathognomonic for particular disease. Say for example, eosinophilic granuloma, if you take, it is not pathognomonic for any allergy or any parasite. It can be due to parasite, it can be due to allergy causes. So it can be a food allergy, it can be an atopy, or it can be a parasite. So it is very, very important to remember that any reaction pattern, it is not going to be a pathognomonic in particular disease. So then what? So the distribution pattern, that is very important. So the distribution pattern, the localization of the changes is more important. So the distribution pattern means, say for example, in cat you have a paraneoplastic syndrome. You might have heard about this. Paraneoplastic syndrome. That means the skin will have lesions, but the skin lesion is not due to parasite or anything. Whatever the tumor inside the animal body, they produce certain substances, humoral substances. It may be a hormonal or hormonal like substances. They stimulate the cells in the skin and they produce the thing. But it is not going to have, suppose you are going to take a biopsy and see, skin biopsy, it may not be giving you the neoplastic cells, but the reaction pattern will be there. So once it is going to have the problem, so in that, say for example here what I told you is distribution pattern. The localization of the changes is more important than the lesion. So the lesion in the paraneoplastic cell is shiny alopecia. Shiny alopecia, that will be pink in color. You can see the shining. So if it is going to be in the chin, then it is mostly of thymoma or any lung tumor or anything. If it is going to be in the ventral abdomen, it is more of abdominal tumors. See, most commonly what we are having as a paraneoplastic syndrome is cholangiocarcinoma or liver carcinoma, pancreatic carcinoma. All these things are very common. So in those cases you can see the abdominal shiny alopecia. So that is the difference. So if it is going to be the chin, it will be thymoma. Like that we should know the distribution pattern. That is very, very important. So that is very important in the cat. So it is very difficult to diagnose because they have the behavior of grooming. So it is normally cat will groom themselves. If it is going to be an excessive grooming, then comes the problem. Okay. So the normal grooming is the normal habit of a cat. So it is difficult to identify, say for example, if it is going to be a normal grooming, we have to find out whether it is over grooming or normal grooming. That is very important. It is difficult. then response to treatment trial may support the diagnosis. So, if you are going to have a treatment, say suppose atopy, so if it is going, so it is not there. Why you are having this problem all the time? ಅಲ್ಲಲ್ಲಿ ಆಯ್ತು. So, here the response to the treatment trial may support the diagnosis. Say for example, if it is going to be an atopy, if you are going to give a steroid, immediately it will respond. So, you can have an idea. So, like that, like what we are doing in case of thyroid, thyroid trial, treatment trial, if you give it is going to improve, we are considering it as the clinical signs will get reduced. So, the activity level will be vary and other thing will be coming back. So, like that. So, allergies have not yet been well defined in cats, that you have to remember. So, unlike in dog, here it is not well defined. So, all will be in a mixer, all will be having overlapping each other. That is why it is very, very important to rule out the allergic causes as exclusion. That is a very important. One by one you have to exclude. That is a very important thing. Say, as I told you, not as site specific as in dog. Say for example, in case of flea allergy in dog means what you say? Where it will be? Lumbosacral, isn't it? So, whereas we cannot completely have that thing in case of cat. So, it can be a different causes. Like that, one example is abdominal licking. So, the abdominal licking, it can be due to flea allergy, or it can be due to food allergy, or it can be due to atopic dermatitis, or even it can be due to psychogenic. So, it is very, very important to rule out one by one. So, likewise, we have got another example, linear granuloma. You can very well see this linear type of granuloma, this red thing line like this, that is a eosinophilic granuloma. So, in eosinophilic granuloma also, it can be of food allergy, it can be of even hereditary, or it can be of, as doctor was telling, idiopathic. So, it can be of idiopathic. So, it is very, very important to recognize that. Then scratching of the neck, here also it is not as site specific as in case of dog. So, here it can be a flea allergy as well as food allergy. So, not only that, we can also have head and neck pruritus because of hypersensitivity disorders like flea, food and environment. Apart from that, viral dermatosis. What are all the common viral dermatosis? Herpes. See, in young kitten, you used to have the conjunctivitis. So, because of that, they will scratch, irritation. So, there is chance for getting that calcivirus, pox virus, FELV. So, all these things are going to be the reason for head and neck pruritus. So, the head and neck, not only that, ectoparasites. So, as I told you, the ear mites will be having severe itching. So, the ectoparasites, even the notoderus or even any skin, any parasite can create head and neck pruritus. So, the lesions can be appreciated in the area. So, head and neck, not only the ectoparasite like Demodex, Artodactic, notoderus, It is also due to skin tumor like squamous cell carcinoma. There is chance for getting. So, it is very, very important to identify what is the actual problem, because it is having a mixture of causes. So, it is one by one you have to rule out. First, you should know it is having a mixture of causes. Then only we can go what are all the possibility if it is going to have a head and neck. So, that will give a clue. So, these are all the list, one by one you rule out, like a skin tumor means take a biopsy or fine needle aspiration. If it is going to be a parasite, you take a scraping, or if it is going to be a viral disease, you go for that ELISA test, all those things. So, of course, you will be having other symptoms. Say for example, herpes virus means conjunctivitis definitely will be there. So, you can correlate those things. Then face and feet. So, it is also getting affected in certain cases. Most common is pemphigus. In pemphigus, you will be having the foot involvement. See, apart from that, dermatophyte involvement. See, whenever the case is going to be having changes in the face and feet, immediately you have to think of fungus, the Microsporum trichophyton, most of the time. Even though majority of the time they will be restricted to neck and head. See, lot of other fungal infections, they will be going to foot. So, that is very, very important. And apart from that, autoimmune disease conditions like lupus, pemphigus, all these things are definitely going to involve with the foot. You might have seen lot of cases with the hyperkeratosis of the foot. So, what are all the lesions which will give a clue for our diagnosis? Say, it is not like a dog, pustules, bullae, vesicles in cat is rare. So, these thing will be rare. So, the pustules are very specific for pemphigus foliaceus. When the cat is going to have a pus, you have to think of pemphigus foliaceus and see, in that only you will be having more of a pus in that. Then alopecia, or you can have a pyoderma, but it will be very rare when compared to dog. See, whatever the case, in case of dog you will be having full of pyoderma. Like that here, alopecia, crust, excoriation and erosions, these are all the commonest presentation you can expect in the cat. So, that is very, very important. So, alopecia, crust, excoriation means self-mutilation and erosions. All these things are very common. It is because of pruritus. So, when the animal is going to have a self-mutilation, it can expect to have all these lesions. So, to understand better, because of time restriction, I thought I can go ahead with, I can make you to meet my patients. So, these patients are my patients. One is Sarah, another one is Boss, then Prince and Ginger. So, they have some typical symptoms and lesions. We will see one by one. The first case is Prince. It is a 4-year-old male. So, the posterior half of the body excessive licking, that is the history. So, it started simply, it was so good before, all of a sudden it developed a excessive licking at the posterior half and progressive hair loss. Day by day the loss of hair is going to be more and more. That was the worried history from the owner. Then interestingly, there is no loss in the tail. Tail was very good. Okay. And she also told that there are a lot of dogs and cat in the house. In the house environment, it is very rich in animals. And also it is having a very good appetite. So, there is no systemic involvement. We can guess from the history like this. So, what are all the things we can expect? Flea allergy and food allergy. See, the flea allergy you can very well have because it is where? Lumbosacral. Definitely we have to rule out that. Then food allergy, it is possible because a lot of that licking habit will be there all over the area, particularly in the posterior in case of cat. Then feline atopy, in that also you will be having very great thing. So, for flea allergy we can rule out by putting spot on or a like any broad line or anything you can apply and see how it is the response, salamectin. Then food allergy, go for a dietary trial with the help of duck meat or anything, because here you have to know that fish is not the hypoallergenic for cat, whereas for dog it is a hypoallergenic. Okay. So, here we have to go for a duck meat or pork meat. That is the important thing you should remember. So, you can suggest the people to go for a duck meat. So, that is the thing. So, that has to be done for 5 weeks. So, in that if it is going to be all right, we can very well say it is a food allergy like that. Then atopy, whenever it is going to have, what is the good response for the atopy? Whenever you are going to give a steroid, immediately it responds well. So, that means it is an atopy, we can go ahead with the proper appreciation. Then parasites. So, as I told you, it can be of flea or even internal parasite or anything, that has to be ruled out. Then dermatophytes. So, that has to be ruled out by taking a culture or wood slamp or even direct examination. All these things will give an idea about that. So, Telegon deflection. What is Telegon deflection? It is a, see, whenever animal is presented to you with a history of loss of hair, they will say recently whelped. So, when the immediate the lactation or pregnancy, lactation, or even some will say it is under chemo, like that, in those cases you know very well the loss of hair will be there. You can very well see that Telegon deflection with the history, that is very, very important. And in that, if you are going to do a trichogram, you can see the shaft of the hair will get broken. And also you have to have a thorough history. So, once you are going to clear the history, it will be all right. That is a very important thing. Then hyperthyroidism, that is also one another important thing, wherein you can expect to have the posterior loss of hair. So, they will pull out the hair in the hyperthyroidism. Say in case of cat, hyperthyroid is very important, whereas in case of dog it is not so important. Hypothyroidism is so prominent in case of dog. Hyperthyroidism is so prominent in case of cat, where when you can expect to have mostly in the middle and old age. Old age is the very important thing you can expect. In that you can expect to have the pulling of the hair from the posterior aspect. So, that is also we have to rule out, that is a very important thing. Then as I told you, paraneoplastic syndrome. So, whenever there is a tumor inside the abdomen, whenever there is a tumor in the body, they produce lot of chemicals. So, the humoral bodies that can be of hormonal or hormonal like substances which are being produced to make the skin to have the alopecia, which is shiny. From that we can easily identify that. For that we have to go for imaging and other thing. Then the psychogenic. Sometime we have to think of psychogenic also in case of cat, that is very, very important. So, here psychogenic, how you can identify as a psychogenic? How, what is the reason to have a psychogenic? Stress. See, whenever you have problem with your wife, what you will do? Smoke. Some of us say, I will go and eat full. That's why I am having tummy like this. So, that means no, don't think I am having frequent fight. It is not like actually each and everyone will have their own way of expressing the or solving the problem. So, like that cat also will go for solving the problem by pulling out the hair at the back. Say licking, excessive licking. So, that is a very important psychogenic alopecia reason. So, that is a very important thing. That is, see, whenever there is a continued excessive stress, what are all the continued excessive stress? What could be the thing? It can be of overcrowding, it can be of or anything, any new person coming to the house, or any fight between the cat, they are going out of house. See, when I came to Anaikatti, one fellow called from Chennai. He told that, sir, I have got a cat, so I want you to consult. What is the problem? He told, I heard that you are good in dermatology, so Dr. Lakshmi from Hyderabad is my friend. She asked me to contact you. Like that he was telling. Then when I asked, he was telling, just a few days back it had a very bad fight with the, he used to go out, so they had a very bad fight. So after, to heal the wound itself, we made all the e-collar and we tried so many times, and after 2 or 3 weeks only the wound has healed. See, after that, see, when we removed that, it is not, it is always moody, and it started having lesions around the leg. See, the lesions around the leg means it is reachable for the mouth. So the lesions which are making by the self mutilation, it is reachable. That is very important characteristic in this. So the psychogenic alopecia will be presented as a reachable for mouth or tongue, so that it will reach the area, say either back or hind leg. They used to do that. So that is the thing. The alopecia without inflammation of the skin, that is also very important. In the early stages, there won't be any inflammation because it will lick. But if it is going to be constantly leaking, what will happen? It will again go for eosinophilic plaques and pyoderma. So because of the self mutilation, as you are seeing in acrylic dermatitis in dog, used to have a circular hairless patch with the pyoderma. So likewise here it will have a pyoderma. There is chance in the later stage. In the early stage you may not be having the issue. So what are all the clinical signs you can expect in this psychogenic alopecia? So the multi-cat household, that is a very important history what we had from this. So the multi-cat household, that is the very important history. And indoor cats, all the time, the lady was telling it is always indoor, they won't go out. How can it develop like this? Then we thought we have tried already under hypoallergenic, like that she was telling. And we have ruled out all the parasites. Then I thought of going for a steroid. It was not responding. They said it is more. It is not at all improving, like that. Then we have finally see that it has got a psychogenic. So that is very important. The history is so important, particularly when the breed is going to be Siamese or any tropical breed. If it is going to be a oriental breeds, there is more possibility to have this particular psychogenic alopecia. So here very important thing is, if it is going to be a conflict, fight between each dominance fight. So the conflict can create stress, or anxiety can create stress. Then frustrations. See the cats with the calves. So you can remember like that. Cats with the calves can develop this kind of psychogenic alopecia. See the frustration, stress, all these things are factors. So the hairs pulled out entirely or broken off. See, if you are going to see a trichogram in that, definitely it will have a broken hair. So that is the idea, good idea to have a suspicion with all this history. So this is the thing, a cat, you can see the anxiety over the face. It is maybe because of the clinic, and you can see the loss of hair in the posterior half. See the broken hair. You can very well see the broken hair. The tip is not sharp. The broken hair you can easily see under trichogram. So the case may be presented like this also. See the psychogenic alopecia, common areas what you can see is, it is another case of mine. The caudal abdomen, you can expect to have the loss of hair there. Then medial thighs, see you can see the medial thighs which are having alopecia. Then inguinal regions, then dorsolumbar regions. So not necessarily all the dogs should have the same pattern, it can be like this also. So it is very, very important to recognize once it is going to have a caudal abdomen, medial thighs, inguinal and dorsolumbar, you have to add in your differential diagnosis psychogenic alopecia also. That's a very important thing. See, uncommon area, forelimbs. So, majority of the cases they won't lick forelimbs. That's why very rarely you can have in forelimb also. So, as I told you, differential diagnosis, ectoparasite means we have to rule out all the fleas, chilatilla by combing, and octodectes by ear swab, lice, demodex, everything. By way of skin scraping, combing, ear swab examination. Then the allergic dermatitis means flea, food and atopy. As I told you, you can go for treatment, dietary trial or steroid trial. The third one is dermatopytosis. As I told you, you have to go for Woods lamp. That's a very easy way. And if you still suspect, you can go for culture by way of toothbrush technique. So the telogen deflection, as I told you, you can see the broken shaft in the trichoscopy. You can very well see that. Then hyperthyroidism, you can very well appreciate by elevation of total T4 and also the old age dog, old age cat. That is a very important clue. Then paraneoplastic alopecia, you can very well appreciate by imaging like X-ray, abdominal ultrasound or biopsy, you can confirm it. So this is the hypothyroidism case wherein it is pulling out the hair in the abdominal area. So the excessive in the middle age to older cats. So weight loss will be there, that's a prominent symptom. So in case of psychogenic alopecia, weight loss will not be there. It will eat nicely. And the increased water consumption, urination, increased activity, the voice, vocalization will be very more. See, it is very prominent. So that is commonly seen in hyperthyroidism case. Hyperthyroidism case will have increased vocalization. Owner will be complaining that it is going on vocalizing. So you have to see if it is going to be having other symptoms like polyuria, polydipsia and loss of weight. And if it is going to be a older or middle-aged cat, you can very well think of going for this. And a poor hair coat and hair loss. So changes in the grooming habit can include not grooming or excessive grooming inducing pulling of fur out of the body. So that is also one another important differential diagnosis in psychogenic alopecia. As I told you, paraneoplastic alopecia symptom also will lose weight. So no signs of excessive grooming, sometimes easily epilated. So if you are going to touch, immediately the hair will come out. That's a very classical thing. And as I told you, the shiny alopecia, that is also one another important thing. So this is easily epilated by gentle tugging. So you can expect to have this kind of paraneoplastic alopecia. So the environmental stresses for the cat, what are all the environmental stresses? So limited access to the important resources such as food. So in one room, you should not make it, say what we usually give our most of our clients, in one plate they will feed for all the cats. They will develop psychogenic. So each cat should have a separate food bowl, and also they should have a litter box, separate litter box. That is a very important thing. Water also, and they should have perches, so they can climb and do the activities. Moving into a new home, that is also can create the problem. So moving into a new home, different environment, change in the household routines or family members, that is also can create an isolation. So if you are for any reason, as I told you that owner was telling, it was kept inside, it was always roaming around, all of a sudden it was kept inside, that fellow who called me. So I told it is a psychogenic because all of a sudden you kept inside, it was a roaming cat, now you are not even allowing because it will have fight like that. So that is a very important, isolation is a very important thing, forcefully isolating the thing. The status or territorial conflicts with other cats, that is the thing. Then overcrowding, bored and not getting enough exercise. So, that is the very important reasons to have the stress and psychogenic alopecia in cat. So, how to go for it? Treatment. So, it is very, very important to go for keeping different feed, bowl or even the litter and perches. They have to climb and see in the top, and they can go and see the activities, and they can have the play area. Like that, they identify the stressors, first work to prevent the cause, desensitization and counter conditioning program, that is very, very important. Teach positive association with the distress causes. What is the cause? You have to find out. That is the duty of us. Then cats needs are effectively met in more than one. So, because overcrowding or more than 2 cats are there, there is always chance for getting dominance, aggression or fight between them, or that is the main reason. So, you have to find out with the history. Then increased activity level, play, cat perches and hiding food toys. So, the toys with the food, you can keep the food in the toys and they can play and engage. So, you make it engage, and play sessions you can make. Like that, we can correct the problem. Provide a predictable daily routine and sleep areas that are there alone. So, that is a very, very important thing. Then what is the treatment aspect? See, in the treatment, very important is behavioral modification and providing the environment conducive for improving the health. Apart from that, immediately you cannot bring it, it will take time. So, we have to go for behavioral modification, particularly with these psychotropic drugs. So, psychotropic drug what we commonly use is fluoxetine. So, the fluoxetine or amitriptyline, clomipramine, in that fluoxetine is widely used all over the world very commonly, but we should understand that whenever you are going to have drug interaction, we have to think of that. Say for any reason you are going to give a cephalexin, it will not have action. Likewise, whenever you are going to use butorphanol or anything, and it will go for serotonin effect and it will sleep more. So, you have to consider while selecting a drug for any other reason while giving this fluoxetine. So, the fluoxetine is so important. So, it is even atropine can go for a QT interval prolongation of risk of QT interval prolongation. So, you have to very much careful by knowing the interaction between the drugs before using that while it is under fluoxetine. That is very important. So, the monitoring and prognosis much depend on how much you can address the cat's source of stress. That is very important. Whatever can be done to reduce the stress should help make the cat feel at least a bit better, even if it is not enough to entirely stop the self trauma from the continuing. So, these are all the cat play things are available with the feather tip or even the fish tip bars. So, you can very well appreciate that they will have a very good diversion and distraction. So, we can easily correct them. The second case is a ginger male, 3 months, it has got a hair loss, pruritus, companion and owners are affected. That is the this is the cat. So, here it is a dermatophyte we have identified with the wood slab. So, for dermatophytosis to develop, skin stroma is required or any area will be wet, and if it is unhygienic, there is chance for getting it. Most commonly it is in the group cat you can expect, and more than the individual cat owners, you will be having more of group. Then very important to check whether it has got culture negative, 2 consecutive culture negative before stopping the treatment. That is very important. Sometimes clinically it won't be there, but if you take for a culture, it will be positive. So, it is a zoonotic. We can have like this lesions in the human and like this round lesions. So, it is very important. So, the group cat, particularly in young kitten, you can expect to have this. It is a predominantly seen in young kitten. So, we have done a study in some 500 cats, 530 cats. In that we have identified 60 cats are having the dermatophytes. So in that we have done a study, it was showing hair loss, pruritus, and other cats also affected as a predominant history. And in the clinical sign, we have seen the crust, scales, and circular alopecia, and also the generalized rather than the localized, it was generalized. And also we have got a cervicofacial dermatitis, that is the commonest thing. Here we have not seen on the foot, we have seen not in the majority of the cases, but we have seen in the cervicofacial area, that is the commonest thing. So this is the cat, we have seen one case, so often attacks or often affects the kitten. So kittens are most commonly affected, and also there is possibility to pick up by the geriatric patients, and also immunocompromised. So these things you have to remember in case of any fungal. Even for us old people used to get more fungus if any problem, immunocompromised. Even in corona you might have seen lot of presentations. So the dermatopytosis, if it is going to be overcrowded or unhygienic, or infected hair is going to get exposed, or fomites are going to get exposed, or even spores in the soil, or even the environment. That's why we have to decontaminate the area very seriously. That is very, very important. So wood lamp examination, the room needs to be darkened. That is very important. And use a plug-in long wave wood lamp with a magnification. But generally they used to say we have to wait for heating. But lot of dermatologists say wood lamp do not need to time for warming up. So ready to use. Hold the lamp close to the skin, that is 4 to 10 centimeter, and you can expect to have like this positive hair fluorescence brightly in the apple green and blue green. That is the commonest thing. But there are negative fluorescence which is commonly seen by dust and dander. So those things are with a white and a blue-white color. So that is a very important difference you have to see. So that is a medication and oils on the hair coat, they can also fluoresce, particularly the pivotoniodine. Those things will be having a very good this thing. Then orange carpet fibers also fluoresce, even sometime apple green. So like this, the ultraviolet light wavelength is going to be 270 nanometer filter through cobalt nickel filter. That is the one which will make the MKNs to fluoresce. But not all the species of, not all the MKNs will fluoresce. Only certain species are going to fluoresce, not all the strains. So that you should have. So this is the fungal culture with the MKNs, you can see. That is the brush technique. So this is the direct examination by which you can even take out the thing and see under a microscope. So if you put a mineral oil and even mix with the Parker ink, whatever you have, Brill ink or whatever ink, just to put a drop, you can see the spores like this, the sharp ectothrics. So that is a very easy method to identify. If you don't have anything, you can just take a drop of ink. First plug the hair and put in the mineral oil in the slide. You put the hair, along with that you put a drop of Parker ink or methylene blue or lactophenol blue, anything you can do and see under like that. There you can see the thinning of the hair, and the pale hair will be in a different style. So this is the macrogonidia of MKNs. We can expect to have more than 5 cells, 5 to 15 cells in this, whereas in case of other you will be having less. So 3 only. Here it is 5 to 10. Trichophyton will be looking like this. It is a spiral and it will be grapes like. So the grapes like thing you can see under microscope. And even Nanesia, you can see the number of cells, it is less than 5. So like that PCR also possible to nowadays we have it. The efficacy we have seen, trichogram is highly effective, and fungal culture and fungal PCR. Even though wood lamp is less, it is very, very useful in field practice. Just we can take a thing immediately if you have it. To avoid negativity, you can take out, plug the affected fluorescent hair and put it in a glass slide and again see under Woods lamp. If it is going to fluoresce, definitely you are not making a mistake. It is a dermatophytes. Sometimes you can avoid the other thing, contaminant and other thing like oil or anything. So therapeutic trial we have done. In that we have done with the itraconazole and terbinafine. Itraconazole with the 10 mg per kg body weight single dose and all for 6 weeks. And terbinafine we have given 40 mg in that one, concentration only. It was very much helpful. So you consider this 40 mg, whatever the literature says, we have done the work and we have found a good result in this. 40 mg per kg body weight for 6 weeks, it become completely all right. See, that is the result. That is the 6th week. So before and after the treatment, you can very well see the progress. Cats are treated until they are cured 2 consecutive negative fungal culture. That is a very important thing. Here we call it as a cat's plan. Cat's plan means confinement. You have to confine the affected cat. It should not allow the cat to spread with others. Then cleaning with the shampoo and other thing, antifungal shampoo. So along with the oral, you have to go for antifungal shampoo weekly. Then assessment, how it is improving with the Woods lamp or a fungal culture, you can do that. Then topical and systemic therapy. This is the cat's plan for dermatophytes. So, what? We can give after a week or after even a month, you can go for it. You still suspect, or if the owner is telling skill scratching or anything. See, the diagnosis, the World Association of Veterinary Dermatology, they have given this thing as itraconazole and terbinafine is effective and safe. And there are a recent report we have, the terbinafine can be having a resistant. One report has come, resistance for microsporum canis in cat, they have reported. Dr. Han from Malaysia, he has published recently. So one cat was not responding, it was responding for itraconazole. So the resistance also possible to have with the terbinafine, that is the recent finding. So here twice weekly shampoo bath with the miconazole and chlorhexidine, and Woods lamp and direct examination are good positive and negative predictability. Decontamination is very important. So the limonene oil, that is nothing but Lysol lime, Lysol. So the Lysol will have lime. So that having this limonene oil, or you can go for oxygenated hydrogen peroxide if you have it. This is very easy, Lysol lime. And sodium hypochlorite, as for corona we can use that, but the problem is it is highly irritant. So this will be very easy, Lysol with the lime. It will have the limonene oil. Ketoconazole you should not be given because it is toxic for the cat. Then the case 3 is Sarah, female, ND, 1 year old. See, you can see what you are seeing, tail base excoriation, face dorsal lumbar erythema. So what could be the disease? It is in the lumbosacral area, tail area. What? Flea allergy. So when we took pinna-pedal reflex was there, otitis externa was there. It is nothing but a autodactic. So the autodactic also can give mislead you. So it is very, very important to recognize that. And I had a beautiful video which is given by our friend Venkatesh. I will show you that. Before that, autodactic cyanosis affects kitten and young cats. Occasionally old cats will get affected. Bilateral otitis will be there. Mainly live in the ear canal, highly contagious and in contact animal. Face or other dorsolumbar and tail base areas also affected, that you should remember. So, if it is going to have a tail and a dorso-lumbar area lesion, you should not forget to check the ear. That is also one another important clue. So, dry brown complete exudate you can show. Self-induced alopecia and erosive lesions around the ears, you can very well appreciate that. Tympanic membrane rupture or vestibular signs also can be in severe cases. So, this is the one. So, this is the male female egg. So, here the treatment is spot on 10% imicloprid and 1% moxidectin or selamectin are the important treatment recommendation by evidence based medicine. Yeah, we can use. We can go for safely, we can go for 2 months, we can go for this fluorolanar 2 kg. The third one, the last one is Boss 10-year-old male. The condition persists for years together and treated locally with the various drugs by the local vet. It is not resolved, it is keep on recurring, that is the thing. The symptoms were right hind leg with a reddish plaque like this, and ventral abdomen was having full thick granuloma with linear ulceration. So, the eosinophilic plague very pruritic and well circumscribed. It can be of flea allergy or atopy or food allergy. So, eosinophilic granuloma, it also can affect by many allergic conditions. You can see that granuloma, and you can see the indolent ulcers. This is the indolent ulcer in the upper lip, you can see. That is the indolent ulcer. So, in that also you can expect to have all hypersensitivity reaction. So, how I diagnose this is presence of any 4 major cutaneous hypersensitivity pattern like miliary, eosinophilic here, eosinophilic dermatitis is there, then induced alopecia, head and neck pruritus, cytology, skin scraping, skin biopsy. So, here we have to apply the criteria. So, the criteria is favorite et al criteria, like dog and cat also they have a favorite et al criteria. Here in this case we have got a presence of any 2 body sites affected. Yes, it is affected with the miliary dermatitis and eosinophilic dermatitis, and the presence of any lesions in the lip. Yes, it was having an indolent ulcer. Then absence of lesions in the rump, absence of non-symmetric alopecia in the rump and tail, absence of nodules or tumor. All these things are applied. So, it is definitely more than 76% positive clue for this atopy. So, the investigations what we have done is more of eosinophilic infiltration and flame figures, that is what we have seen in that. So, eosinophilic granuloma complex we can expect to have. In this particular case is very beautiful is all the 3 we had in this case. So, a plaque was there, granuloma was there, indolent ulcers were there. So, there is possibility to have differentials like this. We can have a parasite, food allergy, environmental allergy, everything. But we have to identify by way of steroid trial, that is what I have done. First dietary trial we have given, parasitic prevention trial we have done, antibiotic cefavaxin we have given because it is easy to monitor or manage the cat by single injection 10 days it will cover. So, we always go for this cefavaxin, that is convenia 8 mg per kg once. Then depemetrol methyl prednisolone acetate 5 mg per kg intramuscularly or subcutaneously. Every 2 weeks we have to give 2 weeks. It was having a great response. Along with that cyclosporin we have given. It is 7 mg per kg in cat, not 5 mg as in dog. That has to be given daily for 60 days, then we have to taper. Fatty acids like omega 3, omega 6 has to be given. So, when I give this it was having a great response. So, the etiological therapy with the allergen avoidance we can do if it is possible. Flea and food easy to avoid. House dust, mite, pollen and molds are not easy. So, limiting the cat access to bedrooms, benzoate spray can be applied, and if possible you can go for immunotherapy. So, feline allergic dermatitis treatment generally we go for cyclosporin, methyl prednisolone, oclocetinib. Even nowadays we have apoquil, we can use that. That also give, and marapitant that is recently available now. So, that also if you use 2 mg per kg body weight there is a great response, or even you can focally if it is going to be there you can go for cortisone spray, hydrocortisone acetonate. So, very recently we have come across with this experiments and severe this thing cannabinoid receptors. There is going to be a very effective way of approach in case of cat as well as in dog, but in cat it is so effective that has been found out and it has been presented. So, it is nothing but a hemp seed oil, CPD oil and natural anti-inflammatory lipid. Nowadays we have got various products in the market. We can give 10 mg per kg body weight per oral 24 hours for 30 days. That will improve the pruritus symptoms, and even they have gone for spot on how it will help and other things they are going for it. And this is the report given its safety and improvement by using the hemp seed oil, or that is the recent report. So, the atopy you can expect to have commonly less than 3 years old in case of cat. Eosinophilic granuloma complex can be there, or head and neck pruritus may be there, miliary dermatitis or self-induced alopecia. All these things may be there in any one of them, or a combination of them may be there. Majority of the cases will be with the head, mouth, neck and abdomen trunk. So, we have to go for exclusion diagnosis, allergic contact avoidance, specific targeted treatment, that glucocorticoid, cyclosporin or oclosutinib can be tried, as I told you, hemp seed oil also you can try, and topical hydrocortisone acetonate and essential fatty acids also will be very much helpful. So, that is the end of our thing. Thank you very much for your patient hearing. See, I welcome all of you for our next conference, Indian Association of Veterinary Dermatology we have, and that we have got a very great authors and the global leaders. They are going to come. Dr. Chaira Noli, they are going to give 16 lectures, 8 in cat, 8 in dog. So, I welcome all of you to attend the thing and get more information about dermatology. You can have a very great exposure in that. Thank you one and all. Thank you.
Thank you, Professor Nagarajan. And next we have Dr. K. Vinod Kumar, who is going to talk on differential diagnosis of canine and feline hemoprotozoan diseases. Dr. Vinod Kumar is an assistant professor of preventive medicine in College of Veterinary Medicine, Mannuthi. I request Dr. Vinod Kumar.
Actually, this is a 1 hour presentation, but as it is reduced to 30 minutes, I will try to go only for the important points. Okay. See, hemoparasites are the most important diseases. You can compare that to the prevalence of dermatology. So many cases we are getting hemoparasites of dogs and cats. And there is a lot of confusion also regarding how to treat, what not to treat, how not to use. So many confusions are there. Dr. Venkatesh was telling me, sir, you focus only on the differential diagnosis as well as the treatment. So if you want to refer to the textbooks, the irony is that these 5 are the most important textbooks that we can get freely on the internet. And the interesting thing is that all these 5 textbooks tell 5 different things regarding the treatment of Babesia gibsoni, because you can see that all these books, some of the books say that Babesia canis vogeli. Babesia canis is not there anymore. It is Babesia canis, Babesia rossi, Babesia canis or Babesia vogeli. 3 species it has been differentiated. And in India, we have got only Babesia vogeli. And all these books and so many articles say that Babesia vogeli is benign, non-pathogenic. And you see what we are getting here. Babesia gibsoni, the other one, the second one, it is also supposed to be a benign parasite. And we are losing so many dogs. When you check onto these textbooks, you can see that all their recommendations are based on articles that concern with either 10 or 12 cases. So my first advice to you is that forget these textbooks that are written by the Western authors. Focus only on those articles and books that are written by the Southeast Asian authors or Australian authors, because those are the areas where Babesia gibsoni and Babesia vogeli are creating a lot of havoc. Whereas these people are concerned with mostly the Babesia rossi and maybe Babesia canis. Am I clear? So first thing is that don't refer such things. So we are concerned with 3 parasites in this class. It is very difficult because this is a 3-hour class. It is very difficult for me to confine that knowledge into 30 minutes. So I will be running fast. Flag me down if you want me to, if you don't understand anything. These are the 3 parasites that we are concerned. Babesia canis, or now it is called as Babesia vogeli, Ehrlichia canis and Babesia gibsoni. All these 3 cases will be present in your area. According to the last statistics, 62 to 65% of the dogs in India being brought to the private veterinary clinics are either infected with any one of these 3 parasites. But they may not be having clinical signs because they have got a resident parasitic stage, there is a carrier stage, so many things are there. One word about transmission, Babesia gibsoni can be transmitted through fighting dogs. When a healthy dog bites an infected dog, when a healthy dog bites an infected dog, the healthy dog's teeth come in contact with the blood of the infected dog, and that is now supposed to be the major route of transmission for Babesia gibsoni. Whereas for Ehrlichia canis and Babesia canis, it is the ticks. Am I clear? Okay. Before going into the actual clinical signs, you should understand. Give me 3 minutes for the pathogenesis. That is very, very important. Why? Because Babesia canis or Babesia vogeli is a large pathogen, 8 to 12 microns in size, multiplies fast. Within 15 minutes, it multiplies, doubles. It is capable of destroying the RBC by itself. Very, very important. So it is a pyroplasm-mediated hemolytic anemia. The organism is multiplying very fast. It is capable of destroying the RBC by itself. So it is destroying by the process of its multiplication. It is an organism-mediated hemolytic anemia. Very important because this is always acute, and there is no organ complication. There is no organ impairment. If you are getting an organ impairment for Babesia canis infection, it is only because of as a result of anemia. So Babesia canis destroys the RBC by the process of its own multiplication, acute onset always, there is no carrier stage, and the hemoglobin that is produced as a result of destruction. This destruction is called as intravascular hemolysis because the organism is destroying the RBC within the blood vessels. So this hemoglobin that is produced is channelized to the kidney, to the bladder. That is why you are getting coffee colored urine for Babesia bigemina in cattle, because that is also a large pathogen. But in this case, the canine kidneys are having a larger threshold for containing or for the excretion of hemoglobin, so that only in 20 to 25% of the cases of Babesia canis infection, you will be getting a darker colored urine, and only in 3 to 5 cases coffee colored urine. So, coffee colored urine is not a diagnostic feature of Babesia canis at all. This is important. Okay. Now we go to the next one. These things you know. So the clinical signs are always associated with anemia only. They are always acute. So you will be getting sudden development. Every case of Babesia canis, you will be getting acute onset with pyrexia, acute onset of anorexia. And one more thing, even though the incubation period is 7 to 14 days, within 24 hours of being bitten by a tick with Babesia canis, the blood becomes positive. Your laboratory technician will say it is Babesia canis positive. But the clinical signs may develop only after 5 to 6 days. So every case where you get a Babesia canis as positive in the slide is an indication for treatment. There is no carrier stage. If you get a Babesia canis positive in the blood smear, it is either in the clinical phase or in the incubation stage. There is no convalescence, there is no carrier stage. And here you get acute onset only, and you can see that weak, depressed, these things you know already. I will skip them. This I will skip. Regarding Babesia gibsoni, it is very different. 2 to 3 microns in size, very slowly multiplying. The organism is not capable of destroying the RBC by itself. But the body will not permit the organism to be there on the RBCs. So the body mounts an immune reaction. Body mounts an immune reaction. What happens then? Initially, the body, have you seen the riots where the police and the rioters are facing each other? The rioters throw some stones to the police, they start lathi charging the rioters. Then what happens? They start lathi charging the bystanders. Then they start going into the houses and start lathi charging the other people. This is what happening for the body immune system. Initially, the body immune system destroy. Am I too fast? I am fast, I know, but am I too fast? Okay, initially the immune system destroys the RBCs that are infected with the Babesia gibsoni. Then the system starts destroying normal RBCs on whose surface the gibsoni particles are seen. Then they start destroying even the healthy RBCs which are not at all having any problems. This is a slow process because this is immune mediated hemolytic anemia. The extravascular destruction is not happening within the blood vessels. The RBCs with the infection are being taken to the spleen, to the reticuloendothelial system where they are destroyed. So this is a slow process, and this slow process has got 2 more complications. One, thrombocytopenia. The thrombocytes, the innocent bystanders are killed at random. So you get severe thrombocytopenia. 2, organ impairment. The immune system, after starting to destroy the RBCs, targets the organ parenchymas, the kidneys, the liver, the lungs. So shall I continue? Okay. Okay. So the immune system starts destroying the organ. So every case of Babesia gibsoni, by the time it is presented to you, will be having 3 major parameters. One, it will be anemic. It will be anemic. First thing is that the clinical sign, it will be hyporexia progressing into anorexia. It is never acute. So the owner will come and say, the dog was eating normally, then it started to have reduced food intake, then it started to pick up only on the meat pieces, now it has gone totally anorectic. It is hyporexia progressing into anorexia. The second one is that it will be having thrombocytopenia. Normally it is 2 to 5 lakhs per microliter. It will be around 1 to 2 lakhs or less than 1 lakh it will be. And third one, there is every chance that organ impairment has started. So slow onset, organ impairment is there, thrombocytopenia is there. This is for Babesia gibsoni. So the clinical signs will be, as I said earlier, those things I will skip, I have already told about this. And since the organ impairment is there, since the immune mediated hemolytic anemia is happening, there will always be proliferation of the superficial lymph nodes as well as the spleen. How many of you are good in palpating the spleen? Is anyone palpating? Now you start to learn because that is the most important thing regarding the diagnosis of either Babesia gibsoni or Ehrlichia canis. Start to diagnose, there are so many videos on the YouTube, 3 minutes videos, 5 minutes videos. Start looking at the spleen, start looking at the popliteal lymph node. Lymphadenopathy with splenomegaly, thrombocytopenia, hyporexia progressing into anorexia, anemia. So almost 100% accurate diagnosis of your either Babesia gibsoni or Ehrlichia canis. So check on the spleen, check on the peripheral lymph nodes, and you will be getting a good idea about the immune-mediated hemolytic anemia. And one more important thing, in Babesia gibsoni, the RBC that is destroyed, the hemoglobin will be channelized to the liver. It is not to the urine. So you will not get any darker colored urine. If you get dark colored urine, that means it's only dehydration. But you will be getting so many, scrotal edema will be there, lymphedema will be there. And as I said earlier, in almost all these cases, you will have some sort of impairment of the organs. There could be either elevated creatinine, 1.8 or 2, or there could be hepatic problems, or there could even be neurological signs. Remember how in the last 5 or 10 years, we have been seeing more and more of neurological complications. Have you seen? Dogs are being more dogs are being brought with complications of convulsions. Yesterday night the dog was normal. Today morning when I went there, the dog is lying down. It is brought to the clinic. We start fluid, it starts developing. Have you seen such cases? So many, because the gibsoni cases, majority will be progressing into a neurological case if it is made to last, if it is not treated properly. So these many complications can be there for the gibsoni. And the first and foremost complication that we have noticed, before the development of neurological complication is that anisocoria, different size of both the pupils, different size. Only after this, I work in a hospital where we are treating 60 cases of infectious diseases in the morning in 4 hours. For the past 15 years, I have been seeing such cases. Anisocoria is the most important sign, different sizes of the pupil. Then only that animal will progress into neurological signs in the case of Babesia gibsoni. Now the third one, then we will go to the treatment, canine monocytic ehrlichiosis. Babesia canis was multiplying very fast. It was destroying the RBCs by its own. The clinical signs were acute always, temperature, hemolytic anemia, there is no thrombocytopenia, there is no organ impairment. Babesia gibsoni was infecting the RBCs, multiplying very slowly, not capable of destroying the RBCs by its own, but the body immune system destroys, leading into immune-mediated hemolytic anemia, slow onset, slow progress, thrombocytopenia, organ impairment, important. The third one, as far as we are concerned, is canine monocytic ehrlichiosis. Here, this organism doesn't have anything to do with the RBCs. This attacks the WBC. The morulae are there, the monocytes are infected, even the other granulocytic cells are infected. First multiplies in the macrophages, and then it goes into infect the other WBCs. Here also, the body will not permit any Babesia, this Ehrlichia canis is quite capable of surviving within the macrophages, surviving within the monocytes, but the body will not permit. Immune system is aggravated, hyperactivated, and it starts destroying the affected WBCs first. Okay, we are happy with that. The RBCs next, thrombocytes next. Again, we are happy because this is same as gibsoni. First, WBCs are gone, that is not there in gibsoni, but it destroys the RBCs, the thrombocytes, then causes the complication, 2 complications. The first complication is that it destroys the functions of the thrombocytes. In Babesia gibsoni, thrombocytopenia is very severe, but whatever thrombocytes that are left, they are functional. They are still capable of preventing the, bleeding. Whereas in the case of canine monocytic ehrlichiosis, even though the thrombocytopenia is not as severe as Babesia gibsoni, here the thrombocyte function, the thrombocyte migration factor is blocked. Thrombocytes agglutination is blocked, so that bleeding starts to happen. Here the thrombocytopenia is not as severe as Gibsoni, but the thrombocytes, since the thrombocytes are non-functional, you get epistasis, petechiae, ventral abdomen, on the glans penis, hyphema within the eyes, bleeding tendencies are there, melena. Clear? So Gibsoni is not producing this, Ehrlichia canis produces bleeding disorders, thrombocytopenia. And the second problem it causes is that it progresses, if not treated properly, if not recognized properly, it progresses into the chronic stage. And the chronic stage, it goes into the bone marrow, suppresses the myeloblastic cells, all the blast cells are destroyed. So it leads into pancytopenia or panleukopenia, where the WBC count goes below 3000. Thrombocytes are gone, RBCs are gone, WBC count is also gone, making the animal much prone for secondary bacterial infections. Clear? So this is the difference in pathogenesis between these three. This is very important for our treatment. Why? If you use prednisolone in the case of Gibsoni or canis, it will cause multiplication of the organism. If you don't use prednisolone in the treatment of chronic ehrlichiosis, it will not, if you don't use it, it will not lead into resolution of the signs quickly. So for Ehrlichia canis, you have to use steroids. For the other two, it is contraindicated. For chronic ehrlichiosis, the duration of treatment is 45 days because it is there in the macrophages. It has to come out. Whereas for Gibsoni, it may be around 14 to 21 days. Canis, it is only a single shot. So diagnosis, differential diagnosis is very important. Now, I will just try to give you one or two more important clues regarding differential diagnosis. Then only we will go to the treatment. Please. Can you give me 5 minutes because that is coming up. That will be explained in the slide. Treatment I am going to discuss. Okay, it is coming up. Doubts are welcome, but this is coming up. That's why I said. This I have already told. Acute, subclinical and chronic, I have to skip. There is no time. One important point, two important points. If you want to go for E. canis, the other ones peripheral smears are good. For Babesia canis, peripheral smear is good. If you want to go for Ehrlichia canis, go for the Buffy coat. If you want to make sure that your B. canis infection diagnosis is more accurate, go for the layer immediately before. You take this, you go for centrifugation, go for the RBC layer immediately before the Buffy coat. Make a slide with that. Never prepare a direct slide with venous blood because only 1 to 3% of the cells in the venous blood are affected. So if you want to go for preparing a slide for any hemoparasite, either go for the capillary blood from the ear tip or go for the top layer immediately before. Venous blood if you are taking, go for the top layer immediately before the Buffy coat for preparation of smears. Never prepare a direct smear with venous blood. The tendency is there for us. Anyway, we are poking it into the vein. We can take a drop of blood. Never do that. Okay. And when you are going for the capillary blood, always the tendency is that you poke it, you see just a reddish dot, you squeeze it, you milk it, then you try to touch the slide onto this, you make a slide. That should not be done. Any peripheral smear should be prepared only from a free falling blood drop. You should never touch because half of it will be serum. A free falling blood drop should be placed. The blood drop should be falling onto the slide. Touch the slide, second slide, lift it up, place it beyond the drop, then make the smear. If you directly make the smear, the excess blood will flow and your thin smear will become a thick. That's why so many wrong diagnoses are made. Am I clear? Okay, so this is for the diagnosis. These things you know already. Never go for PCR because for PCR is never a clinician's tool in an endemic country. If it is COVID, PCR is good because we are not endemic. If it is leptospirosis, PCR is worthless because we are endemic. PCR is so sensitive that it will give positive results. PCR will give positive results even for such cases where the presence of that pathogen is not clinically relevant. 10 nanograms, PCR will give positive. So, Babesia gibsoni and Ehrlichia canis, once infected, the animal is infected for life. But at that particular time, when the dog was brought to you, it may be having some other disease. And you send the sample for PCR, it will come out positive, positive for Babesia gibsoni. That doesn't mean this Babesia gibsoni is the etiological agent responsible for the clinical signs at this particular moment. So, never go for PCR. PCR is a tool for an epidemiologist. In an endemic country, PCR is never a tool for a clinician. Of course, rare diseases, you can definitely go for PCR, rare disease, but not for diseases such as leptospirosis and Babesia, where you can get so many false positives. So, PCR is not a good tool for the diagnosis. Now, this point, actually there is no time, but I cannot afford to skip this, because this gives you how to read your CBC and diagnose these three conditions. So, I will go into this, even though I will have to cut down on the treatment side. Think of what happens in hemolytic anemia. This is a normal RBC. Okay. You always look for, so many things you are looking for the CBC result. How many of you are going for the regular CBC in hemolytic cases, anemia case? Only one. Start doing, because right now the prices has come down. Even human labs, they are ready to give us for 80 to 100 rupees. Veterinary labs, so many are there. So, start going for this, because that will be a good idea. Now, you are looking at the RBCs, you are looking at the hemoglobin, you are looking at the thrombocytes. Start looking at these three factors also, the MCV, the MCH and MCHC. MCV, mean corpuscular volume, the size of the RBC, MCH, the mean corpuscular hemoglobin, the quantity of the hemoglobin, and MCHC, the mean corpuscular hemoglobin concentration. This is very, very important. Start looking at this. Why? Because the first one is a normal RBC, normal MCV, 70 to 80 FL. MCH will be around 35, MCHC will be around 28 to 30. Now, the organism is destroying, or the hemolytic anemia is progressing. Okay? Hemolytic anemia is progressing, the RBCs are destroyed, the organs start clamoring, demanding for oxygen and blood, energy, because the RBCs are gone, anemia is there. So, what does the body do? The first thing the body does is that, when the hemolytic anemia has progressed to some extent, and the organs are not getting enough oxygen and glucose, the body pushes out the reserves in the spleen, in the bone marrow, into the circulation. Clear? They are normal RBCs. So, what will be the MCV? Normal. Come on. MCH normal, MCHC normal. These RBCs are also destroyed. So, what does the body do next? There are no more normal RBCs. So, what does it do? It pushes in the Agniveer 4-year training is pushed into the war. The immature RBCs from the bone marrow. Clear? Immature RBCs are pushed into the circulation to meet the demands. The RBCs become old, as the RBCs become older, their size is reduced. They are biggest when they are immature. So, what will be the MCV? More, good. MCH normal, because the hemoglobin is normal. But what about MCHC? Normal hemoglobin, more volume. Low, good. Now you are getting the hang of the things. Okay. So, next time you look and you see this. MCV is 95 to 100. MCHC is low. That means this has been going on for 1 week. The body has depleted. The normal reserves have been depleted. Now the body has pushed in the immature RBCs, but still the body is capable of meeting the demands. Clear? Could be nucleated, could be the bigger ones. If you look at the smear, there could be nucleated RBCs and the bigger ones also. Mega cells could be also there. Bigger ones could be there. Okay. And now these RBCs are destroyed because the infection is not controlled. The animal hasn't been brought to your clinic because the owner is busy. So these RBCs are destroyed. Now the body doesn't have any more RBCs, any more immature RBCs also. But the organs' demands have to be met. So what does the body do next? The body allows the RBCs to live longer instead of 120 days, 140 days. Because there is no more reserves. So the older ones, the retired ones like me are left to fight. So what will happen to the volume? MCV, low, good. MCH, normal. MCH, MCHC, high, good. Got it? So when such an animal is brought to you with an MCV of 40 to 50, MCH 35 and MCHC is above, that means the body's reserves are almost at an end. This is the last one. The retired ones are fighting. Got it? Okay. Now these retired ones are also gone. But the body still has to do something. What is happening now? The hemoglobin reserves are depleted now. And those RBCs that were processed or that were produced in the bone marrow, at this stage, they will be having low hemoglobin. They will be having, and they are permitted to mature. The last stage where the body has surrendered, nothing more. But the RBCs that were produced at a contingency rate with a low hemoglobin, now they are permitted to mature. The last stage, the HCT has come down less than 10. So what you will get in the last stage? The MCV will be low. MCH will be low because those RBCs are not having enough hemoglobin. MCHC will be low or normal. Clear? Sorry for the Malayalam. You got it? Okay. So next time, so the last one, shall I go again, once again? These RBCs were produced when there was not enough hemoglobin. And they have now become permitted, they have been permitted to become older than beyond their normal life. So their size is reduced, MCV is reduced, MCH is low because when they were produced there was not enough hemoglobin, and low MCH, low MCV, that means either normal or low MCHC. Clear? So next time you look at a CBC, look at this, and the owner says this animal has been anorectic for 2 days, and you find that it is the stage is this, think that the owner either he didn't notice or he is bluffing. And why this is important? Because this gives you an idea about whether blood transfusion is there required, prognosis is what, how much you should treat, what amount, how aggressive your treatment should be. So you look at the RBCs, RBC count, you look at the hemoglobin, you look at the thrombocytes, you look at everything, you start looking at these 3 factors also because they give you a good idea about the stage of the animal that is presented to you. Okay? 5 more minutes. So this is what I was trying to tell you. Now I will skip that. We will go to the treatment direct. So treatment of hemoparasitic infections have 5 steps. All five are equally important. Go for an anti-infectious agent, definitely. Choose it well. We will go into that in detail. Always add hematinics. Never hold back from day 1 onwards, start hematinics. There are so many theories which says that liver impairment is there. If liver impairment is there, if you give iron, will it not aggravate the liver impairment? Forget about this. Start hematinics. Managing the organ impairment. Check for the, if possible, check for the renal hepatic function impairments by their functional. For the hepatic function, if possible, go for serum bile acids. That is the most accurate indicator. Otherwise, go for your normal ALT and ALP. Serum bile acid is the best indicator. Go for creatinine, go for BUN. Check for the, because if you are able to detect it early, as sir was telling, you should be able to manage it very early. Otherwise, the thing will progress to a level where further management is not possible. So always look for the organ impairment. Acaricides, very important because transmission you have to block and follow up. First, we will go to the treatment. So for Babesia gibsoni, 3 treatments are there. For Babesia canis, 2 treatments are there. First, we will discuss imidocarb. Imidocarb, why I am discussing first and not dimenacin is because even though Greene, Sykes, Ettinger and Nelson, they say that imidocarb is not effective for Babesia gibsoni. Under our experience, we are treating 8 to 10 cases per day. Imidocarb is as good or even better than dimenacin for the treatment of Babesia gibsoni. And the most useful thing about imidocarb is that If you are going to have a reaction, it will happen within 10 minutes. And you have got a drug with which you can easily reverse it. Whereas for the dimenacin, if you are going to have a reaction, that will happen from 24 to 36 hours later with a petechiae in the brain, neurological signs which are irreversible. As far as the effect is concerned for Babesia gibsoni, there is not much difference. So, imidocarb is the first drug of choice for us if it is possible, if you can give it. The dose is 6.6 milligram per kilogram body weight subcutaneous. If the animal is very weak, and it should be repeated after 2 weeks. If the animal is very weak, when it is brought to us with gibsoni, we don't go for 6.6, we go for 5. I will give you the treatment chart later. So, imidocarb is the first choice for the treatment of Babesia gibsoni. So, you may get cholinergic signs. Never go for atropine initially. That is not required. Even though some people are giving atropine first, subcutaneous, to prevent the reaction, that is not required. Imidocarb reactions will start with profuse frothy salivation. The animal will start to circle around. It will start to pant. It will start to lie down. It will start to lie down on its side. Even when the animal is lying down on the side, and the owner runs to the store and brings back the atropine, you can easily reverse it. Imidocarb reactions are easily reversible. Atropine at 0.04 milligram per kilogram body weight subcut will easily reverse imidocarb reactions. So, never give atropine before giving imidocarb. It is not required. So, if the animal is very weak, we go for a reduced dose. We don't give atropine first. Whereas, if it is Babesia canis, the drug of choice even today is dimenacin. Drug of choice today is dimenacin. That is our Bernil or whatever it is. Dimenacin, you should remember 2 things. The therapeutic doses for the RTU, ready to use solution, the therapeutic dose for the dog is 3.5 to 5 milligram per kilogram body weight. And the toxic dose is 5.5 milligram. Toxic dose can be from 5.5 milligram. So, if you don't have a balance, if you don't have a weighing machine in your clinic and you are estimating the weight, never go for the 5 milligram dose. Always reduce it to 4 to 4.5 because it can be toxic. The second thing regarding dimenacin is that it takes at least 36 hours for the dog's body to metabolize it. So, if you are giving even 3 milligram today and giving 3 milligram tomorrow, the dog, it can become a toxic dose because it requires 36 hours. So, never repeat dimenacin for a dog. Previously, we were telling our students that you can repeat after 14 days. Then some articles came telling that you can repeat only after 21 days. Now, Goodman and Gilman says never repeat. So, never repeat. You can go repeat dimenacin for a cow. Why? Because the therapeutic dose is 8 and the toxic dose is 31. That is why for Babesia it is more than sufficient for metronidazole and 10 milligram per kilogram body weight is sufficient for doxycycline. You need to repeat it in the afternoon. So, if the animal is brought to you in a very bad condition where you are not confident of giving imidocarb or going for the dimenacin therapy, go for the triple therapy. It works for bony as well as in a private hospital, in a government hospital where only one person is there. This will take 45 minutes because you cannot push metronidazole. It requires 4 to 5 ml per kg. That is 20 milligram means 4 ml per kg. A 30 ml dog means 120 ml. It will not have any effect on doxycycline absorption. You can give any time. Only I am talking about oral because acidity is required. Another problem with doxycycline is that it chelates iron and we are giving hematinics and hematinics are invariably tasty for the dog and doxycycline is bitter. So, the owner has got a tendency to mix these 2 things together. So, tell him never mix this hematinic with the doxycycline. 30% of the doxycycline will be chelated by milk. 80% of tetracycline will be chelated by the milk. So, if you are giving doxycycline in milk, increase the dosage to 13 milligram. Am I clear? Increase the dosage to 13 milligram. So, go for IV therapy for the first 3 to 4 days if possible. Once the animal starts taking food, you switch over into oral therapy. And the duration as he asked. 3 things for baby. You only asked about the duration. You only asked about the duration. Very soon it will come to less than 100 rupees. So, you can go for IV for the first 3 or 4 days, then go for oral therapy. 45 days is the duration for Ehrlichia canis. Now, the last one point before I stop this, prevention. Hematinics and all supportive therapy, I think you know this from. if you are going for triple therapy. If you are going for imidocarb, 2 injection, 1 and 14th day. Clear? It have to continue for whatever day. Not doxy alone. That was the question. Not doxy alone. Okay. Now the last thing regarding acaricides. We think that we know a lot about acaricides. We don't know. 2 or 3 points. Many people are using synthetic pyrethroid shampoos as acaricides. Am I clear? Most of us are using for the shampoos. Of the 4 synthetic pyrethroids, permethrin, deltamethrin, cypermethrin, flumethrin, only cypermethrin is the only drug that is not inactivated by the presence of organic matter. So never go for any shampoos on a never go for application of any of these shampoos on the body of a dirty dog if it is not of cypermethrin. And never use any of the other 3, deltamethrin, flumethrin, permethrin, for spraying on the kennel and all. Only use cypermethrin because that is the only drug that is not denatured by the presence of organic matter. Second one, all these 4 drugs are destroyed within 15 minutes of exposure to sunlight. And many of our owners has got this habit. After the animal is being bathed, it will be taken out and tied under the sunlight for it to get dried up. So never use it, never tell the owner, because these are contact poisons. You need to retain them on the body for a long time. So tell the owner, never take it out and expose it to sunlight for the next 24 hours. Third one, this is very important. The louse and the mite, they have got their entire lifespan on the host. So surroundings are not important. Whereas for the ticks, engorged tick falls down, crawls, lays eggs, reinfection. Flea lays eggs, they will be hatching out in clutches in the next 6 months. So if it is a tick, the owner has to continue the therapy weekly once for the next 6 weeks at least, together with the surroundings. Or if the owner is wealthy, you can go for the floralana and all those things. These 2 are the only drugs. Never think that a heavy tick infestation can be cured with fipronil. It will not work. Amitraz is good. Amitraz is good, but the smell and all. Amitraz is an excellent tick remover. We are using it only for the mites, but Amitraz is good for the ticks. Never use it for the therapy. You can use Amitraz if the owner is willing. I think that is all, sir. Everyone is hungry. So steroid. Remember this. Any hemoprotozoan, even in an incubation stage, will multiply quicker if you give steroids. So steroids are not indicated, even though for Babesia gibsoni, it is immune-mediated hemolytic anemia, unless and until you are confident that you have controlled the infection by 2 administrations of this or 6 or 7 days of triple therapy or 2 administrations of imidocarb. Unless and until you are confident, you don't use steroids. Whereas for any rickettsial infection, like our Babesia or Anaplasma, these are bacteria but rickettsial properties. For them, recovery, faster recovery, steroids are a must. So use prednisolone only for Ehrlichia canis. Never go for prednisolone for Babesia gibsoni and Babesia canis. Am I clear? Any doubts?
Thank you, Dr. Vinod Kumar. And definitely you will all be cursing for him to finish the course quickly, the subject quickly. Definitely we assure you, we will bring him in future for separate diseases also. Definitely he is going to come in the future. And the second thing, all these lectures are being live, video is being given. The same website, you can even go again and again. You can even see to those lectures if you are interested, if you want to learn more. And sorry, please bear with us for another half an hour. The programs are so scheduled that we only got delayed. We apologize for it. And the last lecture is by Dr. Pushkin Raj. He is a renowned surgeon, the upcoming surgeon of Madras Veterinary College. He is an assistant professor in Department of Surgery. So he will give us a lecture on fracture management. Please bear with us. You can be here. In another half an hour, we will Dear delegates, the lunch will be arranged till 3:30. You can all please be wait. Definitely the lunch will be provided till 3:30 p.m.
So, good afternoon to everyone. So, I have to rush because everyone will be restless. So, I will take a shorter time as much as possible. So, the topic is on how to make a decision. So, nowadays we get a lot of cases, we are getting with the fracture, especially in young animals, and thereby causing a great lameness, in the rest of the life. So, as a thing, it can be managed at the basic level. If you want to manage it in the higher level, it has been referred to the institutions. So, the first thing what you need to do as a practitioner, those are the tips I want to give it to you. Next slide. So, basically bone is a framework of the body, and it counteracts the forces of the gravity with the muscles. That is the thing. So, what are the fracture is happening? So, what are the forces acting on the gravity? It has to overcome. Okay, when the bone cannot be able to overcome these forces, the bone breaks. So, as a vet, when you want to decide how to treat a fracture, you should know what the biomechanics is playing on the fracture and how to diagnose, and then you need to classify them properly. That is the most important thing, and you need to choose the right fixation and for ensured bone healing. That is the most important thing. There are a lot of fixation techniques are there. You cannot go just like that, know what you know, and you need to identify the healing progress, whether your treatment is going in a correct pathway, and if there is any complications is there, you should be able to overcome those complications. So, the first decision. So, when a pet comes to you with a fracture, okay, you should not think out only the fracture. Almost if a open fracture is there, 30% of the open fractures is always associated with other system involvement. So, first thing is that you need to systematically diagnose the condition and then attend to that first. Okay, attend to that first. And the second decision is whether you can go for a conservative or any other internal fixation technique, internal external skeletal fixation techniques. So, next. The first thing, so I told you 30% of the open fractures will always be associated with the system involvement. So, prioritize the life threatening injuries. So, suppose if a cat falls from a height, okay, you can expect some diaphragmatic hernia. So, that will be associated with the femur fracture. The first thing is that you need to address to the diaphragmatic hernia rather than to the attending to the fracture treatment. Okay. So, you should go immediately, you should do the A-FAST and T-FAST, that is thoracic focused assessment with ultrasonography. You need to check for any bleeding, internal bleeding is there. Do not look out only the fracture alone. Okay. And the neurological, the physical examination, orthopedic examination and the neurological examination alone comes as the last. This is the point what I want to stress you. Okay. Just do not think that when the animal just we could not able to stand up, do not think out only the fracture, think out the other associated organ involvement. So, the second decision is you need to evaluate the fracture based on the radiography. So, there are two rules, okay. The rules of 2 is always applies for the orthopedic. Suppose if you want to take a fracture, you need to take 2 opposite views, definitely 2 views are needed. You should not miss with 1 view, always take 2 views, and then you need to, in the 2 views, you need to involve both the joint above and the joint below, and you need to always take the other normal side also if possible, because suppose if I want to make a treatment or internal fixation, I need to know what is the measurement of the normal. So, always I should take up the other limb also, and as I told you, other injuries you need to look into out, and 2 occasions, that is pre-operative and post-operative, or pre-treatment or post-treatment. So, a lot of times with the radiograph we will be going for the 2 times. The first thing is that you need to know what are the forces acting on that fracture. Okay. So, the 5 main forces, these are the main 5 forces are acting on the fracture that you should be able to overcome and proceed for your treatment. The first force is going to be your tension. Okay. Tension means, suppose if the bone is bending, the tension means it is going to lengthen the bone. Okay. And bending. Okay, bending is the major force which you can see in almost all the fractures. So, when the bone is going to bend, one side will be the convex and another side will be concave. So, the convex side is going to be your tension side, and the convex is going, and the concave is going to be your bending side. Okay, and shear is nothing but any fracture, it will try to slip away one above the other. Okay, these things now I will just cover next. So, this is the bending force I told you. So, when the bone is going to bend, the tension will be on the opposite end, on the convex side, and the concave side will be the bending. Next. And the tension. So, tension always makes the bone to lengthen, okay, and you can expect a transverse fracture with that tension. And with the compression, when you see the compression, the bone is going to get compressed, it will always go for either short oblique fractures. And shear will be present in all the fractures. Whatever the treatment you are going to give, whether you are going to give a conservative or internal fixation, you need to overcome this force. Okay? Either it will act parallelly or it will act as at an angle. Okay, torsion. Torsion is mostly seen only in the angled bones such as humerus and also in the femur. Humerus and tibia. These are the 2 bones where you can see the spiral fracture is very, very common. Okay. So, in that torsion, one axial force will be acting, the force will be, compression force will be acting, apart from that there will be rotation. So, this causes it go for the spiral fracture. So, when the impact is too more, the bone is going to break into multiple pieces, it will be defined as a comminuted fracture. Okay. Then you need to classify, you should put in your mind what are the forces are going to act on the fractured bone. Then you should be able to classify. The bone is usually classified based on the bone and location, and what is the severity, in that you need to identify. Based on the severity only you can decide what type of treatment I can able to proceed. Okay. And the pattern and displacement, how far it is displaced, and contamination. Contamination goes on with your open fracture and the closed fracture. So, with regard to the anatomical, okay, so you need to know what is the epiphysis. Everyone knows that is a simple epiphysis, because each and every part of the bone is broken, you need to fix it up. Okay. So, the first top part is going to be epiphysis, and below that it is going to be the physis. Physis is very important, very, very important for with regard to the young animals, physeal fractures. Okay. So, that will always cause the permanent lameness in the rest of the life. And below that is going to be a metaphysis and diaphysis. So, epiphysis, physis, metaphysis will be seen on both the ends, and diaphysis, it is always for a veterinarian to treat the diaphyseal fractures, but it is always a big headache to treat the upper and distalmost fractures. So, based on the severity, it will be classified as either a complete or a incomplete fracture. Next slide. So, incomplete fracture, mostly in young animals you can see the green stick fracture, it is called as incomplete fracture, where one cortex will remain intact, the other cortex will be broken. So, that will be called as a green stick fracture. Next. So, sometimes you can see the fissure fracture, a longitudinal fissure fractures you can see. Okay. Next. The multifragmental, this is always a challenging fracture configuration. So, this is also multi-fragment, this is called as multi-fragment, multiple fracture is different, these two things you should remember. Okay. Multi-fragment means a single bone itself, it is being divided into multiple pieces, but multiple fracture is at many parts, okay. So, it will be it is also called as comminuted fracture, commonly we call it as comminuted fracture, again divided into wedge fractures. I will show the picture, next slide. So, this is called as wedge fracture, a small piece of bone is come out, okay, but that you can make it into some contact after your reduction. Next slide. So, this is called as a reducible wedge fracture. So, when the fracture pieces are 1/3 of the bone diameter, it can be reduced, that will be called as reducible wedge fracture. When it is broken less than that, okay, multiple pieces where you can not able to put them together, it will be called as non-reducible wedge fracture. So, comminuted fracture itself is having a subclassification. Next. So, this is the multiple fracture I told you. It is so where the fracture fragments you cannot meet them together, all the fracture planes cannot meet them together, it will be called as multiple fractures. So, the transverse fracture. So, when you define the transverse fracture, if the bone diameter is equal to the fracture plane, it will be called as a transverse fracture. So, when it exceeds 2 times, when the fracture plane is exceeding 2 times the diameter of the bone, it will be called as oblique fractures, or if the angle is greater than 30 degree, it will be called as an oblique fracture. Okay. So, next. The spiral fracture I told you, so it will be, you can see the fracture plane will start at one cortex and it will move to the other cortex. Next slide. So, there are also extra-articular fractures is there. So, above the joint you can see the fractures. Next. And this is a condyle fracture, it's a single condyle fracture, partial articular fracture. Next. And this you can see them in which bone, this type of fractures, which condyle? You cannot see this type of fracture in all the condyles. Humerus. Humerus is the bone where you can see the Y type fracture or the T type fractures, you can see them. Okay. So, this is the classification is going on with the fascial fracture. I told you, fascial fracture nowadays is very common. Almost all the dogs which have been, most of the dogs, they bring with this valgus deformity. So, what happens, So, when the animal makes any fall, the fascial line is getting damaged, and because of that the growth is stopped and the animal is going for this valgus deformity. Okay, so, this has been divided into classification, it's called Salter-Harris. S is simple, easy to remember. When both the when the segments they just join together, it will be called as S. Okay. No, sorry, it's S is separation. You remember the word S is separation when the fascial line is getting separated, and A is above the fascial line and L is below the fascial line, and T is through the fascial line, and R is compression. So, S is separation, the opposite is going to be your compression. So, this is called as Salter-Harris classification. Next. So, the impacted fracture, this you can see them in mostly in the which condition? Nowadays, we can see almost all the pet dogs are having this impacted type of fracture. In pathological fractures, in bones with osteopenic condition, you can see the impacted fractures can be seen commonly. Next. So, this is called an avulsion fracture. You can see at the extremities, 2 places. One is at the olecranon process, over the olecranon process, and another is over the tibial tuberosity, over the tibial tuberosity. Next slide. So, stable fracture. So, stable fracture means, so if the fragment can be, it will be, if it stays on the same place but fractured, it will be defined as a stable fracture. Next. Next slide. So, unstable fracture, so it will be a oblique or non-reducible wedge fractures will be defined as a unstable fracture. Okay, next. So, this is one, just I want to show you what are the type of fractures, then only I can able to tell you the fracture fixation method. This is also called as a Montague fracture, where the ulna will be broken and radius alone will be displaced. So, it will be dislocated, that is luxated. So, such fracture will be called as Montague fracture. The Cole's fracture, this is the most common fracture where you can see in the toy breeds. In the toy breeds, this fracture is nowadays very common. So, this is a very headache fracture. So, where this fracture will never heal, either if it heals, it will heal with a malunion, but 83% of the fractures will never heal, especially in the toy breeds. Suppose it's a mini Pomeranian, if they have this fracture, you can definitely tell the owner, you can tell the prognosis of the thing. So, in those cases, you need to give a rigid fixation, definitely internal fixation is needed, your bandaging technique will never work. Even in pug also, in pug breed. So, this fracture is called as Cole's fracture. Why means in these breeds the blood supply is very less to that part. So, because of that it takes a longer time or it will not heal at all. Next slide. So, nowadays there is just for your information, now this A was being classified into to define this all these multiple types of fracture configuration. They define in terms of alphanumeric system. So, the bone will be defined in terms of alphabet, and the configuration, the part is being divided into alphabets. Okay, if it is simple, A. Okay, if the humerus is having a simple fracture, 1A. Like that, bone and the type of fracture is being defined in terms of alphanumeric system, but we don't follow it here, but in abroad they follow this type of fracture. Okay, next slide. Next slide. Okay, the goal of the fracture repair, what we need to do? So, you need to create a harmonious partnership. What are the treatment you are going to give between a fractured bone and for your treatment, there should be some good partnership should be there. If anything fails, either if the bone doesn't cooperate or if your treatment technique doesn't cooperate, definitely it will cause a failure of your fracture treatment. Okay, so the treatment is, you should give a treatment, the animal should walk as early as possible with good cosmetic appearance and full function. That is the three things we need to know, three things we need to promote. So, to bring about, what are the decisions you need to have is, what are the potential fixation methods I need to look into that. I want to give the best. Okay, and what are the advantages and disadvantages of these methods, whether each and every method you should always put into your mind the biomechanics. I told you the 5 forces, whether it is counteracting these 5 forces or not. And also the most important thing is, you should look into the patient. If the patient is very aggressive, it will be very difficult to treat, and also the client. So, there are certain factors are there, I will be showing in the next thing. So, this is the thing, this is the choice we have for a fracture treatment. Okay, from least invasive to the most invasive. Least invasive will always be unstable. Least invasive is always going to be unstable. Most invasive means doing surgery, surgical condition, surgery technique is going to give you the most good stability, is going to give you the most stability. Okay, so this is the range. We have the next slide. The factors, these each and every factor is very important for us in deciding the success of our fracture treatment. The first thing, the patient is a body weight, size and temperament, all these things, and the client, of course, nowadays almost all the clients are willing to go for the internal fixations. They ask guarantee, sir, I am ready for the surgery, please give us the good result. Okay, so certain owners, if you tell them, okay, I don't want to, you just simply put the bandage, which you should not do that, which you should not do any bandaging or anything, but the owner will not be willing to do that. Okay, and the fracture configuration, on the fracture configuration, that is also a deciding factor. And of course, on wet side you should know the biomechanics, and especially the most important thing, you should have the particular implant with you, and instrumentation implant should be needed with you. Okay, with regard to the bone, you need to look into the blood supply, whether the bone has got a good blood supply whether it can able to heal the fracture or any other associated soft tissue injury is also there. Okay. See, we don't know what has happened surrounding the fracture site, but once if it comes, we simply put a bandage and do that. Always try to look into that whether soft tissue is also intact or not. Only the soft tissue is going to help the bone to heal now, till the bone is going to recover from the fracture. Okay. And the mechanical, last thing is implant. What type of implant, how best implant you are going to use it, whether you are going to use a stainless steel or whether you are going to use your titanium. Next slide. So, the approach to the fixation, now it is being divided into two. One is called the Carpenter approach, another is called the Gardner approach. Okay. Carpenter approach is just you need to fix the bone very stronger, so that the fracture treatment is going to be a strong fracture treatment. So, that is called as Carpenter approach. Mostly it is associated only the surgical techniques. Okay. Now, what is being advised is go for the Gardner approach. Don't touch the fracture site. Don't disturb the fracture site. Preserve the blood flow as much as possible. Okay. At the same time, try to give the best stability to the fracture. So, that approach is called as Gardner approach. Okay. Now, what are the type of fracture? The recent trend is going for the Gardner approach. Previously, initially they started, okay, put the plate, put the screw, give a rigid fixation, but it does not give you good healing. Okay. Now, the healing is, we need to go for the Gardner. This is very, very important point. Okay. Next. So, when you want, now you are going to decide whether I can go for ordinary external coaptation or whether I need to go for the internal fixation. Okay. So, now this is a choice. Who has to make? Either a vet has to decide or the patient owner has to decide. Okay. So, external coaptation, always remember, it can overcome only the bending and rotational force, but the thing is that you need to immobilize the joint above and joint below. If you do not do that immobilization, the joint above and joint below, definitely the fracture will never heal. Okay. Your external coaptation is going to be a 100% failure. 100% failure. Okay. And the contraindication for the external coaptation is, do not go for long oblique or comminuted fractures. Now, I told you comminuted fractures and long oblique fractures, your external coaptation, either your POP cast is going to be definitely a failure, it will lead to the different complications. So, that is contraindicated. Okay. Internal fixation, when the fractures with compression, shear and tensile forces are there, definitely internal fixation alone will help you. This is the decision you need to take. Okay. So, when you go for the external coaptation, once the fracture comes, do not put the bandage as such. Okay. The most important thing is you need to reduce, okay, minimum 50% of reduction should happen, and at least 50-50 contact should happen. No matter whether you want to put a POP or just a bandage, you are going to put with a bamboo stick or anything. So, this is the most important thing. So, most of the times the fractures will be like this, you simply put a bandage, nothing will happen. So, try to reduce minimum 50%, it should be reduced, okay, and 50% contact should be there. Then you can expect assured healing will be there. This is the for any external coaptation, try to follow how will you do that? Suppose if the case comes after 2 days, so what you should do? Anesthetize the animal, okay, just give some traction as they do in the human, okay, give some traction, okay, try to reduce, you can reduce, try to reduce as much as possible, make it little bit contact with each other, then you go for your treatment. Okay. Without doing anything, if you put after 21 days, definitely the fracture will not heal at all. Next slide. So, this is the 50-50 rule, try to put in mind, this is very, very important for the external coaptation. If you do not do that, definitely the failure will happen. So, external coaptation, okay, I told you, it is always reserved for the fractures distal to the elbow and to the stifle joint, not to the femur or humerus. As many people they think that we can put bandage for femur or humerus. Okay, if you put the bandage, definitely it will act as a fulcrum. Okay, it will cause a lot of muscle trauma. Okay, So muscles are there, don't do anything, don't put any bandage, because muscles are there, they will give you a good protection. They immobilize, muscles will immobilize the fracture. Don't put any bandage. If you put a bandage, what is going to happen? Again, overriding is that it is going to, you are going to complicate it more. So external coaptation is reserved only for the fractures below the stifle joint, below the elbow joint. Okay. Then young animals with the green stick fractures, external coaptation is the best choice for them. Okay. Or minimally, suppose if radius and ulna is there, only radius is fractured, ulna is intact, then you go for your external coaptation. Okay. So I told you again, I want to stress bending and rotational force. It will not bend. Suppose if you immobilize the joint above, joint below, the fracture will not move. It can overcome the bending and rotational force, and 50-50 you can do that. So the most thing, headache, where you should not do is your chondrodystrophy breed. Chondrodystrophy breed means dash end. It is very difficult to put an external coaptation in those breeds. Okay, in pug also, it is very difficult to do that, because it will, bandage will slip away. How best you do, it will slip away. Okay, and patients with the polytrauma or any immunosuppressive drugs, those immunosuppressed patients, and if the temperament, that is a very most, if the dog is highly uncooperative, don't go for external coaptation. You should think of a rigid fixation with a minimal handling. Okay, so that is most important thing. And small and toy breeds, I told you already, especially the radius ulna fracture, 83% the chances for either malunion or non-union. So this is the thing, you need to restrict your bandaging everything only to this level, okay, up to the mid humerus or to the mid femur. So this is the area where you can focus your external coaptation. Nothing more beyond that you cannot able to proceed for your external coaptation. Next slide. So advantage. So we are not opening the fracture, no infection, okay, easy to apply, expenditure is less. So these are the various advantages you know already, but you please, disadvantage is 63% you can expect any complication. After putting your external coaptation, 63% you can expect any complication. Okay. So if it doesn't work out, it will go for delayed union or malunion, and putting the bandage for longer time, what will happen? Your muscle will get atrophy, your joint will become stiffness. Okay. So these are the complications with external coaptation. Okay. Next. So just I want to go very fast. So when you want to put a bandage, okay, many people are putting a bandage, but how to do it in a proper way? A bandage consists of 3 layers. Okay, if it is a open fracture, the first layer is going to be called as your contact layer. Okay, the primary layer or contact layer, where you are going to keep any medicament gauzes you are going to put. Okay, the second layer is going to be your intermediate layer. This layer is very important. This is the thing which is going to decide your success of your external coaptation. Okay. So just what you are going to, I will tell you the tertiary layer, the primary layer, next slide. The primary layer, okay, I told you, dressings, you are going to apply some dressings, either ointment or gel or anything you are going to apply over the wound. That is going to be a primary layer. Okay. In the primary layer, the first thing, donut, next slide please. See, for the bony prominences, try to prepare. This is a simple thing. Okay, just take a bandage roll, roll 1 or 2 or 3 times, then just like ladies wearing a hairband, just like that. You just keep it over the prominences, so that you can avoid the complications. Just put a bandage, or you need to pad very nicely in those bony prominences. So this is going to be your primary layer. The secondary layer, next slide, is going to be your cotton roll. Okay, when you are going to put a cotton roll, what you are going to do? Just to simply take the cotton roll, make it into 2 pieces, then simply roll it away. What you need to do? Compress the cotton roll. Compress the cotton roll with something, the bottle or something, chapati, this thing like that. No, you just compress so that cotton pads are available nowadays. It is very easy, very cheap. the lateral side, put it onto the medial side, then fix it up with a scale in between. So there is no primary layer for this. Since it is a thing, there is no primary layer for this. Always start from the distal extremity, go for the turns. Okay. So here is the which side of the limb? Is the left limb. Okay. So what direction I am rotating it? Anti-clockwise. So for the left limb, you should always rotate in anti-clockwise. For the right limb, it will come in opposite direction. Okay, this is the thing you need to remember. Don't do, because we are right-handed, our hands will always go like this. So for a left limb, if you do like this, it will go for the external rotation. It is always whenever do a bandage for the limb, it should always go for the internal rotation. If you go for the external rotation, what will happen after recovery? The animal will walk like this. Okay, it will become awkward. Okay, so always aim for the internal rotation. This is very, very important trick you need to follow. Okay, for the left limb, go for the anti-clockwise. For the right limb, go for the clockwise direction, so that the limb should go for the medial rotation. Okay, next slide. So the tertiary layer is going to be your bandage cloth. Okay, here you need to follow. When you have to start from the distal extremity. When you start from the distal extremity, you should make 75% coverage of the first turn. Like that, you need to go from the distal to the proximal. When you come back, you should cover 50% of the 50%. Like that, you need to vary. It is not uniformly, you should not roll like that. Why means, then only you can get adequate compression, adequate padding, adequate support to that internal thing. If you change there will be some irregularity will be seen in the bandaging thing. Okay, and also now, as everyone knows, you have got the, nowadays you are getting a creep and adhesive bandage. Oh, so this is going to be your tertiary layer. Okay, next. So Robert Jones, this is the thing. So Robert Jones is nothing but you need to keep a lot of cotton. That's all. A simple bandaging, but lot of cotton. Robert Jones means minimum 8 centimeter thickness. You imagine one whole cotton roll you need to put it 8 centimeter thickness. Now the modified Robert Jones is, they will be telling, modified Robert Jones is only 4 centimeter thickness. That's all. There is no big difference between that. The thing is that when you put a bandage, there should not be any compromise to your blood supply to the thing. Especially for the hounds, you should be very careful. Especially hounds, chippy parai, and this all our native breeds, where there is no adequate musculature. You need to put lot of padding. Suppose if a Shih Tzu comes, if you are putting too much padding, what will happen? The bandage will slip away. To avoid that slipping of the bandage, you are keeping that stirrup. Okay, next slide. So here is the difference. I told you, So for the right limb, it will come in the clockwise. For the left limb, it should go in the anti-clockwise direction. Next slide. So paw bandaging. So you need to cover the bandage like this. Sometimes only in the carpal, in the digits, you will have the fractures. So in those cases, you can apply this. So you need to make a turn on the front to the back and then take it in a crosses like this. Next slide. So when you put a POP cast, the same principle as you do for the tertiary layer, 75, 50, 25. Okay, you are doing it. Immobilize the joint above, joint below. Don't focus only onto the fractured limb. You need to immobilize the joint above and joint below. What happens to the POP, if the animal is going to put on weight on it, so the cast will become a fracture. So to avoid that, you apply 2 or 3 layers of the POP cast. In between that, you just keep either your aluminum splint, aluminum rod or anything, scale or anything, so that your cast will remain intact. Okay, the next slide. So like that you can put your aluminum, don't put directly over the skin. Okay, first make your primary, your secondary and then tertiary, and you are going to put your POP. Over the POP you just apply this, okay, so that you can avoid the pressure source and the cast fractures. Next slide. Okay, when you want to put a fiberglass, okay, POP, the two things are there, please understand. POP and fiberglass, there are two things are there. One is called setting time and curing time. Setting time is when I dip that POP roll I am going to apply, it is going to become soft, and then it is going to set to a hard structure again. It is going to set to a hard structure again. Okay. So, that is called setting time. But curing time is the complete dryness, complete drying. Do you know what is the time for setting time for a POP cast? How much time it will take? Setting time, it will take only 10 minutes. If you put a thing, within 10 minutes it will set, but curing time is more important. How much is the curing time? It's 24 hours. Suppose if you put a POP cast and then make the animal to walk, immediately the cast will become a fracture. So, for a POP cast, it takes 24 hours. To overcome those problems, we are using nowadays a synthetic casting material that is called fiberglass. Fiberglass is come. The setting time is very fast, only 10 minutes, less than 10 minutes, and the curing time is only 15 minutes. And the curing time is only 15 minutes. Okay. With the POP, the another disadvantage is it contains a calcium sulfate. It's a gypsum, nothing but a gypsum, calcium sulfate. Suppose if you want to take the healing status, if you want to take an X-ray, calcium is there, it will not allow you cannot see them, you cannot judge properly the healing status. Whereas the fiberglass, it's a radiolucent. You can just know without removing yourself, you can able to judge periodically. Every 3 weeks, you can able to judge. So, and also know fiberglass is lightweight and 20 times more stronger than POP. 1/4 of the weight of the POP. One thing is lightweight and another thing is more stronger. Only thing it is 4 times it is more expensive than your POP. Okay, next slide. See what I will do, just simply dip it. Okay, next. So, if you want to put it as a splint, in the first line, you need to take from the joint above to the joint below. Okay, always put it in the cranial aspect in the hind limb and caudal aspect in the front to the back to the front. So, this is the thing, but mostly it should cover most to the lateral aspect. It should give more coverage to the lateral aspect for a splint. Okay. What is the thing is being suggested now is put a cast. It is 2 to 3 layers is enough for a fiberglass. 2 to 3 layers is enough for a fiberglass. For us, for a POP, minimum 6 to 8 layers is needed. How many? 6 to 8 layers, keeping in your memory 75, 50, 25, like that, like the 6 to 8 layers is needed. Okay. So, after putting this, what we can do, suppose imagine if an open wound is there, I will put a cast like this, then I will cut it into 2. Next slide. Then I will cut it into 2 half on the lateral aspect and the medial aspect. Okay. Then again I will fix it back, and you can secure it with the adhesive tape. So, this is called as bivalve splint. So, it is better to have this. Suppose if you want to recheck again any bandage, soiling, anything is there, it is easy. Otherwise, you need to remove the whole cast. The cost factor again, it is a big headache. So, apply a cast, cut it into 2, fix it up. Suppose if the animal urinates or some urine soiling is happening, you can remove it back, put it back, you can fix it back. You can reuse this again. Whereas POP, if it becomes wet, finished, that is all. Again you need to reapply everything. So, this is the advantage of the fiberglass. Next slide. So, the next version, sometimes you can also use your POP itself as a splint. Okay. So, make it into 6 to 8 layers, measure from the joint above, joint below. Okay. Dip it in water, then apply as I said for the cranial aspect in the hind limb and caudal aspect in the forelimb. Okay. Or sometimes nowadays we get these ordinary PVC pipes. So, this is going to be your ordinary PVC pipe. You can cut it half into 2, pad with the ordinary sponge, and you can put it like that. Okay. The problem is, next slide. So, this is the way of application of your ordinary PVC splint. Okay. Next slide. So, there is another technique called a modified Thomas splint. Okay. Just ordinary aluminum hanger. You need to take an aluminum hanger, make it into a turn like this. Next slide. And you can fix it up with this. But this is not a rigid fixation. Always remember, this is not a rigid fixation. For pathological fractures, you can attempt this. That too below the stifle, below the elbow joint, you can use this. Next slide. So, now a ready-made thing is available. So, like a rolled splint. So, based on the length, how much you need, you can able to cut it, but it is a rubber on the front and the back. In between, you have the aluminum sheet. you have the aluminum sheet is in between. So, based on the requirement you can just cut it and you can mold it to the shape of the limb and then you can put a bandage. Okay, next slide. So, now ready made splints are available for the forelimb at various sizes. You can also use this. Next slide. And this is for the hind limb, you can use this, but these things always remember, these things are helpful only for the joint above, joint below, below the elbow joint and below the stifle joint only, not for other things. Okay, next slide. So, for the sometimes you get a lot of metacarpal fractures and metatarsal fractures. So, this a special splint is available. This is called as spoon splint. Spoon splint, just you can apply at the caudal aspect of the thing, then you can secure it with the adhesive plaster. Next slide. So, this is also spica splint. Sometimes if you want to immobilize the humerus or something, okay, take a rod like this, put a bandage over the shoulder, then take an aluminum rod like this and fix it up like this and secure it with the tape. So, this is called spica splint. Next slide. So, the common complications, you know already. Pardon, sir? Yeah. Previously. The spica splint, sir. What is that? No. Suppose you want to immobilize, definitely you need to immobilize either the femur or humerus or scapula also. What you can do, you can put the over the shoulder bandage. You can put the bandage over the shoulder bandage, but this bandage is a soft thing, no, will act as a fulcrum. To avoid that, you need to take a aluminum rod or anything. So, bend it to the shape of the thing, take it over the shoulder, bend it like that. So, that will be over the bandage, you fix it up. Now, there is no chance for the whole limb to move at all. Or you can use your fiberglass, just start from here, take it as a roll, okay, just measure from here to here, take multiple layers, that also you can put it over the thing. So, this type of splint is called spica splint. Next slide, please. So, these are the common complications where all the bony prominences are seen. You can expect a thing, and always remember the complications of external coaptation will cost you 4% more than your original surgery cost. 4% of your original surgery cost. Okay? And also remember, the price for poor bandaging is amputation. The price for your poor bandaging is amputation. Next slide, please. So, these are the common complications what you can see. Now, only safely what we are doing, nowadays we are telling the owners to put a e-collar. But anyhow, urine soiling will happen. You can see the swelling like this. Okay, the owner will not notice. After 10 days, okay, you need to go for the amputation only. Or if you want to treat it, it will take distal extremity wounds, always it takes longer time, more than months. Okay, so the more cost is going to happen. Next slide. Okay, now these are all with the external fixations. Now I am going for the internal fixations. So, internal fixation is very good because I am going to open the bone, see the bone, I am going to fix it up, good alignment is going to come and good stability is going to come. Okay, the next. So, what is the thing, disadvantage? So, I am going to open it. It can go for infection and invasive and longer exposure and expense. Expense is the main factor for us nowadays. Expense and the infection is the most common problem. Other things are not a problem. Okay, next slide. So, first thing is the intramedullary fixation. I am going from the weaker to the stronger support. First is going to be your intramedullary pin. Okay, there are two things other, K-wire and Steinman pin is there, and many persons are there who are doing surgeries, they know better. Okay, Steinman pin, it is having thread at the end also. Okay, don't think that thread will make a good purchase. Never. It doesn't do at all. It is going to loosen more only. Instead, go for the smooth pin itself or trocar pointed pins. Next slide. So, this can be this. The thing is that the disadvantage. I will tell you only the limitations of each thing. Okay, it is unsuitable for your comminuted fractures, only for the transverse fracture, it is suitable. Okay, and it doesn't counteract the rotational force. Suppose it is inside the medulla, it cannot able to counteract the rotation force. That is the biggest disadvantage with your thing. So, how much do you need to choose? You need to choose 70% of the medullary canal diameter. the size of the pin, you should choose 70% of the medullary canal at the narrowest part. So, bone is not uniform, it is becomes 70%, that is going to be your pin size. Okay. Next slide, next slide. Okay. Transverse or short oblique fracture, okay, and it can be inserted again, many people know it can be either directly you can insert from the top to the down into the medullary cavity, or open the fracture site. Through the fracture site you just go to the top, then align it properly, then from the top insert it, that is called normograde and reverse. Okay. So, this surgical technique. Next. So, humerus, retrograde and normograde. The only bone where you should not do intramedullary pinning is your radius and ulna. Only for your radius and ulna, your intramedullary pinning is contraindicated, because the radius and ulna is oval in shape, it will not hold the pin. Next slide. So, these are certain cases I want to show. So, simple transverse fracture or short oblique fracture. So, you can go it as you can use this as a primary fixation. Next slide. So, you can be for a long oblique, you should always use your orthopedic wire. You should always use with your orthopedic wire, not only your intramedullary pinning. Next slide. So, this is also a femur fracture. Next slide. So, this is for the, and always know, for a young animal it is always better to avoid this intramedullary pinning, because you are going to damage your growth plate. So, that will be a problem. So, it is contraindicated. For temporary fixation you can put it, but see to that you are not damaging your growth plate. Okay. Next slide. So, complications is mostly the pin migration, and once if you put no, you can see the seroma formation. These are the two things you can expect with the intramedullary pinning. Next slide. So, multiple stack pinning. So, when there is a comminuted fracture is there, do not go for single pin, put for 2 pins. Suppose if the diameter comes around 4 means use 2 sizes, two numbers like that, so that it will occupy the maximum medullary cavity and then it will not displace at all. So, that is the thing, stack pinning, multiple pinning or stack pinning, you can do that. Next slide. So, this is a rush pin. Rush pin you can use it for the distal condylar fractures. So, it is a flexible pin. It is a flexible pin. You need to push it from the bottom, put it into the medullary cavity. So, this is a rush pin. Next slide. Or sometimes no, we will put the pin like this for the condylar fractures, just with the small pins, no, as a cross pinning. We call it as a cross pinning and additional support with your thing. Only advantage with your intramedullary pinning is it will not bend. It will not allow for the bending. That is the only advantage with your intramedullary pinning. You can use it along with your plate, you can use it along with the external skeletal fixation techniques, all these things. Next slide. So, K-wire. K-wire is a weak wire like a pin, but it can be used for the young animals, okay, limited usage only. Next slide. So, orthopedic wire. So, always we use this wire, we cannot use this wire as a main fixation. You should use along with other fixations only. Okay. Next slide. So, the tension band wiring, the avulsion fracture I told you, avulsion fracture. In those cases you can use this technique. Next slide. Next slide. Next slide. So, this is the thing. So, wire can be used alone in the mandibular fractures. You can see in the mandibular fractures you can use the wire alone, whereas in other cases you need to use with other fixes, either with your pin or with your K wire. So, this is the tension band wiring where the muscle pull will be there. You can overcome this with your K wires. Next slide. So, the next a little bit stronger support is going to be given by your external skeletal fixation technique. External skeletal fixation means fixing the fractured bone from externally. The only advantage is that you are not going to open the, you need not open the fracture site. From externally you can able to fix it up. I told you the Gardner approach. You can go for your Gardner approach. So, you can expect a good healing. Okay. So, it contains next slide. So, it contains these are the components, mainly a pin is needed, a clamp is needed. To connect the clamps we need to have a connecting bars. The next slide. So, these are the various types you can fix up a bone. with their external skeletal fixator. Okay, if you can go through only one side, you can go to on two sides perpendicular to each other, or in the case of tibia, you can go from one side to the other side, okay, from one side to the other side, or type 3 is also another type. You can mix up the type 1 and 2. These things are not just for your information. Next slide. So, circular fixator, they are all called as linear fixators. This is going to be a circular fixator. So, now the simple technique as a field level, what you can do is, you take your K wire, okay, imagine for a goat metacarpal, just insert it through and through like this, okay, 2 pins on the top, 2 pins on the bottom, okay. You can take your ordinary the PVC hose is the electrical hose is there, cut it into 2, take your M seal. So, you can stuff that tube with M seal and you can fix it up like this. So, this is a simple technique. This is called as acrylic pin external fixator technique. This you can follow instead of using that much hardware, you can use it as a simple technique. You can follow this for your tibia and for your radius and ulna. These 2 fractures you can use this. Next slide. So, minimum 2 pins on the top you should be there. That is the important point I want to tell you. Use threaded pins rather than your smooth pins. Here I need to use threaded pins, not the smooth pins, to avoid pin loosening. Okay. Next slide. So, how much to leave a gap outside the skin is 1 finger width. You need to give you a 1 finger width distance from outside the thing, or you can use the intramedullary pin along with your fixation and you can tie both the things. Okay. You can fix it up intramedullary pin along with your external fixator, you can connect both the things, that is called as a tie-in fixation. Okay. Next slide. So, these are the safe corridors. The safe corridor is medial side for the radius and tibia, because there is no muscles or nothing is there. So, the safe corridor, whereas for the humerus and for the femur only on the lateral aspect, but for the other 2 bones only on the medial aspect. The next slide. So, the disadvantage is the simple thing, whatever the thing you want to drill a bone, please remember you drill the bone at RPM less than 150 RPM, less than 150 RPM speed alone you should drill. If you are drilling more than that, you can expect a complete loosening of any implant, whatever the thing you are going to put it, because no thermal necrosis will happen. Okay. So, that is the only thing, if you do like that, you can avoid this loosening of your pins, everything. Next slide. So, this is the fixation technique for a femur. Okay. You can put it as on one side alone, okay, with connected with 2 pins alone, we have 4 pins we have put it here. The next slide. So, this is the X-ray of that. So, there will be a lot of loss of bone is there, comminuted fracture is there, you can fix it up, and I am also putting to avoid the bending force, I am putting one intramedullary pinning into that, and then I am just connecting this external frame with that of the intramedullary pin. I am just connecting both the things, so that the fixation will be very rigid. The next slide. So, this is the transverse fracture of humerus. Next slide. So, this has been fixed with a type 1A. The next slide. So, this is the thing. So, for a femur and for the humerus, if there is a comminuted, you can take this as an option. Okay, the next slide. And for the simple radius ulnar fracture, okay, simple radius ulnar fracture where internal fixation is very difficult. So, you can do like this. Only thing is that you need to hang the limb, then only you can get the alignment. So, this is called a hanging limb. Then you can put the pins like this. Next slide. So, the fixator will be seen like this. The fixator will be seen like this. I told you distal radius and ulna is always a headache. It will take longer time to heal. So, you need to provide a rigid fixation, either plating or any external skeletal fixator you need to apply. Next slide. So, this is for the tibia. Tibia is very easy. Just you need to drill the pin, 2 pins on the top, 2 pins on the bottom, and secure with the clamp. That's all. Next slide. You can use this very well for your any joint luxation, especially the tibiotarsal luxation. You can fix 2 pins on the tibia and 1 pin on the tarsal bones, and you can fix it, you can freeze it. So, you can do the arthrodesis. So, till the fracture is going to heal. Next slide. So, the advantage of this is it overcomes your axial force, it overcomes your rotation force, it is going to overcome your bending force. So, this is going to be the best setup, best type of fixation than the other fixation. The next slide. So, the disadvantage of the intramedullary pinning is the rotational force. To overcome that rotational force, so the pin which is inside the medullary pin will be fixed with a screw. So, there is no chance for the bone to go for the rotation. So, of the techniques, this is the only technique which can overcome all the forces. All the forces I told all these forces can be overcome. This can be the best technique, but the only thing, you are going to put it in intramedullary thing, you are going to disturb your blood supply. You are going to disturb your blood supply. So, that is the only disadvantage with this technique. Next slide. So, the most rigid fixation better than this is going to be finally your plate and screws. Everyone thinks that it is very easy, just open the bone, keep the plate, drill the bone, put the screws. It is not like that. Okay, it is, you can do the technique, you can be a carpenter, best carpenter, but the thing is that what happens, the bone healing is always delayed with that technique. The bone healing is always delayed with the technique. Now, that is why don't manipulate too much. Suppose if I want to fix the bone, fix the plate, I need to damage the soft tissues as much as possible. So, what I am doing? I am reducing the blood supply naturally to the bone. They say that internal fixation is the best. Okay. So, they say they are the only fools. One orthopedician, human orthopedician says they are the only fools, because we are disturbing the maximum soft tissues, then only we could be able to do the best fixation. So, do not go for the disturbance, always go for the Gardner approach. Okay. So, the plate, the next slide please. So, these are the various types of plates are available, daily market. So, many varieties of plates are available with each one advantage. Okay. So, it also varies with that of the shapes, depending upon the anatomical requirement of your anatomical requirement of the bone. Okay. So, you can see the J plate, this is very like a hockey stick. Okay. So, this can be applied for your condylar fractures, okay, and you can use that for that acetabulum, that one rounded curved plate is there, over the acetabulum you can use. So, nowadays lot of variety of plates are available. It is easy to fix it up, but the only thing is it's very costly, and you need to do it meticulously without any infection. That is the thing. Next slide. So, to fix up the plate, we need to have a screws. These are the common 3 screws are available. A little bit modified version is coming. It is called as a locking plate. You can see on the head of the screw, there will be a thread will be there. So, what is going to happen? That thread is going to fix up with the plate itself. Okay, so that if the plate has to loosen, along with the screw, it has to come out. Whereas, in the first thing, only screw can become loosened. If one screw loosens, whole plate will come away. So, this is the advantage with that. I will show you in the next slides. Okay. So, the screw, we can use this as a primary fixation, any simple condylar fracture. I told Y fracture or T fracture. In those cases, to fix it up, you can use this. Next slide. So, the plate, where to apply the plate? The plate has to be applied on the tension side of the bone. That is the most important thing. Tension side means, okay. So, suppose if you are putting the plate, what will happen on the, I told what is the force acting on it? A convex and a concave is there. So, convex and concave. So, tension will be on the convex side. Okay. So, if you put it on the concave side, what will happen? Your plate will bend. Your plate will bend away. So, it will break away. So, it is always better to put your plate on the tension side rather than the other side. Okay. So for the femur and the humerus, put it on the lateral aspect, and for the radius and the ulna, you need to put it on the medial aspect. Okay. The next slide. So this can be applied as a compression. Just suppose if any comminuted fracture are there, just what you need to do, two things. If you want to put a compression, put the screws near to the fracture site. Start from near to the fracture site. If you want to fix it up and fix it up on the comminuted fracture or something, start from the end. This is the two tricks you need to follow. Next slide. Next. So a modified version is, this is becoming a very popular dynamic compression plate. So what happens is, if I drill a hole, if I screw it and this will make the bone and the plate to move towards the fracture site. So what happens is, okay, I will be screwing it slowly after tightening, the plate will move to here. Okay, so that both the bone ends are brought together. So compression is achieved. So that is the plate design is available like that. Okay, that is called a dynamic compression plate. So the problem is with the dynamic compression plate is the bottom surface will be very flat. It will interfere with the healing. It will interfere with the periosteal healing. So to avoid that, the next design has come. So these are the guides are available, ready-made guides are available. So what type, what is the size of the plate I should do? So what is the screw size I should decide? Everything knows the guide is available. The next slide. So this is also technical chart is available. Next slide. Okay, the steps, what are the steps you need to follow in a plating is that you should not miss is bending the plate to the shape of the bone. If you fix it up as such, your plate will become failure. You need to bend the plate to the shape of the bone, then only you need to fix it up. If you don't fix it, you bend it, so it will break away. And first thing is that you need to drill, then measure, then tap, and then you need to screw. This is the basic steps. Next slide. So to overcome that, I told the flat surface of the DCP, nowadays the undercut is available. So that will be called as a limited contact dynamic compression plate. So only a limited contact will be there. So the periosteal healing will not be that much. Next slide. So this is a new type of plates are there. Okay, the locking compression plate. In the plate itself, the thread will be there on the over the thing, so that the screw will fix up with the plate and the plate will not get loosened. Okay, so this is called as a locking compression plate. So it is, and a little bit modification is a clamp rod. This is only a recent thing. You can fix it up. So you are putting a plate onto the side. So that is going to, instead of plate, you are going to fix up with a rod. This simple rod is there. The rod will be connected to a clamp and screw the bone. So this is called as a clamp rod technique. Next slide. So this is for the right femur, we just been applied. See all these aims, what does it aim? Why we are doing, why this such a modification we are doing? Ultimately, we need to preserve the blood supply to the bone, promote good healing and early healing. That is the only trick we need to follow, that's all. Only that is the main aim is to do like that only. Next slide. So along with that, you can also put an intramedullary pin. You can also put an intramedullary pin so that the bending will not happen. Next slide. So only locking screws are available. Only locking plates are available. This is called as a recon plates. So this you can use it for your any mandible fractures or for the cats. You can use this, and you cannot expect a good healing. So you will be thinking that I have put a best plate, but the fracture will not heal at all. The problem is only because of this. Some amount of micro motion should be there in the fracture site. Next slide. Sometimes you need to apply double plating also. You need to apply double plating, especially if a Saint Bernard comes, one plate alone will not be enough. To counteract all the forces, you need to apply double plating also. Next slide. Sometimes nowadays we are getting mostly bilateral fractures. That is the problem. So bilateral distal distal femur fractures are there. So, you need to apply, you need to give a very strong fixation. So, I just know we applied the J plate and also with the intramedullary pinning. Next slide. So, pelvic fractures is very easy, even if you do not do fixation also it will heal faster. Next slide. So, radius and ulna. So, here now bilateral radius ulna fracture. So, in one thing we need to go for the locking compression plate and another we need to apply a T plate. So, distal radius ulna fractures is always a headache. Nowadays we are getting T plates are available, you can just go for that. Next slide. So, this is another plate recent now it is becoming popular, it is called a string of pearls plate. Next slide. So, this can be applied, you can see no, it will not be like a plate, it will be like a string of a thing. So, this can be applied for the femur. Next slide. So, this is for the tibia fracture. So, the Gardner approach, with this now I will just finish this. The Gardner approach is, now the recent technique is, do not disturb the fracture site at all, do not open the fracture site. Okay. Just below the skin I will push my plate and fix the plate. So, this is called as minimally invasive plate osteosynthesis. You are not supposed to open the fracture at all. Okay. You need to preserve that hematoma. So, I will be just applying this minimally invasive plate osteosynthesis, and one more recent technique is putting the plate on the top of the skin. So, normally the plates are put inside the skin. Now, as an external skeletal fixator, you can apply this. You can keep the plate over the skin and you can fix it up. So, I am not disturbing the fracture site. So, this gives us a very faster healing and more stronger healing also. So, this is the recent things we are following now. Next slide. So, when there is any infection is there, immediately you need to remove it. And mostly nowadays what we are seeing, after 1 year or 2 years, the animal is getting irritation, it is going on licking and the plate is getting exposed. So, lick granuloma happens, definitely you need to open the plate, you need to remove the plate. Okay. Next slide. So, when you will call as a totally healed, so total healing, the animal has become totally healed means when both the cortices has become, when 3 of the cortices, suppose if you take 2 opposite views, one is the lateral view, one is the craniocaudal view. If you see in these 2 views, 3 cortex has been united, then we can tell it as complete healing. Before that, if you remove the implants, it will not heal at all. Okay. What is the normal bone healing days? It is, suppose the owner is asking how much time it will take. 8 to 12 weeks, that is the normal time. If anything goes beyond that, it will be called as delayed union. It will be called as delayed union. Okay. The next slide. So, this is the time phase normally. First it goes as the inflammatory phase, repair phase and remodeling phase. The remodeling phase is the major time what you can expect within that 8 to 12 weeks. The remodeling phase is the time. Okay. So, once the bone remodels, then it is strong enough to bear the weight. Next slide. So, next slide. So, only one point what I want to stress is the bone is going to get the nutrition through the nutrient artery. From the nutrient artery, it goes into the intramedullary canal. From the intramedullary canal, it goes to the metaphysis. It goes to the metaphysis. From the metaphysis, it comes to the periosteum. Imagine if a fracture is, imagine a bone is getting fractured, what happens? The internal endosteal supply is cut. So, naturally it has to get the blood supply from the surrounding soft tissues. Again, by putting the pin, if you are damaging the endosteal supply, again by putting the screws, if you are putting the endosteal supply, the bone healing is delayed. This is the concept which is being stressed now. Do not open the fracture, immobilize the fracture with rigid fixation, go for that Gardner approach. Okay. So, with this I conclude my lecture.
Thank you, Dr. Pushkin. And just 2 minutes, I know that you are all hungry. Now we have a lucky draw. And before that, we have to felicitate our beloved Dean. I request our Dean to come to the stage. Dr. Pandian will garland him, and Dr. Kaniyappan will felicitate him with the shawl. And Dr. Nagarajan will give the memento. And before winding off, now we have to thank one good person who has really worked hard for it and no one knows about him. In the background itself, he has worked. He is nothing other than our treasurer, Dr. Suresh. I think probably he wouldn't have attended the clinic in the last 10 days. He has done so much of work in getting the sponsors and getting the logistics, all our certificates, everything getting done. He has done a wonderful work. We wanted to really thank him and felicitate him, but he is refusing. He is refusing. So he is the main person behind the entire show. I request the people here, give him a good applause. He doesn't want to accept that. That's the reason he is not coming here. He is the main, our treasurer is the main man behind it. Now, apart from Dr. Suresh, Dr. Kaniyappan, Dr. Ramachandran, Dr. Senapati, Dr. Siranjeevi, Dr. Pandian, Dr. Jagadisan, and Dr. Swaminathan, they have also done wonderful works in the past 2 days in the conduct of this work. So our sincere appreciations and thanks to them. Apart from that, we thank, before that, we will finish off the lucky dip. I requested Dr. JP to come here. The lucky dip, the 5 lucky dips, we are going to take it, and they will be given free entry in the next next CE program. The first one is Dr. D. Vivekanandan, Coimbatore. Second one is Dr. Dinesh Krishnagiri. Third one is Dr. Sivanandam Karur. I think he is getting for the second time. Dr. K. Suresh Kumar, Gobi Chettipalayam. The fifth is Dr. Jennifer Vellur. And we are winding the shows with due thanks and appreciations to our Sapac team, the SR Jungle Resort, mainly Mr. Rafiq, Mr. Manjunath and Sivanandam, Mr. Prabhu, Mr. Bhuvan, who are all coordinated with us. And then the main appreciations to our sponsors, Right for Pass, Sky Easy, Mutt and RV Drugs. Again, I thank one and all our participants. Thank you. With this, we wind off the show. Thank you.